at KMC Jyoti, and we do an exclusive hip and knee practice. So my senior orthopedic surgeons are also here, and they will very well endorse that it is now orthopedics as such is such an advanced field in terms of knowledge that it becomes very difficult to practice just the entire gamut of orthopedic surgery. The knowledge is advancing by leaps and bounds. So we have more and more of us just coning down on specialty aspects of orthopedics. So I myself just do hip and knee. People often introduce me as a joint replacement surgeon, but I am passionately not a joint replacement surgeon. I would rather call myself a hip and knee surgeon because I'm as passionate about preventing joint replacement, and there are various ways by which we can either do effective conservative treatments like exercises or various pre-joint replacement things like cartilage regeneration and reconstructing ligaments which prevent a person from progressing to full-fledged arthritis. So the purpose of today's program really was to acknowledge and even though this is organized by us as orthopedic surgeons, it is not going to be didactic orthopedic talks at all. It is where we all appreciate as doctors that we need to manage a patient in the best interests. So starting from the first to a couple of orthopedic things towards the middle and the end, which are relevant to everybody's day-to-day practice. In the sense, we all get asked for advice from family members. Here is my MRI, it's showing a meniscal tear. What do I do? So, and what then happens is do you then refer them to an orthopedic surgeon or somebody who advertises their joint replacement or somebody who advertises their arthroscopy. So there shouldn't be a bias towards technicality in specialty. I would rather say we should be, there should be more of a culture of having a region-specific specialist. So somebody can be a spine surgeon or a knee surgeon. So one can be as justified in preventing surgery as in doing it, and having the different range of surgeries under one roof, rather than just coning down on one type of operative treatment, which then tends to bias a person. The way we have designed it is we've got various people from specialties, and we will be talking, or rather I would like to demonstrate the journey of how we manage different conditions in liaison with different specialists depending on the condition. So it will be, rather than introducing the you can say the specific qualifications of the respective speakers, I would like to put it all in perspective as to how we have engaged with those particular speakers in managing the patients, which helps us take decisions on effective management of our patients. So what we are going to do is I will be introducing the speaker. The speaker will be, relaying his talk in about 10 to 12 minutes, following which we've got a moderator for every session who will be directing questions. Please feel free to interrupt and ask and make it as interactive as possible. So we go away with, maybe all of us picking up a few things, but more than that, working together for the patient's combined benefit, so to say. So without wasting time, we shall start with the first session. Following the first 3 lectures, we'll have an inauguration and lamp lighting, and proceed on for the rest of the day. We have some panel discussions as well. To start with, we've got a session on emergency medicine. Dr. Karthik, our speaker, is a budding consultant in our emergency department. He's a qualified emergency physician, and we want him to talk on hip and knee emergencies. So conditions apart from fractures. Of course, fractures are some emergencies, but things which are not that obvious, which you might be seeing in your day-to-day practices, things like occult fractures and ligament injuries and things like that, which he will be covering. I would be very grateful to invite chairpersons to occupy their chairs. Dr. Mubashir sir is here. Sir is a senior consultant practicing at BC Road and also in Mangalore. Sir, I would be grateful if you can take your chair. And we also have Dr. Bagali. Dr. Bagali is right now making Adani Power more illustrious, but he is otherwise a specialist in and has got accolades with occupational health, if I'm not mistaken. Welcome you, sir. Dr. K.R. Kamath, I'm lucky to have Dr. K.R. Kamath. He is a senior orthopedic surgeon, the president of Canara Orthopedic Society. He's had this under the aegis of Canara Orthopedic Society, and he's also like an elder brother to me. And to moderate the session, we have our own intensivist, Dr. Vasant Kamath. Thank you, Vasant. So Vasant actually sees the emergencies from the other end. So he sees them at the reception, and Vasant is involved often, or hopefully not that often, when after operation, sometimes we have to manage patients in critical situations. Vasant is our senior intensivist. Thank you, Vasant. So as regards emergencies, we often have patients coming with knee injuries, people who are not able to straighten their legs. So that, for example, is a locked knee. It is not a fracture. People come in limping to the emergency, and there are times when people, out of their own misunderstandings, or sometimes are stuck up in braces, when it leads to stiff knees and loss in sports. So these are the kind of aspects which we thought we will talk on in this lecture. Of course, my personal experience with the emergency department, it's a very common emergency in orthopedics, the hip fracture, and I would like to share what we have had with in terms of outcomes with the emergency department. We now have enhanced recovery for hip fractures. It is well understood across the world that a hip fracture will have a much better outcome if operated within 24 to 36 hours, whatever the risk. So what we do in our emergency is we do them fast track into the operation theater. They are taken to theater within literally, at least within 12 hours, if possible, by expediting all the medical consultations and whatever risk in terms of blood thinners, etc. So we've got some audits. We've got our average length of stay from what we did before. We published this. This is very much known in the National Hip Registry from the UK, but we've got our own data from here now. So the average age before we implemented used to be about 14 days of admission. We've reduced it to about 5 odd days. The time from admission to surgery average has come down with fast tracking. We've got time from surgery to discharge, and we are talking discharge of patients. These are average 70 to 80-year-old. We've got it reduced from 10 days to barely 4 days. We've got admission to medical reference literally happens within hours with a good emergency setup and good emergency physicians being involved. And of course, the mortality, more than anything else, is known to be very high. So in all the years, the 1-year mortality has reduced by over a half since when we've implemented these protocols. Dr. Karthik, I would love to invite you to take the stage from here. Thank you. Good morning, everyone. Thank you, sir, for the warm welcome. So, I'll be dealing with the emergencies related to the hip and knee. And we know the most anticipated
divided into mainly three areas: the anterior, lateral, and the posterior pain. So the anterior hip pain, the most common, the intra-articular pain of the hip usually present as the anterior hip pain. So the it could be a referred pain from the intra-abdominal or intra-pelvic region that will require examination of the respective areas of the abdomen and the pelvic region. Or it could be extraarticular when there is a injury to the flexor tendons, a strain or injury because of the overuse. There will be tenderness in the anterior superior iliac spine region or in the anti-inferior iliac spine region or pubic symphysis. So pain can be elicited in these areas if it is because of the extra-articular reason. So the intra-articular reason because of which anterior hip pain patient present to the department could be of a various different reasons. So first one is femoroacetabular impingement. So young athlete, gradual onset of a pain, and when there is a pain with the range of movement and history of development dysplasia. In these patients, when there is a when you evaluate the patient, when the Fadir and Faber test are positive, so you can suspect the femoroacetabular impingement syndrome. So most common causes are the pincer deformity. It's an overgrown area of the acetabular region, or cam deformity in the neck of the femur. So another entity is a labral tear, similar to femoroacetabular impingement. When the onset is acute, with a similar presentation, like a young athlete patient, the pain with the range of movement. So you can suspect a labral tear also. So this also produces positive Fadir and Faber test result. So investigation usually MRI and surgical treatment. This is the Fadir test, flexion, adduction, and internal rotation, and flexion, abduction, external rotation. So another entity for the anterior hip pain is a femoral neck stress fracture. So overuse, overtraining, and energy imbalance can produce the stress fracture of the femoral neck. So the patient will be having antalgic gait, pain with the range of movement, and while ambulating. So investigation usually MRI in the early stages and surgical treatment. So avascular necrosis, middle-aged men or older age with a history of smoking, alcohol use, medical syndromes, and if patient has hemoglobinopathies, corticosteroid use, so they may produce avascular necrosis as an anterior hip pain. So physical examination similar, the patient will be having antalgic gait and pain with the range of movement and limited ROM in the hip region. So investigation, earlier diagnosis with the MRI or the CT scan, and treatment in the later part is usually the surgical. And then next one is the osteoarthritis can also present as the anterior hip pain. So older age, gradual onset, and the pain aggravates as the day progresses. So investigation is usually AP radiograph, which shows a joint reduction and presence of osteophyte formation that can give us a hint towards the osteoarthritis of the hip joint. And the treatment is intra-articular corticosteroid injection can ease the pain in case of this condition. So next one is the hip fracture. If older age, osteoporosis, and history of trauma can present as a hip fracture. So accordingly, the treatment varies, usually the surgical correction. So this is about the anterior hip pain. So next one is the lateral. What could be the cause for lateral hip pain? So the greater trochanteric pain syndrome. So it usually a pain in the lateral aspect of the hip joint. So when there is a bursitis or a tendinopathy of the gluteus medius muscle, so this can present as a lateral pain in the hip region. So usually the history would be like there won't be any history of any pain, the injury, and middle-aged men and overweight, pain while sleeping on the affected side of the hip can produce these kind of syndrome. So on examination, the Trendelenburg test will be positive, or the positive restricted external derotation test. So the Trendelenburg test is like when patient is standing with the unaffected leg raising above the level of the the ground. If the level of the hip sag below the normal level, then it is a positive for Trendelenburg test. And resisted action derotation test is like when patients are sleeping supine position, 90-degree hip and knee flexion, and the examiner will do the external rotation of the affected limb, and when the patient is resisting for the maneuver. If there is reproduction of the pain in the lateral aspect, then it is positive for the disease. So investigation could be MRI or the soft tissue ultrasonography. So treatment would be usually anti-inflammatory and physiotherapy. If there is a partial or complete tear of the gluteus medius tendon, so then it requires a surgical correction, which has a good result if it is done early. And next one is the posterior pain. So intra-abdominal, intrapelvic can also present as a posterior pain. The deep gluteal syndrome. So the syndrome is thought to be as a result of the piriformis muscle entrapping the sciatic nerve. So this can produce a pain in the deep gluteal region and also the sciatic shooting pain. So history will be the pain in the deep buttock region and no history of any injuries, and it worsens when patient is sitting in the car or sitting in a chair. This kind of a pain aggravates. So So, like I was explaining, the deep gluteal syndrome could be because of the entrapment of the nerve in the piriformis muscle. So, seated piriformis test, when the patient is sitting on the examination table, internal rotation of the foot will produce a pain in the deep gluteal region. So, issue of femoral engagement can also present in the deep gluteal region pain. So, long side walk test will be positive in this condition, and yeah. So the posterior, the hip pain can also because of the lumbar spine and because of a lumbar spine muscle, which the pain will be in the low back region above the level of L5. Sacroiliac joint pain also can also present in a similar fashion. Different kind of a pain related to the hip, anterior, lateral, and the posterior. Coming to the knee, the most important part I am going to discuss about the knee. So, the most obvious injuries which may miss in the X-ray, or X-ray may have a subtle signs or features which may make us miss the condition. So, the occult injuries of the knee are mainly the quadriceps or patellar tendon rupture, the lateral tibial plateau fracture, the dislocation of a knee with spontaneous reduction before coming to the emergency, lost knee and ligament injuries with a referred pain and compartment syndrome and septic arthritis. So the quads and patellar tendon rupture, when do you suspect this kind of injury? So when the triad of acute knee pain in the anterior aspect and inability to raise the leg, and when there is a gap in the suprapatellar or infrapatellar region, you can suspect the quads or the patellar tendon rupture. So X-ray, usually the patella will be one joint above the one finger breadth above the joint line. So when there is the patella is below, then it is called a patella baja, lower than the usual, or patella may be higher above, which is called as a patella alta. So investigation usually USG, and the treatment is a knee immobilizer and surgical if there is a complete tear of the tendon. So lateral tibial plateau fracture. When there is a trauma to the lateral aspect of the knee, valgus force, there could be a possibility of injury to the medial collateral ligament along with the lateral tibial plateau injury. So X-ray, usually the lateral subchondral line is a higher the level compared to the medial subchondral line. So if it is below the level, so then we can suspect lateral tibial fracture. So like shown here, it is lower than the medial. So CT scan, if there is a more than 2 mm or split displaced fracture, it requires urgent surgical correction. Next one is the dislocation of the knee with a spontaneous reduction. 20 to 50% of the knee dislocation will the patient will come to the emergency with a spontaneous reduction. So significant minority percent of the patient will have neurovascular deficit, which may produce ischemic complications and also may require limb amputation as well if delayed. So suspect when there is a 3 or 4 ligaments disruption or ligament laxity in multiple directions. So buckling a knee with the foot drop, and upon lifting the heel, so there is a hyperextension of the knee, and high energy mechanism is there. You can suspect the dislocated knee with a spontaneous reduction. So next one is locked knee. So locked knee is inability to fully extend the knee. So in case of a suspected meniscal or ACL tear, there is a possibility of a locked knee. If it is a delay, it can produce a decrease the range of movement in the knee. So ligamentous tear, and in this the most common is the ACL. So the mechanism is usually the sudden deceleration injury with the body moving away from the side of the injury, and 70% of the patient will complain of popping sound or a buckling and giving away sensation during the force. Right. So evaluation is the usual test. What we do is the Lachman test, where the examiner will hold the proximal part of the foot in the inner aspect and with one hand, and the outer aspect of the lower aspect of the thigh, and the knee will be pulled in the front, and if there is a laxity, it is because of the ACL injury. So X-ray in the pediatric, it may show a tibial spine fracture, as shown here, the fracture line over here, tibial spine fracture. In adults, there could be a second fracture over here. So rise here in ACL injury, the R cannot stand for rest. It is because it stands for a restricted movement. So early mobilization, restricted range of movement activity is necessary for the ACL injury, and knee immobilization is usually avoided. So next one is the PCL injury, posterior drawer test, gravity sag, and flat activation tests are the most commonly done tests. In which posterior drawer test is like a patient knees reflects to 90 degrees, and the limb stabilizes after the examiner stands on the dorsal aspect of the foot, and when the holding the proximal aspect of the limb and the knee is pushed behind. So when there is a laxity of the knee, is because of the PCL injury. So it should be a meniscal tear as well. So meniscal tear can be diagnosed with joint line tenderness, McMurray test, and appreciation and that's walk test. So most commonly the McMurray test, what we do, knee left to 90 degrees, place one hand on the lateral aspect of the joint line, and the foot is held with the other hand, and with various force to the knee, with the other hand from the heel, it is external rotated and extended. If there is a popping sound or if there is a reproduction of the pain, it is a positive for meniscal injury. And the varus and valgus test, it is done to diagnose if any injury to the medial collateral or the lateral collateral ligament. Thank you.
Thank you, Dr. Karthik, for a quick presentation of all the hip and knee emergencies. Any questions, chairpersons, any questions to the speaker? Any inputs you want to add?
So, everything, and we all know that immobilizing is the first line of treatment in case of any kind of fracture. I just wanted some insight on the hip fracture. What would you advise for like identification and the first aid? What would you advise in case of hip fracture? What is the best thing to do after immobilizing?
Whenever we get the patient with the suspected hip fracture, so first thing what we do is like a pain management along with the immobilization. And then we go ahead with the radiography and to find out what specific type of injury is there. And if there is any involvement of the shaft of the femur or something, then we have to immobilize with the form of pain before mobilizing patient with other departments. So if there is the rate of suggestive of injury to the hip region, so the skin traction and pain management is the best method for it follow.
Thank you. Thanks so much.
I think we can take a quick question from the audience. Anyone? Okay, then I think we'll wrap up the first session.
Thank you very much, Dr. Vasant. I would like to ask Dr. Vasant to give our chairperson's mementos. Dr. Mubashir. Karthik, that was excellent. Thank you. And you can ask him questions over lunch and the breaks as well. He's going to be here.
Thank you.
And Dr. Prasad, sir. Prabhudev, sir, sorry. Can I call upon Dr. J.N. Bhatt to provide a memento to Dr. K.R. Kamath, sir, and Dr. Vasant? I must say, K.R. Kamath, though he looks pleasant, you also have to be scared of him because he's the KMC observer for today's program as well. So, if people go away from the sessions, he'll make a note. Dr. J.N. Bhatt, sir, if you can give a memento to our moderator, Dr. Vasant Kamath, as well, please.
In a break like this, you should always have the same background. Mine.
Oh, sorry. We forgot to give a memento to the speaker. I'm so sorry. So, can we ask Dr. Karthik to come? Thank you so much. I'm so sorry. I forgot that. Please. Yeah. Sir. We should have done that first. So sorry. Yeah. Without wasting time, we'll move ahead to the next session. The next session is Dr. Prashant, our hematologist, and until recently the only real hematologist in and around this region. So Prashant and I have managed a few cases together, and he is so important when it comes to managing those specific conditions. Initially, I'll invite the chairpersons, Dr. Nutan Kamath, my senior colleague and friend. She is our senior consultant pediatrician. She has been associate dean in research at KMC, and she continues to be a guide for me personally as well. Thank you, madam. Dr. Sri Rama from Kasargod has actually cancelled his schedule. Sir runs a very busy practice in Kasargod. He has his own clinic, and a few of us have been having outreach clinics at Sir's hospital as well. Thank you very much for coming. He has been kind enough to, he was actually traveling to Bangalore, but he is got the cab waiting for him after and attending the sessions. Then he's broken his program to come and attend here. Talking about Dr. Prashant, moderator, sorry. Dr. Harsha Prasad, my friend, sorry if I'm being too informal, I hope you'll forgive me. Dr. Harsha Prasad is the apt moderator for a session because he is the only pediatric hematologist in and around the region, and as you might have heard, has not only treated various pediatric blood related things but runs a special unit along with a lot of integrated care in terms of getting government facilities, integrating that with chemotherapy, integrating with surgical specialties where we manage things together, and also working on various things for rehabilitation and for the families of the children. He set up a center at Attawar. He works between Attawar and Jyoti, so that way he can cater to people from all different financial backgrounds as well. So thank you, Dr. Harsha, for being here. As regards Dr. Prashant, he is of course our consultant hematologist. In terms of managing cases, I will just show an example here. Now this relates back to about 7 years ago. This is the youngest joint replacement, as in knee replacement, I have ever done. Now looking at that x-ray, it is pretty, what happened to the projector? Just as I was pointing at the x-ray. Anyway, it is pretty clear from that x-ray. I wonder whether you remember, Prashant. I'm sure you do, because so it is obvious. You can see the bones separately on one side, and on the other side the bones were quite badly destroyed. And to see that at an age of 29, with a 29-year-old limping literally that badly, was quite a sight. There's nothing else you can offer that patient but an intervention like a joint replacement. But when you see that kind of bad destruction in somebody that young, one should not, the message is, we should not rush into surgical management of such a patient, because when you see that bad bone destruction with that many, what we call cysts and so much of bone damage in a young person, that means there is some underlying condition. I would like to show you a scary operative picture in this patient. I don't know why that didn't work. Can you change the slide from there? So this is, it's getting stuck for some reason, I think. So it turned out to be hemophilia. So hemophilia is a known genetic condition, as you know, where you get bleeding into the joints preferably. And I had a picture of what we call chocolate synovium, because that is where blood collects in all the joints and the synovial tissue becomes thick and dark. Obviously, this kind of case has to be managed with the help of a hematologist. It would have been a disaster if this would have been done in a case which does not have tertiary care, because we have to do it in conjunction with giving blood factors and very integrated medical management, for which Prashant is the expert. So I'll pass it over to Dr. Prashant. Thank you.
Thank you, Yogesh. I think we had a wonderful association. Not just, this is one case where, it was primarily my patient. Then he had his own set of patients where there are a lot of hematological complications that arose. Not because he did not manage it well. It is because it was incidental. It was undetected earlier. I'll go through the blood related complications of orthopedic surgery. I'll go in a very basic manner, quickly going to. Now, the hematological complications are fairly common because we are chopping off a raw area there.
So blood is going to ooze out. There are going to be blood, involvement of the blood. It can be mild to severe, because of blood loss, immobilization, or because of trauma. And most important is early recognition, prompt treatment, and preventive measures help in reducing these complications. Now, what are all the commonly seen complications? Either it can be prothrombotic complications, excessive bleeding, anemia, DIC, fat embolism, blood transfusion related complications, and hemarthrosis. If you see the incidence, if you look at the overall orthopedic surgery, these are the three most important surgeries: total joint arthroplasty, hip fracture surgery, and spinal surgery, which have most of the complications. So minor surgeries like Colles fracture won't impact the patient much. These are the ones, and as you can see, as the severity of the surgery increases, the complication incidence also goes on increasing. DIC, it's difficult to get a percentage of what exactly is the incidence, but mostly seen in polytrauma patients. Blood transfusions depend on how much blood products we require during the surgery period. Hemarthrosis is commoner in, just like what Dr. Yogesh showed, like hemophilia, or somebody who is on oral anticoagulant drugs or on antiplatelet drugs. So coming to DVT, we know that, virtuous triad, three risk factors for development of DVT. Risk factors being age more than 40 years, obesity, history of earlier DVT, cancer, inherited clotting disorders, prolonged surgery, more than 2 hours of surgery, general anesthesia, and immobility more than 3 days always pose risk for development of DVT. Most commonly happens either in femoral or popliteal veins or iliac or femoral veins. Generally, patient develops swelling of the particular affected limb with the pain and warmth of that limb. The swelling may be unilateral or bilateral depending on whether we are having unilateral or bilateral DVT. There will be edema. Patient can have DVT associated fever, sudden spike in the temperature. Now, early mobilization, mechanical prophylaxis, pharmacological prophylaxis are all advocated to prevent DVT, especially in those risk factor. Whenever we have patient with the risk factor, we have to give as far as possible a chemoprophylaxis with either low molecular weight heparin or at least an aspirin. So, this is not me. So, the diagnosis basically, D-dimer can be done. D-dimer is useful in patients where we cannot get an Doppler immediately. Otherwise, D-dimer is not easy. This one, you should remember that we have done an orthopedic surgery. There has been a tissue trauma, iatrogenic trauma that has happened, because of which also D-dimer can be mildly elevated. So severely elevated D-dimer, just a borderline high D-dimer doesn't denote a DVT there. You should always remember a severely elevated D-dimer. We do ultrasound. Thankfully in India, it's very, very easy to get ultrasound. Even now, small towns also have ultrasound facilities available. Then if required, we can do a venography, contrast imaging. If the patient has DVT, we treat with the anticoagulants, initially with the low molecular weight heparin, then we switch to, nowadays we switch directly to Novax. We don't give warfarin nowadays, unless the patient also has a cardiac issue, like, valve problem. Otherwise, we always go for newer anticoagulants like apixaban, dabigatran or rivaroxaban. Intervena cava filter is indicated only if we cannot put an IVC filter. We cannot give anticoagulation, then we have to put an IVC filter. If we are able to give a full therapeutic dose of anticoagulation, then there is no role for IVC filter. Pulmonary embolism, there is nothing much different other than DVT as far as the risk factors are concerned. Symptoms wise, they can have breathlessness, sudden onset of breathing difficulty, hypotension, they can have tachypnea, tachycardia, hypoxia can come, fever again can come. Diagnosis wise, we have to do a CT pulmonary angiogram to prove the pulmonary embolism. Ventilation perfusion scan is theoretical in nature. Nowadays we don't do it because mostly we have CT scan facilities in most of the centers. Pulmonary angiography is invasive. Again, we generally don't do it. Treatment wise, we have to anticoagulate. If the patient is hemodynamically compromised, then we have to give thrombolytic therapy, either systemic or catheter directed thrombolytic therapy. But if the patient is hemodynamically stable, we just start with the low molecular weight heparin and then switch to a NOAC and continue it for anywhere between 3 to 6 months for a minimum period of time. Prevention wise, as I earlier told, early mobilization of the patient, mechanical prophylaxis should be used in most of the patient. Pharmacological prophylaxis wherever feasible in a high risk patient has to be used. Bleeding again, depends on the patient characteristic. Bleeding can be intraoperative bleeding or postoperative bleeding, or there can be delayed bleeding, and most often the bleeding is due to either an inherent coagulopathy in the patient, either like hemophilia, or sometimes patient will have platelet dysfunctions because of allergic manifestations and other things. We had 2 cases where Yogesh encountered hemarthrosis, and we were wondering why it happened, and it ultimately turned out to be a platelet dysfunction secondary to an allergic phenomenon in the body. And simple vitamin C and anti-allergic medications, patient became better. If the patient was on anticoagulant therapy, sometimes trauma cases, patient has already swallowed his NOAC or aspirin and developed a trauma, there can be severe bleeding. Risk factors: age more than 65, obesity, history of bleeding disorders, preoperative anemia. It is very important. If you are going for an elective surgery, always correct the anemia and then do the surgery. Preoperative anemia will pose an increased risk of bleeding intraoperatively or postoperatively. Longer surgical time, complexity of the surgery, and drugs. Symptoms wise, there will be clear-cut oozing or the soakage of the dressing. If you have put a drain, there will be increased drainage there and obvious drop in the hemoglobin. Management wise, pakka hemostasis we have to achieve. We have to give blood products, and depending on if the patient had he was on antiplatelets and we had to do an emergency surgery, the best thing is to give platelets, new platelets. The bleeding will come down. If the patient was on anticoagulants, FFP, cryoprecipitate, or sometimes even prothrombin complex concentrates also may have to be used. Tranexamic acid is a very useful drug. You give 1 gram of tranexamic acid 1 hour before the surgery. It reduces the bleeding by around 30 to 40% of the time. Then if nothing works, then we have to call interventional radiologist, see whether there is a bleeder vessel somewhere and try to embolize that vessel. Prevention, as I told, correction of anemia, coagulopathy and other underlying conditions is of paramount importance. Anemia, again, it can be a pre-existing anemia with the orthopedic surgery or post-surgery. Because of blood loss, patient may develop anemia. The anemia most often because of acute blood loss, but sometimes patients can have something like, Dr. Yogesh or, you have to operate on rheumatoid arthritis patients, SLE patients who have bad hips or bad knees. You have to replace them. They will have anemia of chronic disease. So we have to tackle them. So this is simple. I will not go in full details. But treatment options are blood transfusions. If the surgery is urgently required, better you transfuse the patient and then take up for surgery. If it is surgery is going to be elective, give IV iron, IV parenteral vitamins and erythropoietin supplements to boost the hemoglobin production. DIC is another dreaded complication, especially seen in polytrauma cases, where what happens is that there is a widespread clotting in the microcirculation of the blood body, because of which there will be consumption of the clotting factors, depletion of platelets, fibrinogen and other factors, and that leads to bleeding and organ dysfunction. At a microvascular level, there will be organ ischemia. At macrovascular level, there will be bleeding. So it is kind of a paradox that we lead. So trauma cases, infection, if the patient has coexisting infection, a severe inflammatory response, if there is a prolonged tissue ischemia, there can be local DIC. Sometimes, you have put a limb tourniquet which went on for longer periods of time. You will have a local DIC setting in the lower limb only. The rest of the body is fine. And there is a bleeding, and also there is evidence of, little gangrene going on in the toes. This is called local DIC. If the patient has a cancer, you have operated on a malignant patient, the DIC risk is higher. And if the patient required unnecessary transfusions, or massive transfusions, patient can develop DIC. So risk factors: complex or prolonged surgery, high energy trauma, pre-existing coagulopathy, cancer, sepsis, or organ dysfunction. Symptoms would be, as I told, there will be bleeding, thrombocytopenia, PTA, PTT will get prolonged, fibrinogen will go down, and because of microvascular ischemia, there will be renal or hepatic dysfunction. So treatment-wise, supportive care, treatment of underlying condition aggressively like sepsis. Then if there is a major organ ischemia that is going on, we have to start these patients on heparin. If the patient has thrombocytopenia, transfuse platelets and then give heparin for these patients. Fibrinolytic therapy, if there is a major clot load in any organs. And surgical intervention like re-exploration may be required in some of the patients. Prevention-wise, early recognition is of paramount importance in DIC, because the earlier we diagnose, higher the risk chance that patient will recover from it. Then fat embolism, it is one of the peculiar complications associated with the major bone surgeries of the body. Rare but potentially life-threatening complication. It mainly happens in long bone fractures, joint replacement surgeries, and spinal surgeries. It happens because of mechanical disruption. Bone marrow or fat tissue gets disrupted during the surgery. Venous thromboembolism happens. These get into the venous circulation and go into the lungs. The surgical trauma and inflammation also can lead to the increased fat mobilization and lead to fat embolism. The patient will have respiratory distress, sudden onset breathing difficulty, hypoxia, respiratory failure. The patient can have confusion, agitation, and coma, especially the fat embolism has gone into the brain. Cardiac symptoms, if it is gone to the heart, arrhythmias can happen, hypotension, even sometimes cardiac arrest. Cutaneous symptoms, if there is a fat embolism to the skin, petechiae, purpura, or skin discoloration can happen. Diagnosis, clinical suspicion. We do a chest CT, MRI, or ultrasound to detect fat droplets in the lungs or in the brain. Elevated lipid levels, decreased platelet count, and coagulopathy like PT, APTT prolongation can happen. Management wise, just like the pulmonary embolism, supportive care is very important. Fluid management, anticoagulation therapy, and surgical intervention, especially if there is a brain fat embolism. There will be increased intracranial pressure, so surgical decompression of the cranium may be required to save the patient. Again, prevention is early recognition. Surgically, again, it has to be very important not to damage the bone marrow or not to dislodge the bone marrow too much. Intraoperative monitoring. Hemarthrosis can happen after various procedures, after joint replacement surgery, arthroscopy, osteotomy, or fracture reduction and fixation. Mainly happens because of surgical trauma to the blood vessels if the patient is otherwise absolutely healthy. Otherwise, inadequate hemostasis during surgery, underlying coagulopathy, anticoagulation therapy if the patient was on earlier. Symptoms wise, joint swelling and pain, limited range of motions, bruising and ecchymosis around the joint, and warmth and redness around the joint. Diagnosis wise, do X-ray imaging, and to confirm, we have to aspirate the joint and we have to take out the blood to confirm it. Management, joint aspiration to remove the blood and reduce the pressure, compression and elevation to reduce the swelling. Pain management, anticoagulation reversal has to be done if they were on anticoagulants. Surgical re-exploration may be required in some patients. Most important prevention is to make sure that patient is not on any anticoagulants or any other blood thinners and take care during surgery. I think to conclude, orthopedic surgery, like any other surgery, carries some risks and complications. Some of the blood related complications include these, whatever I have discussed now, and most of these complications can be managed effectively with the multidisciplinary approach. With that, I conclude. Thank you. Thank you, Yogesh, for the talk.
How to diagnose them and manage them. Now the floor is open for questions. Chairpersons and delegates can ask a couple of questions.
Yes, sir. See, what happens is that there is something called non-turbulent flow of blood. Whenever the hemoglobin is adequate in the blood body, in the cells, the platelets travel in the center of the bloodstream and the RBCs travel in the side of the bloodstream. You know, and there is a coherent blood flow that happens. Whenever there is anemia, this blood flow is disrupted and platelets move towards the side of the blood vessel. And because of this, even though platelets are moved, there will be inadequate number of RBCs to form a strong clot. And whenever there is a tissue trauma, the platelets doesn't adequately attach to the endothelium and they cause bleeding. Now this also happens in anemia of renal disease also. So whenever there is an anemia, you know, even in the patients with renal disease, without any trauma also, sometimes they bleed. That is because of this. You know, there is inadequate platelet plug formation in these patients. Local DIC may not become generalized DIC. Local DIC may stay like that if you are able to contain the DIC there. If you are able to re-explore, if you are able to give adequate pharmacological prophylaxis. What happens with the local DIC is that when you are giving a medicine like an antibiotic or your low molecular weight heparin, they have to reach to that organ. If that perfusion of that organ is inadequate there, then the local DIC will not get resolved with the systemic therapy. In that case, local debridement, re-exploration is really necessary there to re-establish the blood circulation there and manage it. Otherwise, what happens, it's just like a gangrene, you know, the local DIC will then become systemic DIC. Immunosuppressive disease. Yeah. See, if the patient is on just having only leukopenia, you don't have to worry. What you have to worry is only infection part. Generally, you are giving one dose of antibiotic pre-op. The same antibiotic you continue for another 2 days. Many a times what happens, you just see a leukopenia. But most important is to calculate the absolute neutrophil count. What is the absolute neutrophil count? As long as the ANC is more than 1000, you don't have to worry. WBC count may be only 2000. but the neutrophils are 70%. Then the ANC is more than 1000, you don't have to worry. You just proceed with any other patient. If the neutrophils are really low, that's the time when you have to give prolonged antibiotic support, and also we will have to give GCSF support for those patients.
Thank you, Dr. Prashant, for the nice talk. When do you give prophylactic heparin to prevent DVT?
DVT in surgical context. Any patient who is more than 60 years, any patient who has undergoing a major replacement surgery, or is expected to get immobilized for more than 48 hours.
When do you start heparin?
Heparin generally within 12 hours of surgery. Within 12 hours of surgery, you give 6 hours, at least 6 to 10 hours for the secondary bleeding if it occurs. You just wait for that, nothing is happening, then give. If the patient is, if you think that bleeding risk is slightly higher in that patient, like 75, 80-year-old gentleman, in that case, within 24 hours, you start the pharmacological prophylaxis. In those cases, I would recommend give mechanical prophylaxis like DVT stocking within 6 hours of the surgery, so that at least you are doing something on that.
Sir, can I add to that?
Yeah.
We have very international protocols for post joint replacement, because those are very high risk for DVT. So every joint replacement patient we give prophylaxis. Every patient we generally start within 12 hours of surgery. If it is a bilateral and we put an epidural for primary joint replacement, we only do spinal anesthesia, so that's not an issue. But if the epidural is there, and the epidural stays usually in our case for about 10 hours post-op, we take out the epidural, and within 24 hours, the first dose of anticoagulant goes in, because revision and bilateral are higher risk for DVT. So, but it can be given only after the epidural is taken out. So I make sure the epidural comes out within 10 to 12 hours of finish of surgery, and we push in the anticoagulant. And depending on, we do a platelet count in every patient, because we generally give low molecular weight heparin because it's most uncomplicated and it doesn't require IV line. We don't give antibiotics, so the parenteral access is all out. So it's all subcutaneous injections, and we shift them to oral when possible. Anybody with a low platelet count, I get worried, because some low molecular weight heparins are known to cause thrombocytopenia. So therefore, then we cry on Prashant's shoulder if anything is left, right, and then he advises on other things like oral anticoagulants and other things.
Yeah.
Thank you. Sir, the protocol is 2 weeks for a TK, 3 weeks for a risk for joint replacement, for DVT. So the NICE protocol is 5 weeks for total hip replacement. So usually days of injectable, because that is when they are less mobile. Everybody stands and walks within 24 hours of surgery. There is no doubt about that. And during surgery, we also give mechanical prophylaxis. So mechanical prophylaxis, that is intermittent calf compression on the table until the anesthesia is out. Then we give them stockings. Every patient, you will see the videos, they are going around with DVT stockings, which we make it compulsory for 1 month. So mechanical is there, early mobilization, which helps. And chemical is initial 2 to 3 days injectable, followed by oral. Oral continues till 2 weeks or 5 weeks, as per the case.
I don't have a question, but I have a comment that in pediatrics, if there is no history of trauma, then any skeletal manifestation, we have to think of multi-system diseases, and the most likely systems
Correct.
to be involved.
Absolutely.
It could be due to the disease, or it could be due to the treatment. For example, if the child is on high-dose steroids, he could have avascular necrosis of the hip, and that can present to the orthopedic surgeon as orthopedic manifestation. So it is very important in children without trauma and presenting with skeletal complaints to look for multi-system disease. Thank you,
Yes,
Dr.
ma'am. In
Prashant,
fact,
for that very
yeah, thank you, ma'am. Yes, ma'am. Thank you. In fact, it is not uncommon for us to see a patient with avascular necrosis of the femur. When we evaluate, we find that this patient is a sickle cell minor. The entire manifestation of sickle cell disease may be because of an AVN there. It is not uncommon. We had, I think Yogesh and I have common patients like that, sickle cell anemia and AVN. I think with that, we conclude it.
Thank you very much.
Thank you.
Can
Thanks
I
a lot.
call upon the chairpersons to provide a memento to our speaker, Dr. Prashant?
Thank you, Dr. Yogesh, for giving us an opportunity to share this session.
My privilege, madam. Can I ask Dr. Harsha Prasad to give a token of appreciation memento to the chairpersons? Can I call upon Dr. Ramadas to provide a token of appreciation to Dr. Harsha for moderating the session? Thank you, sir. Thank you very much, audience, a group photo for a wonderful interactive session. Thank you very much. Without wasting time, we'll move ahead to the next session. Dr. Suchitra Shernai is going to enlighten us with the diagnosis of joint infections. I'll call upon the chairpersons. We have Dr. Krishna Gokhale with us. Sir is graced this occasion. Thank you very much. Sir is the Ayush president. Thank you very much for coming here. Sir has also been awarded for conducting CME, which are interdisciplinary. So I'm really privileged to have you here, sir. Please. Along with him, I'll call upon Dr. Pratish. Dr. Pratish is here from SDM Hospital, Multi-Specialty Hospital, Ujire. Thank you very much for taking your time out. And to moderate the session, I would like to call upon Dr. Priyanka Shekhar. Dr. Priyanka is a microbiologist herself. She has served as a microbiologist in Bangalore, and we are lucky to have her in Mangalore. She works with the SBI specialist as a medical officer there. Thank you, Dr. Priyanka. Please. Dr. Suchitra and I go back a few years. It has been a good journey, of course, as an orthopedic and especially a joint replacement surgeon. The real scare is getting a bacteria next to the knee. So what I have learned on my revision fellowships is where I did my fellowship, it was all about really combating infection. That is the major scare. And people think that if you're in India, your theater control is not going to be as good, and the infection rates are not documented well in our country. I would like to show you a couple of cases, or one particular case, which is of so this is a guy who was 36 and came to us just at the beginning of COVID. This is something which has eventually become a case report, because we were the first in the region to actually diagnose and then report this, thanks to your department. So this fellow was operated on in Bangalore at the beginning of COVID. He languished on the ward because there was lack of facilities and personnel during the COVID time. And following that, he never got up and walked. There wasn't any active discharge, the wound healed, but he was continuously having pain in the hip. Now, looking at that, you could see that, you can see the bone here, but here it is all disintegrated around the implant. So it was a funny picture. We thought maybe looking at the type of fracture, the fracture actually looks healed, even though we thought maybe what is a common complication in these cases, the head crumbles because of loss of blood supply. So this is AVN. So we got in thinking we will just go in and convert it to a joint replacement. But surprise, when we went in there, we saw specks of tissue which were not looking very good. Little pussy, little cheesy, not like a bacterial infection where you expect to see oozing pus or a bad wound. The tissue was just funny. What I took the decision at the time was obviously not to implant, just to put in a spacer. I made a laddu with cement, put in antibiotics into that, put in broad spectrum, what I could think of, and pushed it in. Thinking I might get some diagnosis, sent tissue immediately to the lab. Fortunately, we've had this in place. I would proudly say we are the only center that I know of in our region where if I tell Suchitra doesn't give meals to her family but stays overtime and make sure she's there in the lab while we are doing the operation so as to give us an intraoperative microbiology report. Luckily, in this case, she also tested not only for bacteria, but also she did a KOH mount. It turned out to be a fungus. There are just about 20 cases reported in the world. We were able to diagnose, treat this aggressively, and 3 months later, during COVID, go on to a full-fledged hip replacement. The guy is a stage actor in Kundapur. 5 years down the line, he is comfortably walking. So thank you very much. I'll let you go.
Thank you.
Oh, sorry.
Thank you. Thank you. Thank you, Yogesh and team, for this opportunity to interact. I find in the list that I'm the only person who's not a clinician who's there in your team. And I'm really happy to be here because if you see that program list, he's given me 25 minutes. For my PPT, he said only 10 minutes. Because he said you should have more interaction. And I'm really, really happy for that. Because we are sitting in a four wall and expecting something from the other end. Like garbage in, garbage out. If you don't get the right specimens, we are not able to do justice to it. And microbiology has evolved a lot. And we can do a lot to help people out there, the patients and the clinicians. So going forward, now we are talking about the septic arthritis. It's an inflammation of the joint secondary to an infection. It could be any of these. I'm not speaking much. Most often it's a monoarticular, but it could be arthritis with small joints also involved. It is an orthopedic emergency, which we need to remember. And also, if there is already an inflammatory joint, then the amount of infections or the percentage of infections will also rise. Now, these are the different organisms in the children and in adults. I'm putting this forward because most often there is an empirical treatment which is started for the patient before the patient presents to the tertiary care. And when we are thinking about an empirical treatment, it would be good to give the right treatment and maybe it will subside. So we need to remember that it is always and always Staphylococcus aureus. Whether it's a child or an adult, it's always the Staph aureus when it comes to any kind of bone and joint infections. I'm talking about the nail joints. But once it is touched, it could be anything under the sun. So first, always think about for the gram-positive organisms. When we think about, okay, thank you. When we think about the organisms it would always be better for us to think about the gram-positive organisms and cover them. That's very, very important, except when we are having some kind of a blood dyscrasias, we find that Salmonella is present. In the last 2 months, in the case of spine, we have got at least 4 Salmonella groups. So I'm not sure. These are all very elderly patients who have come. And I think Dr. Prashant should be referred to see whether there are some problems with the blood dyscrasias now. Now, in children, it's usually hip joint, whereas in adults, it is knee joint. Most often, it is a single organism, but in 5% of the cases in adults, it could be polymicrobial. That means it could be more than one organism. Now, I'm repeating this because there is a lot of advocation for using molecular tests today, and it will invariably come positive if the specimen is not collected appropriately. So we go on. In case of the joint infections, now early 3 months, within 3 months after the operation, it's still Staphylococcus aureus. Now this is an organism which is found on our skin. Therefore, there are chances for it to get in from any site, maybe directly or maybe hematogenous spread. So first 3 months, still think about Staphylococcus aureus. After that, 3 to 24 months, it could be a gram-negative organism, and now comes coagulase negative Staphylococcus. Initially or previously, we used to think only about epidermidis, saprophyticus, etc. But we have n number of cons now because we've got a lot of equipments now to identify the organisms like Whitek and Maldi. So you will be getting different organisms which sometimes even we would not have heard about. Now later, after 24 months, there could be an infection of the joint which is extending from another site. Now with our experience from the microbiology lab, not only with Dr. Yogesh's team, we have found with others like the spine, etc. Most often we find that the elderly person has had an episode of urinary tract infection. That is, after possibly 1 year or so, the gentleman or the woman has got an urinary tract infection which is treated adequately. It's not that it's not treated, it's actually diagnosed and treated adequately, but after 2 to 3 months, patient comes with this problem with the joints. So I think people who are treating them should be actually, and they totally forget about this infection. Only when you ask repeatedly, there must have been an infection previously, please talk to them. Then some relative will come and show one report saying that that person had urinary tract infection. They bring the report to show what treatment was given, not to say that infection was there. We have found Klebsiella, we have got group B streptococcus. There are different organisms which we have found in the hip joint afterwards. Fungus, I'm really not sure what is the source, like what Dr. Yogesh had actually told, because there is no reason for a fungus to reach that joint. I'm not saying that it is a septic surgery which had been done, because it's not going to be that way. But I really do not know how the fungus reaches. If it's Candida, I understand, but we find molds, especially Aspergillus and sometimes some saprophytes. I really do not know how it reaches the site. Now, this is all what we all know. I've just still put this because there are few things I want to stress when there is specimen collection. Now, we know this is the joint space which is getting infected. It can be hematogenous, could be adjacent, or it could be from the bone directly coming in. And if you're having any kind of a prosthesis, now this is a nidus which is avascular, and therefore if there's any infection which sets in, very difficult to treat, you may have to remove this out if you have to treat it adequately, because there's no proper blood supply which is going here. So any amount of antibiotics we push may not reach the site. Now, these are the different sites. Please remember this, because the organism has its own defense. This is a crowded one, but I want you to see this is very, very important. Biofilm formation. Most of the organisms which cause infection of the joints or post-joint replacement is these organisms which produce biofilm. So they are going to be sitting on that avascular surface, And they're going to form their own colony, which is very hard for you to remove. It's literally like you have to scrape it out. Okay? And then when this is happening, meanwhile, we also have a lot of cytokines which are released. Why I'm mentioning it? Because they can be used for diagnosis. Some of them can be used. So now when we are talking about septic or not, now this is because we've had around 9 to 10 cases when Yogesh keeps telling us that this is an infected case. We've done all tests under microbiology, and he keeps saying CRP is increasing, ASR is still there, and I think it's an infection. And we have a kind of an argument sometimes in saying that this is not an infection. I don't see anything under the microscope here. Nothing is growing. I think that's a joke which most of them say microbiology gives no growth. Okay, but I think that's something for you to think when I say there is no growth, because it could be a simple inflammatory joint. And we have had 9 cases, different cases, where it was not an infection at all. It was a simple inflammatory joint which they are treating adequately without any kind of other antibiotics, etc. And this is another one more which we have to think of, systemic infection. I repeat this because we have had 2-3 cases, elderly people coming back to us after 1 year, 2 years. And initially when people were coming from other centers, we were wondering whether it was a proper aseptic procedure. But then as we went on learning and understanding it, we realized there must have been an infection in another site which has spread to this particular joint. Now, these are the things which we usually do. You send us the synovial fluid and the tissue, and we do a gram stain culture KOH. As a protocol here, whenever he's trying to send or he's opening a patient, he tells us, now he's forced to do his surgery before 5 because we leave the lab at 5. If he wants on-table reports, then he has to send the sample to us before 5. I tell him before 4 because we need to do a battery of tests before I can give him. Yes, we do stay beyond 5, but that's the thing which I tell him, you have to start by 2, otherwise we are moving out. So he does a frozen section also, so pathologists are also waiting for him. So this is something which we do, gram stain. Most often it gives us an idea. But if it is from the synovial fluid, I'll tell you why we could fail from the laboratory side. Culture, we've got beautiful methods now, and therefore we can make use of it. And when it grows, we can identify it. KOH or calcofluor is something which we do. It's just 15-20 minutes procedure, and we can give you a result. Now, whenever there is a systemic infection, I request you to send blood cultures because it does give us some kind of a backup, because these organisms, if they are present in the blood also causing some kind of a bacteremia, they grow. If it is not growing from the joint, it will definitely grow from the blood. Then molecular tests. I still have my own doubts about molecular tests because invariably something comes positive. It's not grown. We don't know what to give. Okay. But when we have no other source, yes, they may help us in some kinds. Now, why is the poor sensitivity for microbiology? Very few organisms are present in the synovial fluid. Most often, pre-operative, we get only synovial fluid. He sends a synovial fluid to us and says, we'll see if there's an infection, we can treat and then go in. Otherwise, if nothing is there, he is going to stop the antibiotics before he takes for a revision or for the treatment. It may be totally nil in the synovial fluid because the concentration of organisms is very less. It is in the bone. It may be sitting on that prosthesis, but not in the synovial fluid. Appropriate would be to get the tissue which is intraoperative, and that's the reason why we keep waiting for it. Tissue from the edge, not necrotic. Don't send the necrotic tissue because it's of no use. It's all dead and gone. No organisms are going to survive. They want food. Therefore, they are going to be on the best tissues which is next. So the edge are the ones which you have to scrape and send. Sometimes they are fastidious organisms which are difficult for us to grow, but we may be able to see it in the gram stain and give you a report. So now how do we increase? Keep the person off antibiotics for 2 weeks so that there are chances for the number of organisms to increase. It's not going to cause any problem to the patient because the number is less and it has been there for some time. It's not going to change anything except patient can get into sepsis if they are diabetic, etc., which is a problem in the elderly patients. At least 5 intraoperative samples from different sites with different instruments. Don't use the same instrument because we will not know whether you have taken it, spread it other places also. Transport immediately to the laboratory, which is very, very, very important if it has to grow. Otherwise, not possible. Like cases of Neisseria, gonorrhea, etc., they grow only when we are going to culture it from the fresh specimen. Fluids into the semi-automated blood culture bottles. Now, I think most of the laboratories provide with the Bacti-Alert or Bactic. Now, you can use the pediatric bottles because you can get around 30 to 40 ml only from the joint, and it may be required for n number of tests. 1 ml or 2 ml can be pushed into the pediatric bottle, which is sufficient for us to grow. Now, these bottles are different from just sending the synovial fluid because they have resins which can absorb the antibiotics. They have resins which can absorb any kind of anti-complementary, etc., antibodies, etc., which is present in that fluid. So it enriches the organism to grow. It gives a better environment for the organism to grow. And implant to be sonicated and the fluid is used for culture. Let's see what it is. Now these are the bottles I'm talking about. The yellow cap is pediatric, the green is the adult. This is one company, Bacti-Alert, but you may also get bottles from Bactec, which is another company from BD, where the pediatric bottle has a pink cap and the adult has a blue cap. Okay, you can just push that synovial fluid or the fluid which is there on from the table, 1 ml into this particular, like you're collecting any blood culture, and send it. We will incubate it along with the blood culture bottles, and the chances of getting the organism is much more and much faster. Only disadvantage of this is we will not be able to give you the tissue reaction. Whether there is a pus cell, what is it, intracellular, etc. This is something which cannot be done. So what he does is 1 ml he pushes into this, another 1 more he sends to us to do the cultures outside. Now this is how we expect these samples. I know we want many, but I think if you want to find that one small organism in one corner, we need to have many samples. So this is how we receive from Dr. Yogesh's team. And that's the same thing which we did last in April. So these are the ways very rightly to be numbered, and also the site. If that is not there, it's going to get confusing for all of us. We need to see where it is from left, right, where, how many numbers, exactly that, because that's how we are going to process and give you the sample, and that helps you later on to understand where that infection is present. Otherwise, it's a mixture. If we'll just give you 1, 2, 3, 4, 5. You don't know from where it is and what it is. So please label it when you send. Now I want to show you this is how we get the samples. I know, because I'm not saying it's because there's no education. People think I'm sending the bone, you do what you want. I don't have a saw in my lab. This is an entire metatarsal which came. This comes around 9:30 in the night, and the technician is asking me, what do I do with this? I called the clinician back and I asked, what is this? He said, that is saline. And what is this bag? He said, that was a glove bag which was lying. I can't do anything with this because it's totally contaminated. I can grow everything under the sun in this. One. Second thing, very dutifully, one of the senior residents sent us this. I'm so happy that I received the implant. But the problem is it came in a peppermint box. Okay, and problem here is, one, it's not sterile. Second, by the time it reached my lab, it is dry. I can't do anything with it. So not all the labs are actually equipped to do what we are expected to do. Even my lab in many aspects, I'll tell you why. If you're having centers, you can always have these small things. This is how you have to send. You take a sterile box, you put that implant, then you put around Ringer's solution into it, 500 to 400 ml. You sonicate it, and then you vortex it, collect it, and the centrifuge, that is added to the bottle. Now, we don't expect to do this in the lab for one reason, because by the time it reaches us, it is dry. Second, I need to open whatever container you have sent, and it may not, my lab is sterile inside the biosafety cabinet, but outside it is not. You want so much of a manipulation to be done? No, it won't happen. We may contaminate it. So if you are going to send a sample, it would be better that this is done. You know what you're doing, because you also should have different sized containers to put these implants so that you can have adequate sonication and then vortexing it. The bottom part is what you are going to put into the blood culture bottle and send it to us. So because you keep reading and saying that you send the implant, they'll do. But most of the labs are not equipped to do these things. And it may not be sterile area also to do these things. If he's going to do more cases, then we will start doing this. Okay, so this is the way you are looking into and diagnosing, as I understand. So whether it's infected or non-infected, depending on the major and minor criteria, I'm not getting into that. These are the different diagnostic criteria which are present. It's not only the cultures, but also the other added non-specific markers which are actually asked. I'm only talking about microbiology, culture, and how adequately it would be better to send us a sonicated sample and in the blood culture bottles. That is going to increase our chances. Coming to the last slide, along with all these problems, we also see in the literature saying that possibly there's a programmed cell death receptor which is present in these patients, and therefore revisions also may be difficult for the patients to hold on. So this is something food for thought, and maybe not only antibiotics, maybe there are other things which we may have to use to have a better outcome. Thank you.
Hello, ma'am. Yeah, this is Dr. Priyanka here. Ma'am, what are the diagnostic challenges are you facing for the detection of biofilm? Because it is most common in the prosthetic joint infections these days, is it?
Yes, that's definitely going to be the reason why I say that sonication will be the best choice. That will be the best. And when they are sending us a sample, they are literally curating that part and sending. That's fine. But what happens is most of the time the organism is forming a biofilm on the implant. So getting only the tissue is of no significance.
Correct. Ma'am, how about the antibiotic sensitivity test, which is most commonly resistant to what all organisms currently?
It depends on the source of infection. Most often when it's a nail infection, we find the Staphylococcus aureus sensitive to everything. But if the patient has already had some other infection, we have found MRSAs. I think one of the elderly patient who had to be put on rifampicin with a great fight. He put it, he didn't tell us. And after the patient recovered, he told us he had put the patient on rifampicin, because we still have a judgment to say, no, don't do it because we have got tuberculosis. Then the other thing is, if it's gram-negative organisms, very, very difficult at times, because if they have had a urinary tract infection, treated, because what happens is in urinary tract infection, they are generally exposed to all fluoroquinolones.
Correct.
Okay, they are and because many of them understand about ESBL today, so they don't give the third generation cephalosporins, they give fluoroquinolones. And when the patient comes with these infections, they resist their ESBL plus fluoroquinolone, and nothing is there for us to do more. It's total MDR, and then we have to put IV. I think we have had an elderly person, diabetic, who had Klebsiella, and on 3 months on tigecycline and colistin, and then we found that it was resistant to that, and NDM. So now the patient was for 45 days on ceftazidime avibactam with estrionam, one of our own colleagues' father, and it was very unfortunate. Now I don't know, he's on a spacer.
He's on a spacer.
He's a spacer, yes.
He's fine.
He's in, yeah. So that's something very unfortunate for us.
Yeah. Thank you, ma'am.
Is I think to you, sir, what is the protocol that you follow for an elective case in a clean case with regards to antibiotics?
So in a clean case, we are just very, 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 you can say till as many times as possible preventive. So the prophylactic antibiotic as per protocol should not be much. We give 3 doses of prophylactic antibiotic as recommended. What is more important is a screening, which is more clinical screening. Abroad, people do MRSA screening, but we've had debates earlier. We don't do MRSA screening here because our MRSA carrier rate in India is very, very low. So it doesn't matter. We do screen clinically for any kind of dental, urine infection and so on. There has been debates on whether in elderly females particularly, who many times harbor organisms in the urine. So if a random urine sample or a urine culture is done, very often you might find bacteriuria. If it is asymptomatic, Suchitra's pedantic, she tells me not to give any antibiotic. I used to get scared of it earlier, but we've become more daring now if we take intraoperative precautions very, very strictly. What we definitely do is our theater is our temple. So nobody enters that theater for anything apart from joint replacement. Myself and Ishwar, who's sitting at the back, we share our theater. We are very, very pedantic about only elective cases, and patients entering that theater go in only after a chlorhexidine bath. So even if they have been carrying MRSA or whatever, that will be taken care of. Right from head to toe, they take a bath hours before entering that theater. The prophylactic antibiotic I cannot state because it should really vary from hospital to hospital, and Dr. Suchitra advises. We have regular, she's also the head of our hospital infection committee board, so there is a regular review of what is being colonized in the hospital, and depending on that is what they advise us which prophylactic antibiotic to give. It is wrong to say this is the blanket antibiotic that we give. But yes, we generally give Magnex Fort because we do have gram-negative flora which is being grown in our kind of environment. So that is a good positive and gram-negative cover, but that is up for review at every meeting. On that, I'd be proud to say we have isolated organisms in cases of revisions or whatever which we've got from the community. We have got isolation rates of up to 70-75%, which are equivalent with among the best reported in the world. So I'm really proud to say that. Thank you very much. The other thing I would love to say, I mean, of course, this is in continuum with a lecture which is by Dr. Chakrapani sir, where we are talking about periprosthetic infections and management. We have been the only center in India, I've reported this at the national conferences, where we have managed revisions. The golden rule for revisions, as our senior orthopedic surgeons would say, is a two-stage replacement. You have to put a spacer and then 3 months later do a second surgery. But there have been a few cases in old patients with a known organism because we've isolated the organism before surgery, and I'm going to demonstrate that case before Dr. Chakrapani's lecture. We've managed them in one stage and successfully as well. Thirdly, in terms of, we've reported all this, and we are just reporting our series of pseudo-septic arthritis. I'm very proud to say we've had a good series, 9 cases, which have, that many cases have not been reported so far. We are working on the publication, but it requires daring sometimes to, in a joint which looks like infected, to push in an intra-articular steroid. And we can do that only with a robust microbiology. So majority of the times it would be inflammatory, as Suchitra said. There are times when with Dr. Prashant's help, we have seen pseudoseptic also with paraneoplastic syndromes. We've managed cases together. So, I mean, it is all on the basis of a robust microbiology. Thank you.
Thank you.
Should we conclude that session then? Can we ask the chairpersons to present the speaker with a memento, please? Collect the mic. You can leave it there. Yeah. Can I ask Dr. Priyanka to present a memento to each of the chairpersons? Dr. Udupa, Dr. T.R. Udupa, if you can please come on the stage to present a memento to Dr. Priyanka. Thank you all very much for an interactive session. Formally inaugurate this with the lamp lighting. I'm grateful to have and privileged to have quite a few attendees. And Bhaskar, sir, please. Sir is a senior orthopedician from Puttur. Always there as a colleague and guide. Following lunch for Dr. Chakraparty. Thank you very much.
still here and the train has not yet reached the station. Have fun watching the rest. still here and the train has not yet reached the station. Have fun watching the rest. still here and the train has not yet reached the station. Have fun watching the rest. I'm still here and the train has not yet reached the station. Have fun watching the rest. being here, and the train has not yet reached the station. Have fun watching the rest. still here and the train has not yet reached the station. Have fun watching the rest.
We can get our respective lunch inside and have a relaxed eat and listen.
Driving and without any problem. And so I decided to fill out the canal and I think it's a good job.
Lady Chairperson, Dr. Shilpa Hegde. Thank you for coming, Dr. Shilpa. She is from Vijay very much and represents SDM Hospital. Is that correct? Please, ma'am. I'd like to call upon our infectious diseases specialist consultant, Dr. Vineet. Dr. Vineet is originally from Kasargod and practices exclusively infectious diseases in Mangalore. We are privileged to have him here. Thank you. And also I'd like to call upon Dr. Kumaraswamy, sir. Dr. Kumaraswamy is a senior physician from Bondel. Most of you know him already. His clinic is Konchadiyalla, sir. Please. To chair the session, I have our very dynamic physician and my friend, who else? Dr. Harun. Please welcome, sir. Yeah. And it's his privilege to moderate the illustrious Dr. Chakrapani. It gives me great pleasure to, obviously he doesn't need introduction. I will just start with cases which we've managed, just as an example. So, take a minute. Yeah. So, here was an 80-year-old man, not, wait, no, an 80-year-old man had You know what to do, right? To get that. Had joint replacement which failed in France. So originally a British citizen, and as the French would like to reveal or rather unleash all their fury on the French, when he has, on the British rather, no, this one. Yeah, you get the right slide, please. So he had an operation in France and bilateral knee replacement that failed. Then he had, because the metals were loose, whenever a metal gets loose, you have to anchor it with rods inside the bones, respectively. So over time, even that got loose. But in this particular case, as you can see here, the metal broke inside the leg. And this guy was probably 78 at the time. It did not go well. He sued the company in France. But despite that, having another operation which failed and then having continuous or rather intermittent swellings in his knee, was walking around in pain, came down and started living in Goa. So originally of Indian origin, his father is Indian. He was the first ambassador of India to France. That's how he was a French citizen. But anyway, so when he presented to us, he had a swollen knee, there was no discharge from the knee at all. But intermittently taking antibiotics as is prescribed by many physicians and managing, we could see there was obvious loosening around the knee. So clinically pointing to an infection. So in line with what Dr. Suchitra mentioned, we aspirated his knee and it was obvious that we had to go in and do a treatment, as in infection related procedure. Now, taking care of that infection means taking out a huge amount of tissue, and it has to be, that picture doesn't look nice with all those metals out. It has to be like a tumor resection. Now, this particular man, the challenge was, he says, I am 80, 81. I don't want to have the standard thing where you will put me in a spacer. And imagine if I take out this, I'm fracturing that bone there to take out this. He's going to have a huge void. I wouldn't be able to make him walk for the 2 to 3 months that the spacer entails. So the challenge was, what do you do? Fortunately, we have a good, robust team, Dr. Chakrapani, Dr. Suchitra, who, when we isolated the organism, we could see that it was a very sensitive streptococcus. So this is the classical example where we can actually, along with a good surgical debridement, manage it in a single stage, which we did for this patient. We managed to get him walking around and changed that to a successful revision joint replacement all at one stage. Our infectious diseases consultant helped us continue antibiotics. What we did in this case was, you can see these beads. These are antibiotic loaded beads which are put in the tissue. This is an additional mechanism by which we can get antibiotic released locally into the system such that you rehabilitate the patient fast. Dr. Chakrapani is going to enlighten us. We've fortunately got about 2 or 3 of such old people managed with single stage infections, and I can proudly say I presented this at national conferences. We've been the only center in India to do this. It's been done internationally, but people say India is not suited for it. The answer is not right. If you have a good team, we can manage it. Over to you, sir.
Yes, sir. Respected chairperson, moderators, and friends. At the outset, I would like to thank Dr. Yogesh for giving me this opportunity, and also my previous speakers, Dr. Suchitra, and others who have almost covered most of the topics of periprosthetic joint infection. Having a periprosthetic joint infection is a nightmare. It is much, much different from any other infection. It is qualitatively entirely different infection compared to most of the other infections. I'll be talking the etiology of periprosthetic infections, how the infection spreads there, and clinically how will you be able to identify and manage it, and if there are any more questions on that, Dr. Vineet will be there to answer that because he's an expert on this field. The periprosthetic joint infection is, as I already mentioned, qualitatively different. A typical infection, a septic process, is very easy to identify. For example, if there is pyomyositis or a liver abscess or a well-localized abscess, the clinical features are very clear. You examine the patient, you almost have a suspicion, you know that there is an infection or abscess. And then identifying the organism is also fairly easy. And then once you identify the infection, you diagnose it with biomarkers or cultures, and then you start treatment and give the appropriate treatment. That's the end of the story. But a periprosthetic infection is different in all these respects, whether in the clinical presentation, where it can be quite indolent and going on for a long period of time, or biomarkers which can be false positive in most of them, because even without infection, after the prosthesis, there can be positivity of the biomarkers. And identifying the bug is extremely difficult. What you identify may be just a colonizer. So differentiating a colonizer from a pathogen and then deciding to treat, which will be a prolonged affair, and then whether to keep the implant, remove it, 1 stage, 2 stage, all of them requires a very good clinical judgment, and most of them do not have a clear-cut evidence base. Most of the practices which we are going to see in periprosthetic joint infections are based on experienced experts in the field and observational studies, but not much of evidence-based randomized clinical trials. So that is the magnitude of the problem as far as periprosthetic joint infections are concerned. The bug is quite often a treacherous, tricky, and in your own territory. It's like a classical guerrilla warfare. Shoot, scoot, hide, and hibernate. The pathogen suddenly comes out and then will manifest with some clinical findings. When you are about to identify the organism, it's already scooted out and then hides and then hibernates beneath the biofilm. This is in essence the periprosthetic joint infection. You have infection. No, I'm not moved it. Not moved it. Yes. And this is the typical guerrilla warfare of the organism. Prosthetic infections or hardware infections not uncommon. For example, infective endocarditis. But it's not that difficult to diagnose. You can visualize the vegetation. And it's continuous bacteremia. You can easily culture it. And you can give the appropriate antibiotic, and often you are able to preserve the prosthetic valve. But in the case of periprosthetic infection, the organism manifests intermittently, indolently, and then identifying this culturing is quite difficult. Then you want to start treatment, unless you are able to go up to the biofilm and identify it and eradicate it, it's very difficult to control the infection. So we'll be going through the epidemiology quickly and the microbiology, which has already been covered, clinical risk factors, how the infection gets in, clinical features, are there any typical clinical features or not, how to diagnose, prevent, manage, and in conclusion. What is the magnitude of the problem? To what extent do you see these infections? Typically in a good institute with proper infection control, it's mentioned as about 0.5 to 2% in knee replacement and about half of that in hip replacement. In the knee, the incidence of periprosthetic joint infection is more. And it's much more common in the first 2 years, up to about 1.5%, and later on it comes to about only 0.5%. So this is the brief epidemiology of infections. But even if it's about 0.5%, that's 1 in 200, for a given patient, the cost is enormous. Cost in terms of stay in the hospital, in a corporate hospital, every day the bill will be mounting, and the cost of the antibiotics, cost of the repeat procedures, cost in going out of work for quite some time, and mental torture for the doctor concerned. So even if it is 1 in 200, there is a significant burden and cost for everyone concerned in this problem. And Dr. Sujitra has already mentioned the microbiology of this infection. Staph is the most important one, Staph aureus, or even cons will be there. And in hospitalized setting where the immunocompromised host, there can be any kind of gram-negative or other bacteria. Sometimes even polymicrobacterial infections are common. Fungi will also be there occasionally. So you cannot have one bacterial identification for a given clinical feature. That's why clinical features are not specific, and it's difficult to presume the organism and hence the antibiotic. Not everyone gets this infection. There are some risk factors. There are patient-related factors like comorbidities, diabetes, CKD, and other immunosuppressive agents, previous surgeries and infections, surgery-related factors which are fairly well controlled with, as Dr. Yogesh has pointed out, with the dedicated theater and strict asepsis. This factor can be fairly well controlled, and duration of surgery is also well under control. And use of antibiotic based on your local epidemiology and local antibiogram. You have appropriate prophylactic antibiotics. The infection rates can be well controlled. And Dr. Sujitra has already mentioned classification time-wise. And this time-wise classification, although arbitrary, is quite useful for a clinician in terms of the pathogens and to know how the infection came in, and so to know what treatment can be given. Early, delayed, and late. It is true that this is arbitrary classification. There is no evidence base to go by this classification, but it does help to estimate or guess regarding the route of infection and pathogens, and based on that you can decide the treatment. The early and delayed probably are because of the procedures or contamination during the surgical procedure, but the late one is not under our control because this is because of hematogenous spread. Now, bacteremia is very common. Even it's mentioned that even if you chew a food for some time, there can be some amount of bacteremia, streptococcal bacteremia can be there. But not everyone gets infection with that. That's because of good host immunity. So, a combination of a compromised host, well-adapted pathogen, and a artificial hardware is the right environment for infection to set in and then propagate and multiply. So the initial inoculation could be either from the initial procedure, which is not very common, but later on there can be bacteremia which holds on to the artificial material and then continues to grow there. And it, at the interface of the bone and the artificial material, it lodges there and multiplies. The most important next point is formation of the biofilm. Biofilm, as Dr. Sujitra has pointed out, is a landmark change that occurs in prosthetic infection, because a biofilm will protect the underlying bacteria, and there can be colonies where they hibernate, and they without any nutrition they can survive for a long period of time, and antibiotics will not reach there. So for these multiple reasons, biofilm formation is a very important step in the pathogenesis and treatment of prosthetic joint infection. And with that we come to clinical features. Clinical features are non-specific. That's the most important point. Unlike all other infection septic process where clinical features are very striking, whether it is soft tissue abscess or endocarditis, clinical features are very striking. But here, you've got a lot of difficulty in differentiating infective symptoms from inflammatory symptoms from mechanical symptoms. All three can overlap in a given patient. Just because there is a pain doesn't mean there is an infection. Just because there are inflammatory markers, high ESR, high CRP, doesn't mean there is infection. And there may not be even inflammation also. It could be just because of mechanical failure of the prosthetic material. So all of them will be coming together in a given patient, making it difficult for us to diagnose. So initially, I told you how pathogenesis is different. Even clinical features are not specific, and often it's the indolent infection. So florid signs of sepsis are not very common. That's why Dr. Sujitra confidently said you can stop antibiotic for 2 weeks. The reason is these are all indolent infections. If you want to identify the bug, stop the antibiotic for 2 weeks so that there's high possibility of a culture positivity. If there is a sinus tract formation, diagnosis is almost certain. So in the clinical features, diagnostic criteria are either a clear-cut sinus tract which is seen, in which case there is no doubt about the diagnosis. Or microbiological identification, wherein you have to go and prove that two of the cultures are showing the same organism. Multiple cultures are to be done, and two of the isolates should be similar. But then it is difficult to get even one culture positivity. So we are talking about two cultures being similar, and often we have to just rely on our clinical judgment and give the antibiotic based on clinical judgment and empirically. But if you're able to confirm two bacteria similar or one tissue culture and synovial culture, then it adds strength to the diagnosis, and then you can start the appropriate antibiotic. Laboratory markers like blood tests and biomarkers, I already mentioned that non-specific. After joint prosthetic surgery, ESR can remain high for many months. So ESR cannot be taken as the reliable marker of for diagnostic purposes. Once you start treatment, can help in prognosis, but for diagnosis, it's quite difficult to go by single value of the CRP or ESR. The imaging studies have got their own limitations. X-rays can be useful, as Dr. Yogesh has already pointed out, when there is a clear-cut loose zone there, or other clinical features of infection. Beyond that, bigger scans like PET scan or CT scan may not contribute, even MRI scan may not contribute. That is in contrast to infected endocarditis. You've got good imaging, you show the vegetation, you've got the diagnosis. Unlike that, in joint infection, imaging has got very little contribution. Even X-ray is sufficient. Beyond that, CT scans, MRIs, or PET scans may not give much of any useful information. And then once you detect the effusion, go for the actual diagnosis and identify the bug. And joint aspirate can be done. The cell counts can be high even without infection. So the usual cutoff levels of the cell counts or inflammatory markers do not work in joint infections due to prosthesis. So each infection, based on the duration, there are different cutoff levels. But just to highlight the fact, ordinary cutoff levels are not operable in case of periprosthetic joint infection. The cutoffs are much higher. You may require multiple samples and tissue cultures to identify the pathogen. Culture techniques have been already elaborated and explained by Dr. Suchitra, and tissue biopsy has been also highlighted, and the need for immediate histopathological diagnosis, frozen sample, all that has been already highlighted, and that's a routine practice. So we have seen how the infection can be difficult to diagnose, how clinically it is difficult to diagnose, and then treatment also is going to be very expensive and difficult. So how to prevent it? Prevention is by proper selection of the patient, infection to be under control, sugar should be well maintained, all comorbidities should be controlled as far as possible. And then look for colonizers, because if it is MSSA, you must give cefazolin. Is MRSA colonizer, cefazolin plus vancomycin, and then you give gram-negative coverage based on local epidemiology of the bacteria. Intraoperative techniques have to be very sterile, that Dr. Yogesh has already pointed out. And once you have diagnosed the condition, how do you manage it? The straightforward method is debridement, antibiotic, implant retention, ideally. If the infection is only short duration and you identify the organism properly and it is susceptible to the antibiotic you have chosen and clinically patient is stable, then one can go for just appropriate debridement and antibiotic, and you may be able to salvage the processes. You may be, under certain circumstances. And that is the best case scenario. If you are able to identify the proper bug and you are able to have appropriate antibiotic and clinically stable patient, you can just give the antibiotic and then wait and see. Hopefully you are able to salvage the joint and the prosthesis. If not, the earlier one, that is salvaging the prosthesis, only done in acute cases within 1 month of the prosthesis, and there is no mechanical failure, and the bug has been identified, you are able to give appropriate antibiotic, not immunocompromised source. That patient is the ideal one where you can try and salvage the joint. Otherwise, you'll have to go for surgical procedure, either 1 stage or 2 stage. one stage is what Dr. Yogesh just now pointed out, is quite a challenge. But you can do that if these conditions are satisfied, that is shorter duration and appropriate antibiotic has been given and well-fixed processes and patient is stable, then you can try for one-stage exchange arthroplasty. What is done generally is a two-stage. First stage is removal of the processes and placement of antibiotic spacer. And second stage is for reimplantation of the new processes after giving appropriate antibiotic for at least 4 to 6 weeks. Then you go for second stage procedure. And you may have to give a longer duration of antibiotic and sometimes lifelong suppressive antibiotic after the second stage procedure. Long-term antibiotics may be required, especially when there is immunocompromised host. And the challenges, so there are many challenges. Starting from the diagnosis, the challenge of antibiotic resistance, most of it is hospital acquired, and clinical presentations are quite complex. They also have a lot of comorbidities, and there is a huge cost in terms of both time, money, energy, and mental peace. So because of that, prosthetic joint infection is a big, big challenge. So I basically have tried to explain to you the difference between conventional septic process and a qualitatively different and difficult prosthetic joint infection. And the bugs are different, and time frame is very important in the approach to these patients. And identification of the infection, which has already been explained to you very clearly. Then what to do when there is infection. If it's best case scenario, salvage the joint. Otherwise, go for either one stage or two stage, depending upon the facility available and host factor and your confidence in doing it in one stage. And then need for prophylactic antibiotic and also antibiotic after the procedure, and the need for, in some cases, long-term suppressive therapy. Thank you very much. And if there are questions, Dr. Vinith will be there.
Sir, actually now there is this Indian guidelines of adult immunization is there, no, sir. So if we insist on the patients to complete their immunization schedule before they undergo an elective procedure, so whether it can prevent the joint infections?
Yeah, these infections are not those which are covered in the immunization schedule. For example, staphylococcus, that's not covered in immunization schedule. So the immunization schedule is mainly for communicable infections. These are most often host infection, host colonizers which can become pathogens, or vaccine conditions where vaccines are not available. Typical example being Staph aureus. So while it may prevent, for example, a good flu vaccine may prevent secondary staphylococcal infection. To that extent, it will help. Beyond that, it might not help.
Is there any role for prophylactic antibiotics in these patients, considering the fact that these infections are difficult to be treated? So for long-term prophylaxis,
Yes.
whether there is any role?
Theoretically, yes, but the point is, as I told, 1 in 200 will get the infection. So are you going to remain 199 for long-term suppressive antibiotic? That is not practical. On the other hand, if there is a host with significant immunocompromised condition, or where you know that there are other infections also in the body, then it makes sense to have a suppressive or prophylactic antibiotic for these patients. So in selected cases, we may consider that.
Sir, for these joint and periprosthetic infections, considering that some antibiotics may not penetrate the joint, which will be a good, because sometimes we may not be able to grow the organism also. So which will be a good empiric source of, empiric choice of antibiotics when it is bone and periprosthetic?
If it is empiric choice, you'll have to give both gram-positive, gram-negative anaerobic coverage. If it is purely empiric. And that the coverage has to be for staphylococcus. So since you don't know whether it's MSSA or MRSA, you end up giving vancomycin and another gram-negative coverage, BL-BLA combination, and one anaerobic coverage. So it is only when you don't have any idea regarding the organism, but you should take every precaution and extra effort to identify the organism, stop the antibiotic for 2 weeks, and go for diagnostic procedures, as Dr. Yogesh has pointed out. Synovial aspirate or tissue culture, immediately sent to the laboratory and try to get the identification 70% is the usual rate international, and that's what has been seen here also. And with that, you're able to cover most of it. But there will be a small number, culture negative. For example, culture negative endocarditis. Similarly, there's culture negative prosthetic joint infection also. There, push to the wall, you just give these combinations, vancomycin and BLA combination, and then another coverage. So, Vineet, is there anything that you can add?
The last 6 months of the microbiology, for example, if this patient had a recent urinary tract infection, recent organisms, that may help you to guide your empiric choice too. For example, if you are planning, it's a culture negative prosthetic joint infection, you don't have any previous cultures, no past urinary tract infection, you will be right enough to give either cephalosporin sulbactam with vancomycin, or if you're giving piperacillin tazobactam, you don't require anaerobic cover. Iptas with vancomycin, you don't require anaerobic cover. So that will be sufficient for culture negative. But what I usually do is I trace their previous cultures, find out whether they've been colonized with any organisms that may help you to choose your empiric therapy. Another one organism which we may tend to miss is non-tuberculous mycobacterium. At times, NTM can present with prosthetic joint infection. We have seen plenty. The clue will be the histopathology. Culture, that is MGAT plus histopathology, which will give us a clue about non-tuberculous mycobacterium too.
Most common antibiotic to be used
for prosthetic joint infection, sir, as rightly told her, for a culture negative, it is BLBLA, cephalosporin sulbactam, piperacillin tazobactam, with the adequate gram-positive cover. That will be vancomycin. The duration of therapy is minimum 6 weeks. IV therapy. Then once the source is out, you can switch to oral therapy. Although we have sufficient evidence now that 2 weeks is sufficient, in my clinical practice, I still follow 6 weeks of therapy.
On that note, I'd really like to mention we have talked about with Suchitra pseudoseptic arthritis, and around COVID, if sir remembers, there was a case post unicompartmental replacement which came with severe effusion and problems in the joint. We did a washout, we got tissue samples, we got the aspirations, everything was culture negative. So when we went into such pedantic repeated tissue samples and culture negative, we had to take a call. The patient was continuously getting fever, nevertheless. And I really appreciate, hats off to Dr. Chakrapani, where, we were giving antibiotics because we didn't know what else to do. And sir said, stop antibiotics, stop all IV fluids, let's see. This could be just IV fluid related because this was an exclusive thing because we had ruled out. And it was that the fever did stop. Eventually, she then developed throat problems, and with the rheumatologist, we diagnosed her as Still's disease. So, we have the world breaks loose sometimes.
At times, when we stop the antibiotics, sir, we will get the answer a lot of times.
Correct.
But the courage to stop antibiotic will come only when Chakrapani sir is around. That makes him exclusive.
And the team approach, really, we had to have the whole this thing. But having him there is a big relief for us. The decision to say stop it. Should we call it a day? Shall I call upon the chairpersons to give a moment of appreciation, token to Dr. Chakrapani, please. Dr. Shilpa, Dr. Vineet, Dr. Harun as well, please. And in turn, Chakrapani sir, you and Harun, if you can, because everybody would like to have you on stage. Harun, if you can give the token of appreciation to Dr. Kumaraswamy, and we'll ask Chakrapani sir to give a token of appreciation to Dr. Shilpa and Dr. Vineet. Can I please call upon Dr. Dinesh Chandra Hande to give Dr. Harun a token of appreciation? Thank you very much once again. We'll proceed on to the next one. Now, we've dealt with infection in our 2 to 3 talks. We now go on to diagnostic dilemmas. I'm lucky to have another very pedantic specialist right in the next chamber, Dr. Ishwar Kirti. As a hip and knee surgeon, I am often faced with diagnostic dilemmas as to what the situation can be, and they can be diagnostic confusions. I would like to call upon chairpersons, my senior colleague and surgeon, Dr. Shivanand Prabhu. He's a professor in surgery with us. Please, sir. And Dr. Surekha Hoskeri. Madam is now with, she's basically a pulmonologist, but she's now with NMPT. Madam, even though Kannadiga by roots, I relate to her in Konkani and Marathi as well. She's grown up in my hometown, Goa. Pleased to have you here, madam. And to chair the session, please can I call upon Dr. Bhaskar. Bhaskar is my senior colleague and senior orthopedician from Puttur. Who else better than Bhaskar, who would have seen various diagnostic dilemmas in practice. So Ishwar and I go back some way. It is really lucky to have somebody like him, because as a hip and knee surgeon, the thing that I dread is treating backache. So we want somebody, when they say, I've got pain in the knee, and if the pain comes up or goes below the knee, I tell them to go and seek Ishwar's help. So we've got these situations many times. So for example, you see this particular patient, very, very obvious problems in their knees and walking around in that way. So there's no doubt they would require a joint replacement. Many times, because of fear, they tend to neglect their knee problems initially. So particularly when they've been walking like that for a long time, you can imagine what must be happening to their back. So it is often necessary that we go on and at the time of screening, look at their back. Because what is going to happen? You are operating on a patient to provide them quality of life. If they've got bad knees, we have to be able to counsel them very well that, okay, your knees might become straight. You might start looking like Marilyn Monroe from your knee downwards. But the pain, if it is radiating from the back, you won't be able to carry your short skirt very well. So, and that is why my friend Ishwar is here. So many times we do these combined treatments where, you know, I would ask Ishwar to see with such a back like this, it's also scary where to push in spinal and what, you know, for that matter. So Ishwar comes to the rescue. And I mean, while we do the TKR, there are many times that Ishwar comes with his darts and plays around with, you know, we determine together for the patient. And that is the beauty of having him, where if the back is worse, we determine between us what is worse. He would do it first. If the knee is worse, I would do it. And he comes along and gives a temporary injection along with rehab, which helps the patient. Over to you, Ishwar. Thank you.
we have a interlink between spine and the lower limbs, that is pelvis. So the pelvis is called pelvic vertebrae by one of the very famous spine surgeon in Italy called Dubose. So he says this is also a pelvis is also a vertebrae along with sacrum. So pelvis is acting as a basement to the spine. So if there is any pathologies is happening below the pelvis, the hip or the knee, that will alter the position of the pelvis. So our basement is changed. So that can affect the spine. So spine and the lower limbs, they act in coordination in all movements, and one disorders can affect the others. So we have a godfather of spine surgery called McNabb, Ian McNabb. In 1983, he coined a term called hip spine syndrome. So he described for degenerative conditions for patients coexisting hip arthrosis, that is degeneration, along with spinal problem, that is spondylosis. So he says it is commonly not only the one condition, both the condition contributes for the patient's disability and pain. Like hip and hip spine syndrome, later they also described a terminology called hip knee spine syndrome, because like Dr. Yogesh said, if the knee is in wear, like this, they walk with a waddling gait, that will lead to problem in the spine also. So later on, with the advent of surgical treatment, multiple replacements, and of course in spine also we started fusing the spine. So the relevance of hip spine syndrome increased from a short note to a textbook. So now we have a textbook for special consideration for orthopedic and spine surgeons regarding hip and spine syndrome. So coming to the symptomatology, the patients with hip pain, they come with the pain around the hip. Usually that is the front of the hip or the groin. And of course they complain difficulty in walking, stiffness and etc. Whereas spinal degeneration, spinal stenosis or spondylotic patients, they complain hip pain in the behind side, the posteriorly. Of course there may be radiating pain and neurological deficit, etc. So what patient tells hip pain is different from what we feel hip pain. So when I ask a patient, is he having low back pain? Patient will tell, I don't have any back pain, I have hip pain. So their hip pain may be a posterior hip pain, and what we see hip pain is an anterior hip pain. So there may be a confusion between the patient and the surgeon. So there are 4 categories of these hip spine syndromes. There are simple hip spine syndrome. That is a straightforward single pathology. Only thing there is difficulty in presentation. So when we examine, we know that the problem is either in hip or spine, and we treat it as simple. So next, the complex hip spine syndromes. There are pathologies both in spine and hip, so we need to deal both. And secondary or dual pathologies, both are symptomatic and both needs treatment. So there the combined approaches, maybe we have to operate or we need to intervene in both sides, and of course misdiagnose. So coming to the simple pathology, here the pathology is single, only either in hip or in the spine. So once we diagnose it, we need to treat the pathology, patient will become all right. So the treatment is like any other problem. So let us go through, rather than theory, we'll go to some cases. This is a case of 65-year-old gentleman. He came with hip pain. So I asked, are you having back pain? Every patient who comes to the clinic, I ask, do you have low back pain? So they asked, he said, no low back pain, it is a hip pain. So his hip pain is not anterior hip pain, it is a posterior hip pain, and it was going to trochanteric on both sides. That's how usually the lumbar spondylosis or axial or mechanical low back presents. So he was being treated for some problems in the hip for quite a long time. This is the X-ray. Dr. Yogesh and his hip team can tell what are the problems in the X-rays. There are some osteoarthritic changes probably in X-rays. So with his presentation and clinical examination, we could find out that this problem is not in the hip and it is in the spine. So we did a spine X-rays and dynamic views that shows L4-5 degenerative spondylolisthesis, and the dynamics show significant instability. So here the problem is, there is no doubt that it's a simple type of hip spine syndromes. It is a single diagnosis, L4-5 degenerative spondylosis, and you treat the listhesis, patient will become all right. So coming to the another category, the complex cases. Here, patient's history is unclear. Patient is not able to tell where is exactly he gets pain, either in the spine or in the hip. They are also not very clear. And we do examine in detail both hip and the spine. There may be some positive findings in the hip and some are in the spine. So usually these patients are not having major neurological symptoms. So we may need to evaluate in detail with the X-rays and MRIs. And if we have Yogesh very next in OPD, it is very easy for us to evaluate hip. So coming to the case of a 53-year lady, she presented with back pain and radiation to the right side. So the pain is in the low back and it is radiating on the right side and it is going to the anterior aspect of the thigh and knee joint. So whenever patient complains of anterior aspect of thigh, first I'll think of hip, or it is diabetic hemorrhage or other things. It is not commonly the lumbar spine. So this is what is seen in her X-ray. She came with the X-ray here. So this is the degeneration of L5 and S1. So L5, S1 cannot radiate pain to the anterior aspect of the thigh. That is a part of L2, 3 or lumbar plexus. So L5, S1 patient should have had a classical sciatica going behind the buttocks and the posterior thigh. So that's why we thought we need to examine hip in detail. So usually I do not examine in detail, just to do some few tests and then pass on the patient to the other room. So I examined with whatever knowledge I had in the hip. So this is what is seen in her hip. One hip is completely gone. She had some deformities and shortening. So her problem is primarily the hip and secondarily the spine. So we need to treat the hip. Probably treating this osteoarthritis, so severe osteoarthritis, she should become all right. She may not need a spine, but of course we need to tell her that she may need further treatment if she gets low back pain. Another case of a lady, she presented with groin pain. So this groin pain can be a bit tricky in some cases. So here the pain was coming from the gluteal region going to the groin. And she had difficulty in walking and stiffness around the hip joint. And this was the X-ray. She has been taking multiple consultations and treatment. She finished Ayurvedic treatment, everything for hip pain. And this is the osteoarthritic hip, what she had. So on detailed clinical examination and evaluation, we thought that her problem is not arising from hip. Probably it is from the spine. So we took a X-ray of spine that showed a destruction of L3 and what is called classically winking owl sign. The pedicle of L3 is missing and it is suggestive of pathological fracture. So we did MRI. MRI showed a pathological fracture of L3 vertebra and myeloma, suggestive of multiple myeloma. So this case we treat the myeloma and may not need surgical treatment for this pathological fracture. So she became all right and her hip pain also disappeared. It did not need any other treatment for hip pain. So these are the complex cases of hip spine syndromes. So in complex case, we need to identify both the pathologies and discuss with the patient that the primary one pathology is giving the symptoms and treat that pathology, and usually that is sufficient. Coming to the dual pathologies or secondary hip spine syndromes, here both are symptomatic. Both hip is symptomatic, hip and spine are symptomatic. Usually such patients will have neurological symptoms or radicular symptoms. So when there is compression, neural compression, we need to address the spine also. So concurrent treatment may be required, and whenever the patient has neurological deficit, that will come in way of rehabilitation. So Dr. Yogesh says we need to mobilize the patient on day 1 or day 2. So when the patient has got a foot drop or any neurological deficit, it is not possible. So it comes in way of his calculations. So this is a case of a 61-year gentleman who came with the end-stage renal disease. He was on hemodialysis thrice a week, he presented with hip pain, and he has been treating for, they can treat a lot of many treatment for hip pain. Hip is obviously very bad, and we can see a lot of osteophytes, and the joint is totally distracted, and he is having difficulty in getting up and sitting position. Why he came to me? He came to me because 5 years back I had operated him for spondylodiscitis. It was pyogenic spondylodiscitis of MRSA, so I had operated 5 years back. So he came to me for this hip pain. So I thought I will take X-ray of back to see what happened to his surgery, what we did. He had a L3-4 spondylodiscitis, and we were suspecting pyogenic spondylodiscitis, so we did only anteriorly and did an anterior lumbar fusion with a large iliac crest graft that was very well fused. And I examined, because I happen to be a spine surgeon, so I examined spine in detail and thought he has some other problem in the spine other than this old fusion. So I asked for MRI. So the MRI shows another level spondylodiscitis at L2-3. So when a patient has L2-3 pathology, it presses on the L3 root. L3 root comes anterior to the hip, so the patient has got anterior radiation and more of unilateral hip pain. So he was presenting as a hip problem in the pain in the groin because of the L2-3 spondylodiscitis. So this is a dual pathology. We need to address the spondylodiscitis first because it is infective pathology, and previously he had MRSA. Probably this also is MRSA or maybe something else. So we need to treat that first. So we treat the infective focus first and make sure that his all the parameters are all right before we venture into a treatment of osteoarthritis of the hip. Otherwise, going ahead with a hip replacement in a osteomyelitis or a spondylodiscitis, it is a disaster. So in secondary hip syndrome, we need to evaluate both the pathologies. We need to discuss with the patient that which is most probably the most symptomatic pathology, and address that pathology and tell them that once you are all right with your primary treatment, you need to go back and take the treatment for the other pathology also. As a rule of thumb, whenever there is neurological deficit or impending neurological threat, so see, patient is not having a great neurological deficit now, but if you leave it alone, he will become paraplegic. So such cases, we need to go ahead and treat the spine first. Otherwise, we treat the limbs first. Usually we treat, if there is no neurological deficit, we ask Dr. Yogesh or his team to go ahead with their procedures, and we go inside the OT, or later we do some epidural injection or transforaminal blocks or a facet blocks. So definitely we need to discuss with the patient and tell them that later date we need to address the other pathology. Otherwise, patient will not be happy. They will tell IV underwent THR, but he is not still having pain because his pain is coming from spine. So otherwise we treat something like TLIF in spine. Patient will not be able to walk. So we need to tell them that you need another TKR or THR later on. So coming to misdiagnosis. Many times we all miss some cases because of unusual presentations, a rare disease, and unclear clinical signs. So we do sometimes miss these pathologies because we are more focusing on our specialty. So I see in detail spine, but don't see the other joints so in detail. So sometimes we tend to leading to misdiagnosed case of hip spine syndrome, and sometimes this imaging also are misleading. So this is a case of a young lady. She had back pain and gluteal pain for more than 6 months. She has tried all conservative therapy, treatment, Ayurveda, massage. She has underwent panchakarma, everything, but she is not better with the hip pain and radiation pain. MRI they did. The MRI showed a disc protrusion at L4-5. For this, she underwent epidural steroid injection, but not better. So 6 months, same pain, not improved with any treatment. She came for disc surgery. So when I examined, somehow her treatment, her clinical picture is not correlating to the MRI findings. So there is no disc to remove it. So we thought that this is not the pathology, because in spite of epidural steroid injection, she is not better from day one. So we evaluated her further, referred to Yogesh, and he did MRI of the hip shows femoroacetabular impingement. I think he remembers the patient. She's a medical student or a doctor. She has passed. So it was a femoroacetabular impingement. I could not diagnose. Yogesh could. So it is always better to have a combined approach for a comprehensive treatment of these pathologies. So because spine and lower limbs are interconnected, and we need a comprehensive approach for a better outcome of the patient. Thank you.
Thank you, Ishwar, for giving us detailed information about this confusion about spine or lower limb problem, which patient will come, and we also have many times difficulty in diagnosis. My question is hypothetical. If a patient requires surgery for spine and for lower limb, which one to be done first?
Sir, if patient is having normal neurology, we go with lower limb first. So if patient has got any neurological deficit, or we think that if we are leaving that disc or a canal stenosis lead to a major neurological deficit, then we go ahead with do decompression and stabilization or whatever it is required. Then we refer the patient to other lower limb surgeries. And if it is lower limb surgeries once done, we usually don't touch the patient for another 3 months or 6 months. We need to assess them. We need to see how their rehabilitation and the joint is functioning well. Then after that, because sometimes the biomechanics of spine changes. So we don't know. In the beginning, I may think that this patient with spondylolisthesis and hip arthrosis or knee arthrosis needs a fusion at degenerative listhesis. Maybe after their joint procedure, sometimes they become asymptomatic. So we may not need a surgical treatment. So we need give a time of around 3 to 6 months to reassess and then decide whether they need spine surgery.
Okay, thank you.
Thank you, doctor. That was very nice, very informative. I would just want to ask, like, when now they say sitting is the new tobacco. So can you tell, like, if we can avoid like the problems that can come, like, is it sitting for a prolonged period and all? Can we exacerbate, or can we prevent this backache and the complications that occur with it?
Yeah, that is right. They say that sitting is new smoking. So it's always better to sit in a right posture when we sit for long hours rather than bad posture. And of course, usually I tell my patients that they slouch when they sit because their core is weak. A patient whose core is strong, they would like to sit straight. So the patient, if he is comfortable in a bad posture, that means their core is weak. So strengthen the core, automatically our sitting posture will improve. So the concentrate is more on not on the time of duration of sitting, it is about the strengthening of the core muscles.
Sit here, I have to say something. Actually, I have not understood why I've been called and what I'm supposed to do. Anyway, many a time, frankly, from surgery OPD we sent to orthopedics, not with a great diagnosis of what orthopedic problem you might be having. We can't really say, I don't know what to do with you. So instead of saying that, we say it might be related to spine and all. Occasionally, we do have some sort of, we can always make out this is not general surgical. What else it is, we are not always sure. The groin pain, if I have just noting, so many things can cause groin pain. Like one of the things which you don't want to see is a post hernia repair, groin pain and all, which is a problem by itself. Funiculitis or some anything at all, any inflammation or ischemia of iliacs and all. But they are almost never related to movement of the back or something. It will have other triggers, food or walking, or you can prove it by doing urine routine and all that. Most of the time, when we say send the patient to orthopedics, all we say no is that it is not general surgical. But it's good to know that there are so many things which are there, which are lurking there, which may be more important than trying to treat a non-specific this thing. What I urge people is sometimes knowing that I don't know is itself is knowledge. So you have to send it to somebody who might know. That's what I try to do.
Sir, that's exactly the reason we wanted you here, because you remember. I wanted to say this before your comment, but remember we have actually had patients where we've shared. We've had one varicocele who presented as a hip impingement. We've had an inguinal hernia once, and there was also this called the sportsman's groin, which again went to our physiotherapist or practitioner, Dr. Bishwa. But it was nice having those discussions, because a large part of groin pain can be confused with hip impingement, which we're getting referrals for regularly. So having you next to us does give us support.
I tend to believe when the patient has come to us, especially if he has chosen to come to Jyoti, he must be having a problem. Nobody wanders into Jyoti.
Thank you very much for that session, sir. Can I ask the chairpersons to give Dr. Ishwar, our speaker, a token of appreciation, and Dr. Bhaskar, sir, to then provide the chairpersons with a token of appreciation. Dr. Malleshappa is here. Dr. Malleshappa. Yes, sir. Please, would you mind giving a token of appreciation to Dr. Bhaskar? Thank you. Thank you, sir. Now for the next session, nobody likes it, but everybody's got it. If everybody hasn't got it, we know somebody who's got it. Diabetes. It is becoming bigger and worse. We have got Dr. Srinath, who will be talking to us in diabetes in relation to joints. I'm glad to have Dr. Arun, my close friend and managing physician, Dr. Arun S. on stage as one of the chairpersons. Again, our physician, Dr. Prakash Harish. I have known sir for some time. Sir is also active on the KPME site regulating us. So nice to have you, sir. And Dr. Ramanand Rao, sir. Sir practices in Urva, so sir is a friend and neighbor too. Thank you very much, sir. To moderate, I'd like to have Dr. Pawan. Again, one of our able physicians and friends. One of the fittest doctors we know in our group. If he is not in the OPD, you'll see him running 10 to 20 kilometers. He's a mark for us all to follow. Now, Srinath is a close friend and, of course, our close trusted endocrinologist. We are lucky to have him where we can get difficult diabetes is, of course, the end of the spectrum, but he manages so many other things in relation to hormone-related problems. So just to illustrate diabetes, I'd like to put up this case. Now, this is one of our colleagues' fathers who had a joint replacement, an arthritis, simple, straightforward joint replacement. His HbA1c was 11 to start with. So we said it is not a good thing to manage a joint replacement, even though he had a lot of pain and disability from the joint. The surgery went straight forward. As you can see, Srinath had controlled the diabetes. We had got it down to, the HbA1c was actually got down to less than 8, and the best control it could have been. But there are times when this disease is bad, it gets ridiculously out of control despite sugars being controlled. So that was a straightforward joint, mobilized very well, very happy, went home, removed stitches 2 weeks later, and for some reason he got into some massage. I don't know whether that massage on the top could have irritated a wound which was already healed. But unfortunately, a few weeks later, about 4 weeks, 5 weeks after surgery, presented with some part of the wound getting dehiscent. Then went on, he did get initial antibiotics, even though he was walking around well. He developed some UTI where the sugars at that point, HbA1c gives us a control over 2-3 months, but the sugars do go ping pong. That went on to get to a discharging sinus. The initial aspirate had all come negative. We aspirated again after the UTI. So this could not have been an acquired infection from the site of the surgical wound. It must have been a hematogenous infection. So, I mean, such are the nightmares that despite control, this disease is so reckless that it can go up and down. This is somebody who is the father of a colleague, so you can't say diabetes treatment was nearly negligent. It is the disease. So eventually that sinus, once you have a sinus, you know it is not going to get better. We had to go on. You could see the metal getting loose eventually, because initially it was not something which was salvaged. It was salvageable in the sense it was a wound which was not a direct contamination from theater. It was gram negative, and it probably came from the UTI is what we think, but eventually had to go on to a 2-stage revision. I mean, of course, his diabetes was doing ping pong. All we can say is more vigilant than before, but such is the disease. I'll ask Srinath to enlighten us more. Thank you.
Good afternoon, everyone. Hope I'm audible. So, as Sir rightly pointed out, diabetes and knee, that is osteoarthritis, they're a common combination. And many a times, these patients, because of poor mobility, you see that the HbA1c is climbing serially over time. The more time you give, the HbA1c actually goes up. So, at such time, you may have to, if the patient is on oral tablet, you need to switch up to insulin, get a good glycemic control. And whenever we talk about HbA1c, someone who has 12 and we got it somewhere 7 or 8, that 3 months is not enough. Usually we are talking about last 2 to 5 years of HbA1c. Usually they have a poor vasculature, so the wound healing is poor. They are more prone for infection. But it's always good to give certain amount of time to get a good control and then plan a surgery. So it's you have to balance the time and surgery. So, sir gave me this topic, so I could just think about one thing, that is diabetes and osteoarthritis. But then I started thinking there are more diseases that we can discuss. So, mainly you can discuss in 3 categories. One is the soft tissue involvement in diabetes and involvement of joint, then the joint disease as such, and then the skeletal disorders that are seen with diabetes. So, coming to soft tissue in proliferatory disorders, you have the frozen shoulder. Many of them actually go to the orthopedicians first and then diagnosed to have diabetes, and then they come to us. Then you have trigger finger, chirioarthropathy. Chirioarthropathy, many of them go to rheumatologist. I am sure our colleagues will also say the same. And then they come to us. And then carpal tunnel syndrome, they either go to ortho or neuro and then refer to us. And coming to joint disease, you have osteoarthritis, which shares the major chunk of patients, but the other involvement, that is Charcot's disease and also infective joints, are part of it. Coming to skeletal disorders, diabetes increases fractures and also worsens the healing capacity. And you have other disorders like DISH, which can present have atypical presentations. So we have to keep all these things in mind. So what is the relationship with diabetes and bone? The main thing is, when you have diabetes, you have neuropathy, poor mobility, poor joint strength. So you see more injuries, because of which they go to the orthoper. When there's an orthopedic problem, their mobility is less, so sugar also goes up. So it is interrelated. And many a times we end up giving NSAIDs and steroids, which also interfere with therapy. So coming to diabetic keratoarthropathy. So diabetic keratoarthropathy can be seen more commonly in diabetic, but it's also seen in general population also, more common in type 2 because the absolute numbers matter. It involves the contractures of the proximal interphalangeal joint and metacarpophalangeal joint. First, the ring finger is involved, and how do you find out whether this is a keratoarthropathy or not? One is, there is no signs of inflammation, so the synovium is preserved. Many a time you may think it's a systemic sclerosis, so you don't have Raynaud's phenomena here. Pain is usually less. Mild pain because of restriction could be there. And then you look at sign. So this is the classical prayer sign. So normally when you do the prayer sign, there is no gap in between, but in these patients you see a gap. Then you have the table sign. So if you rest the hand on the table, you're not supposed to see a gap, what you're seeing here. This is a normal table sign. So what do you do? Is it important? So one is, glycemic control is very important. And this disorder is also associated with other soft tissue problems, that is Dupuytren's contracture, frozen shoulder, etc. And there is an association. In type 1s, if you see these disorders, they have more likely microvascular disease and macrovascular disease in type 2. Treatment is physiotherapy, glycemic control, and steroids sometimes can be useful. Coming to frozen shoulder. So this is our most common interactions with diabetes, with the orthopedicians. And you have, not all patients with frozen shoulder are diabetics. You see some pre-diabetic, you see some non-diabetic, but very common with diabetes. And if it's bilateral, it is more likely that the patient is diabetic. They have 3 phases. So our previous textbooks used to say that you see 3 phases within a span of 6 months. The first phase is the painful phase. The second phase is where there is restriction, pain is gone. And that's where physiotherapy helps. If you do proper physiotherapy, you can have a good movement. If not, then you land third phase where you have resolution and the shoulder is stuck. You can't, the patient finds it difficult to take bath. So if you do a imaging, you see that the capsule is thickened and the joint is contracted. The volume of the joint itself is less. And the main treatment is physiotherapy and NSAIDs initially. Glycemic control plays a role to prevent the next frozen shoulder. So if you don't take enough care, the next joint also may be involved. And sometimes we give intralesional steroids. And if these don't work, then manipulation under general anesthesia, which is commonly done. Coming to trigger finger. So this again is common in diabetics and sometimes in patients who are into manual laborer thing when they use instruments that vibrate a lot. So here the flexor tendon sheath, it becomes more fibrous and there's a nodule which prevents the sliding of the flexor tendon. So it commonly involves the ring finger first. Some people have a clicking sound and normally you see this kind of trigger finger which suddenly gives away. Patient may have slight discomfort and the prevalence is almost 4 times in diabetics compared to non-diabetics. So treatment is usually good glycemic control, sometimes steroids and sometimes surgery if it doesn't resolve. And if you don't control sugars in time, you see that it spreads to the neighboring fingers also. Coming to osteoporosis and fracture. So osteoporosis is where the bone quality is not up to the mark. Your bone mineral density is less. Majorly impacts the women, then men. And this is what happens. So normal bone is porous, but it is much more porous in the diabetic or osteoporotic bone. In diabetes, this osteoporosis is much more common than general population. And the joints that are involved are little different from the general population. So it's either the proximal humerus, the wrist and foot, and the vertebra. So wrist, foot, and humerus are more common. In type 1 diabetes, what the reason why you see fractures are because these patients tend to have low bone mineral density to begin with. So when you're diagnosing a patient with type 1, he already has low mineral density. Adding to that, you see that he has got neuropathy, he has a risk of fall, and that's why you see fractures. In type 2, the BMD is actually preserved because these people are insulin resistant, insulin levels are high, so the BMD is preserved. But the problem is in the quality. They have a very poor quality of bone because they have more glycosaminoglycans deposited in the bone. So you have a falsely high BMD. Again, there are some drugs like pioglitazone which can increase fractures, canagliflozin which can increase fractures. So these add to more problems. Hip fracture is more common in type 2 than type 1. So risk factors for osteoporotic fractures are: one is duration of diabetes, glycemic control, beta cell failure. So type 1s have more fractures than type 2. Sarcopenia, neuropathy, vision impairment, hypoglycemia, and use of thiazolidines. So now there are a lot of talks on sarcopenia. So one of the most important thing to preserve bone mass is to have a good muscle. So if you're not maintaining that muscle quantity or quality, the fracture risk is much more. So once you have these problems, you have increased risk of falling and fracture. So how do you assess? You do a BMD. So bone mineral density scan is nothing but an X-ray, but it is two-dimensional X-ray. So that gives us a volume. And this is how the report looks like. So we get something called T-score and a Z-score. T-score is used when the patient is more than 50 years, and Z-score if it's younger than 50 years. And this is how we classify. If the T-score is between -1 to -2.5, it is low bone mass. And if it's more than -2.5, you have osteoporosis. Treatment is a separate part. I'm not going to discuss that. Then you have Charcot's arthropathy. So the thing about Charcot arthropathy, how many of you think that it's very common? How many of you think it is very uncommon? So it's much common than what we all think. In fact, not diagnosed. In fact, first when I came and I told there's a Charcot's foot, someone told, is it syphilis? So our classical teaching is that Charcot's foot is with syphilis. But right now we don't have syphilis cases that much, so we see it more with diabetes. So there are different stages. So stage 1 onwards, you start seeing the differences in X-ray, and stage 3 is the cold phase where the joint destruction and structural abnormalities have happened, and now it's a stable phase. So there are different theories. One theory is that these people have neuropathy, so they have small trauma, and these cause microfractures, and this causes change in the foot architecture. The other theory is that these people have vasodilatation, AV shunting, so the bone is much more metabolically active compared to a normal bone. So you have more bone absorption, resorption, and deposition. So that's why you see this. The other thing is the inflammatory theory, the TNF alpha, platelet derived factor, these play a factor in Charcot's. So the common problem joints that are involved are the metatarsophalangeal joints. So here you see that fracture dislocation. This is a normal foot. So when the talonavicular joint are involved, you see that they have a rocker bottom foot. So this is seen in very poorly controlled diabetes. If this is picked up in the right time, you can actually prevent these disorders. We'll come to that later. So this is what is rocker bottom foot. And one of the thing is why we miss is because we don't think about it. So many of the patients, they come with leg swelling, single leg, bilateral. So we think it's cellulitis. So, and we rub it off as cellulitis and give antibiotics, you may miss it. So how do you decide? So cellulitis will have fever, local rise of temperature, the skin overlying the place will be reddish, These things will not be there in Charcot. Charcot, there may be slight local rise in temperature of 1 degree centigrade, but not more than that. Then X-ray. So in cellulitis, your X-ray should not be involved. There won't be any changes, but in Charcots, you will see X-ray changes. In a fracture, you will again see X-ray changes, but you will not have fever and other signs. So in such Charcots, you will see that the HbA1c has been more than 9, and there is no history of trauma. Treatment, acute Charcot is immobilization and bisphosphonate. So bisphosphonate do a very good job, but you have to pick it up in the right time. Chronic Charcots, we do offloading. So basically, it's a rocker bottom foot. The pressure falls on that pressure point, so you have to avoid the pressure point. So you either use a total contact cast or the air walker. So this is where again our ortho guys come into the picture. Coming to the osteoarthritis. So I think this has been discussed a lot. So mainly I want to focus that obesity, diabetes, both of them cause increased osteoarthritis. But diabetes on its own, if you remove the factor of obesity itself, can increase osteoarthritis. So good glycemic control is very important. There are modifiable factors, non-modifiable risk factors. Modifiable is more important: body weight, occupation, and inflammation. So if there's a background rheumatoid arthritis or any other kind of inflammation going on, the osteoarthritis chances are more. That's where diabetes also comes in, because obese patients are pro-inflammatory. That's why you see more osteoarthritis. Treatment, I don't have to tell. Main is glycemic control when it comes to diabetes. Then plan physiotherapy, NSAIDs, and surgery. So I'm coming to the end of my presentation almost. So the other disorders that are commonly seen with diabetes are rheumatoid arthritis. So rheumatoid arthritis increases the risk of diabetes, and the prevalence also is higher in patients with diabetes, almost double in patients with rheumatoid arthritis. Then hyperuricemia also is a common factor with diabetes. So you have to manage both well. And I'm sure my next presenter will be talking more on it. I have two cases to discuss before I end. So first is a 45-year-old gentleman who comes with 2 weeks history of pain and stiffness in bilateral heels. So this was restricted only to heels, not his no other joints involved. So what's the probable DD? So normally when patients come to us like this, all the DDs come into the picture: osteoarthritis, plantar fasciitis, hyperuricemia, rheumatoid arthritis. Rheumatoid arthritis usually see other joint involvement, especially small joint hands, which is not here. Hyperuricemia, again, you see the first metatarsophalangeal joint involvement, which is not seen. Plantar fasciitis is the most common here, a single, only heel involvement. So very common in diabetics and obese individuals. So usually it's seen in 4th to 5th decade. Most important factor is improper footwear. Footwear with heels, footwear which are hard, obesity, sedentary life, poor muscle tone. These are the reasons why you get a plantar fascia. You have calcium deposition here. So treatment is basically NSAIDs, footwear, sometimes steroids, intra-lesional steroids, and rarely you go for a surgery. Next patient, 55-year-old lady, presents with back pain. This is a thoracic pain. Most of us come with the lumbar back pain, and there's no history of fracture, trauma. What's the differential diagnosis? So whenever patient comes with back pain, most common is a mechanical back pain, and sometimes you have to think of inflammatory. So that's why I put the X-ray to make it easy. So vertebral fractures are ruled out because the vertebral height is preserved. Sclerotic bone disease, usually you see sclerosis of the bone, which is not seen here again. So you're left with two. For spondyloarthritis, I think Dr. Sajjan should tell more. You will have inflammatory markers positive. There may be other symptoms. Whereas this is DISH. This is diffuse idiopathic skeletal hyperosteosis. Basically, it is a enthesitis kind of thing. Here, the places where the ligament is inserting into the vertebra, there you see inflammation and calcium deposit. So normally you see the flowing osteophytes here, which are bridging the two vertebrae on the right side. And here you see calcification of the anterior ligament. So these patients can be picked up accidentally. Some people come with vague back pain. Some people can, atypical, so minor trauma. So this treatment is usually conservative, physiotherapy, stretch exercise. Yeah, thank you.
Thank you, Srinath, for a comprehensive talk on diabetes and joints. We always had a feeling that what's that new in diabetes, and you had told us so many learning points that diabetes can be associated with so many joint disorders. So I just wanted to ask, you had put up that pioglitazone is usually associated with osteoporosis. Do we need to screen those people with osteoporosis? Do we need to look whether they have those people who are put on pioglitazone? Do we need to screen them for osteoporosis regularly? And if at all, by how should we screen them?
So guidelines wise, there is no change in osteoporosis screening for patients on pioglitazone. But anyone who has had an osteoporotic fracture, a postmenopausal woman who is at high risk of fall, so that's where you probably have to screen and avoid pioglitazone if possible. Otherwise, routinely, it's okay.
Thank you, Dr. Srinath. It was lucid, clear presentation. With how early into diabetes can we see the features of Charcot's joints?
So normally Charcot's joints we see beyond 5 years of diagnosis, but we can see it as early as first or second year also in very uncontrolled diabetes. As we know, different patients with diabetes have different complications. So if they have more of an autonomic problem, then these patients come early with Charcot.
Is it not? I mean, there is a thought process that whether frozen shoulder affects one side, it's not going to affect the other side. Is it true, or it can affect one? And another thing is, are there any other joints in diabetes per se which go through the similar like mechanism of disability, like as we see in frozen shoulder?
So if it's a non-diabetic, usually it's a single joint. But in a diabetic, you see that he has poor glycemic control. He has one frozen shoulder. After 2-3 months, he has the other shoulder also involved, and now he can't take bath. He has to take shower. He can't lift the mug. So in diabetic, bilateral involvement is very common. Like frozen shoulder, there's a frozen knee. But it's not very classically seen in diabetes. It's also seen because of sports injury and other things. That is one more that could be there.
Does intra-articular injections, when you give intra-articular injection, does the sugars rise after intra-articular injections?
Ideally, no. These are all intralesional steroids and they don't enter the circulation. So it doesn't usually cause problem. But glycemic control should be good because if you give these intra-articular injections when the sugars are high, there can be a chance of intra-articular infection.
Audience has any more questions? Can ask. Otherwise, thank you, Srinath, once again for the wonderful session.
Thank you. Thank you very much. Can I ask, call upon the chairpersons to give a token of appreciation to our speaker, Dr. Srinath, and Dr. Pavan to give tokens of appreciations to the chairpersons as well. Can I call upon Dr. Patrick to give Dr. Pavan, our chairperson, our moderator, the token of appreciation? Thank you for the wonderful session, gentlemen. Thank you. Next is a very demanding topic from very, very clever doctors. We all know there are a lot of diagnostic problems, and as is jokingly said, a neurologist diagnoses things which nobody can treat, but a rheumatologist treats things which nobody can diagnose. So we are lucky to have a few and really good rheumatologists among us. So Sajjan, I relate with him for quite some time now. He's going to talk to us on atypical rheumatoid. Rheumatoid is getting so common that, a lot of us can really identify joints which are many joints, painfully hot and swollen. But the range of these diseases is so vast, and treatments getting better with so many new realizations that the more about whatever we say about it, the knowledge is most rapidly expanding in this field. Can I call upon the chairpersons, Dr. Gangaratna, my colleague and friend. She is one of our consultant rheumatologists. Dr. Shivraj, it's a pleasure to have you here. If you can occupy the chair for me. And Dr. Bhaskar, sir, if you don't mind, representing the orthopedicians along with the chairpersons. Thank you, sir. To moderate the session, thank you, sir. I'd like to call upon Dr. Pratyusha. It's lovely to see so many intelligent, clever rheumatologists among us. Now, to demonstrate a case for Dr. Sajjan, we've gone back a long way. We have presented and published a series where we have, with changing guidelines, continued DMARDs during joint replacements and have documented good results. Let me just show you this play the video. So this is a guy who I had seen. You can see sitting down, he looks normal. Make him get up and walk. Can you imagine? This guy is 28 years old. That is his X-ray. If you play the video of the X-ray, you can see he has continuous bone. He has movement at his knee, and the next movement he has is up in the neck. So he spent 12 years of his life. He was not able to look forward when he was walking. So bad is the disease which attacked him at a stage when he was 14 years old. That was his spine, what we call the classical bamboo spine. Unfortunately, awareness and treatment 10 years ago was not good. When he presented to us, he was already thinking, okay, hip replacement. I want you to do the hip replacement. I'm ready to get admitted tomorrow. But what we realized is when we did his evaluation, we saw that, of course, there's no doubt that a hip replacement will help him, though it is a very complicated procedure. There's no doubt in him because it's continuous bone, and he had a flexion deformity of over 90 degrees. You can see that. The pelvis is fixed as well, so it's by no means a simple undertaking. The issue here, however, is teamwork is still required, not only from the surgical side. We saw his inflammatory markers and the CRP, despite having continuous bone there, his CRP was something like 21, so it was not normal. I was scared doing a big procedure, a joint replacement, which is not even a primary joint replacement, may give him some flare-up. What if his other knee or other hip gets fused with the flare-up? In his spine, he had movement only at C1, C2. What if he has a flare-up and that gets fixed as well? What are we going to leave him with? We convinced him he was on traditional DMARDs. He was on methotrexate, and he was feeling okay. But clearly his CRP was not okay. We managed to convince him to somehow, he had gathered money for hip replacement. We managed to convince him to buy some biologics to tide over the perioperative period. So he agreed to take biologics for about 4 months. And we said, no joint replacement for you. At least we are not doing it for the first 2 to 3 months. He comes back 2 months later. His hip disease obviously was fixed, but he says, subjectively, I'm feeling better. We then did the hip replacement, and that was him walking before. He sends us all these videos. Please play the videos for me, Chandan. So that's him somewhere in the Middle East. You can see he can't look forward when he's walking. And that's about a year or so after surgery. Play that video. And that's him immediately after surgery. And, you know, he puts it up. Now he's able to look forward and walk. That was the young years of his life. This was the time when he was fixed. And now, you know, he leads, he drives his own car. He runs his own business. The icing on the cake is, it's been now 4 or 5 years since we've done the operation. He has managed the money. He still continues the DMARTs with Sajjan. Biologics, sorry. Yes, I hand over to Sajjan.
I'll rob you of the mic, just like how we rob all the secondary osteoarthritis from them. By giving DMARTs, we just rob them of those patients, right? So we'll rob one mic also from you. Okay, so is it that we press this and it works? How does it work? So I've been given a topic about atypical inflammatory arthritis. Now, technically speaking, there is no such term as atypical inflammatory arthritis. It is atypical presentations of common inflammatory arthritis, right? So before we start the discussion, I would assume that everybody knows the differentiation between an inflammatory and a non-inflammatory arthritis, because that is primarily the basic question which every patient should be put through before we even think of evaluating such a patient. So an inflammatory arthritis is where there is a synovitic process, right? So typically having pain, early morning stiffness, swelling, and then usually destruction over time. So that's a typical inflammatory process. A non-inflammatory process is usually mechanical, like injuries or degeneration with age, in which case we typically have pain which is present usually on loading the joint, which has gel phenomena, which means stiffness lasting for maybe 10 or 15 minutes, and then usually located only in a 1 or 2 joints which are degenerating. Now, having said that, so we go into the uncommon presentations of common inflammatory arthritis. And we know that the most common inflammatory arthritis we deal with is RA. So everybody knows about that. So we'll discuss a couple of points on that. We'll also discuss about the diagnostic clues which you can use in such patients to diagnose whether this is really RA or something else, right? So this is what I'm going to talk for the next 10 or 15 minutes. And then obviously the therapeutic implications, because your diagnosis changes and hence your therapy should also be tailored to that. So we'll go through case 1 because this case will keep recurring. Only the last 2 lines will change. So the case 1 is the prototype case which we'll use throughout our discussion. So case 1, 47-year-old lady who has a 2-year history of right ankle pain. Now in the place of ankle, you can put any other joint for that matter. You can put right knee if you want. You can make it right shoulder, any joint of your choice. Essentially, it's a single joint involvement with no history of trauma, no other systemic symptoms, and no comorbidities, right? And on examination, she has tenderness over the right subtalar joint. So right subtalar joint is usually a medial joint line tenderness or a lateral joint line tenderness, not anterior tenderness. Anterior tenderness is usually ankle, right? So we have tenderness over the right subtalar joint, and somebody got an X-ray done which was essentially looking normal. So this was the X-ray of the right subtalar joint, which is essentially normal. This is even after 2 years of disease or at least symptoms. Then we also got an MRI. MRI shows fluid in the subtalar. This is T1 and this is T2 images, and fluid in the subtalar joint with some amount of tibialis posterior tenosynovitis. So it is very clear that there is an inflammatory process going on which is predominantly inside the joint. The soft tissues look fairly fine, and bone marrow edema, all that indicates that there is an inflammatory process. And the orthopedician thought that we should go for a biopsy, but the patient was unwilling for a biopsy. She basically focused on taking some NSAIDs and time went on. After 1 year, she comes back with worsening of the symptoms, and a repeat MRI now clearly shows destruction of all these bony elements of the joint, which is very clear, right? So you compare this, which is the talus, and you compare this, right? So it's as if the talus is basically going to collapse. and all the joint space loss and cartilage loss and bone destruction is very evident. So at this point, now we are the orthopedicians and the team which is seeing the patient thought that this must be some kind of rheumatological problem, and then they referred the patient to us. So from a clinical standpoint, we have a patient who has no comorbidities having monoarthritis of the right subtalar joint. Now in such situations, often we see that a lot of people would consider this as gout because it is in one joint, it is in the foot. But there are many odd points here. You should understand that gout in a lady is very, very rare, not usually seen. So before we diagnose pregnancy in a urine pregnancy test positive for a man, what precautions you would take before you say that this is pregnancy, the same precautions we'll take before we say that a lady has gout. Okay, so it's that kind of rarity we are talking about. So probably not gout. Second thing, chronic synovitis going on in one joint for years, usually not gout. When we are talking about gout, we look at acute episodes, and if the patient has sufficiently neglected it, it will usually become a oligo or a polyarticular chronic synovitis. But single joint chronic synovitis gout, unlikely. Then obviously the second thing you would consider is an infection. Let's say a tubercular infection, right? A bacterial infection, unlikely, because pyogenic septic arthritis would be more pronounced and much more symptomatic in the initial phases. Likely to be a tubercular, because in our country, TB joints are fairly common. So with these two differentials, we have evaluated further. Obviously, to get this diagnosis that whether it is tubercular or not, you would obviously need a biopsy. But then we always try to prove the point with a non-invasive technique. So that's what we did. So we got a basic investigations, which were normal. Basic means, I mean to say blood counts, liver function and so on. Inflammatory markers are normal. Now this is one very important point we need to note here, that a normal ESR and CRP does not rule out inflammatory arthritis. Do not base your decision purely on inflammatory markers, because inflammatory marker elevation will be seen probably only in about 90 to 93% of inflammatory arthritis patients. Normal ESR CRP does not rule out inflammatory etiology. Then we did our favorites, RF and anti-CCP. I am wondering why nobody else had did this before, because they'll do it even if you have a chronic toothache, we'll do an anti-CCP. So we did that and it was strong positive. What is the definition of strong positive? There's no such accepted definition, but usually we'll take it as more than 2 or 3 times the upper limit of normal. Anything less than 2 times the upper limit of normal, we would probably not consider it as significant. But here it was significant. Now with this much information, can you really say that the patient has rheumatoid arthritis? Can we do that? Right? Now that brings us to the point of this diagnostic criteria. Of course, diagnostic criteria are not meant to be applied in individual patients in the clinic. But if you do look into the ACR criteria for diagnosis of rheumatoid arthritis, this patient will not fulfill the criteria for that. We'll go through the table again. So we convinced the patient to go through a biopsy, and then once we got the biopsy, our main intention was to rule out TB, right? We are not really expecting big surprises here. So once we did that, TB negative, gene expert TB negative, histopathology suggestive of chronic synovitis. So what is the diagnosis you would make here? See, whatever semantics you use, it is ultimately an inflammatory pathology in one single joint with autoantibody positivity double, that is RF and anti-CCP. So our diagnosis would be monoarticular seropositive RA, although there is no such diagnosis in ICD. Okay, so monoarticular seropositive RA, and we treated with methotrexate and hydroxychloroquine with a short course oral prednisolone, and patient had significant relief by 2 months and back on her feet with full activity by 3 to 4 months. And we have then continued DMARDs at a lower dose, just like we would treat any other RA patient. Now the points to note here is that monoarticular RA is a rare entity. You wouldn't usually diagnose it because classic teaching is that there is symmetrical polyarthritis involving small and large joint, none of which was here, right? So it is rare, occurring in only less than 3% of RA patients, and in fact it doesn't even satisfy the criteria. You see, we had one large joint, high positive RA for anti-CCP, which means 3 + 0, 3, normal CRP and ESR 0, and then more than 6 week duration. We are totaling up to what? 4 points? Yeah, right? 4 points. We need 6 to make a diagnosis of RA. So clearly, we are unable to satisfy those authors, but we have to satisfy our patient, right? By giving the appropriate treatment. So don't try to satisfy the criteria because they are not going to be of help to you. So out of this monoarticular, now one argument is that maybe you can wait for evolution, right? Evolution of disease. Evolution of disease is the number one enemy of rheumatologists. Because often we end up eating our own words because the disease evolved later. Like I say that you are diagnosed with RA, and then finally the patient evolved into SLE, and then I have to take back my words and say that no, you had SLE. Right? So that's a difficult situation to be because the disease evolves. So if you think that a monoarticular RA will evolve into polyarthritis and then will catch the diagnosis, it will happen only in 15%. So if you wait for it, you're going to lose 85% of the times. Right? Only stock market is worse than this. Right? So diagnosis is based on positive antibody titers and a synovial biopsy to rule out competing diagnosis. By competing diagnosis, we usually mean infections. We sometimes mean a malignancy, right? And we usually do not mean a degenerative disease. Often we do see degenerative disease in a competing diagnosis, something like, let's say, ochronosis. Ochronosis can present as monoarticular disease, although it's a systemic disease. Patients may present as a hip involvement or a knee involvement, in which case a synovial biopsy, usually before that taking the biopsy, the surgeon knows that this is something odd because the black cartilage and the darkened synovium. So these kind of occasional other competing diagnosis may be there, but usually what we mean is infection. And treatment will remain similar to polyarticular RA. So when there is a monoarticular presentation and it is chronic and you have reasonably ruled out infections, always think of RA because that is the most common inflammatory arthritis you are going to see in the community. Now, let's take exactly the same case, but her RF and anti-CCP are negative. And if you had the time to examine her fully, you found this. So with the exception of the chairpersons and the moderator, we want an answer. Psoriasis. The problem with this is that we routinely miss it. Miss it in the sense we don't really go and ask the patient, and even if you did ask, the patient would say, I have dandruff. Now, dandruff is a common term which the patients would use for seborrheic dermatitis, right? But then have a look. Always make it a point to use that stool which you have given the patient to rotate it and then have a look behind the ears, in the scalp, in the hairline, right? And if required, ask the patient whether you have lesions in the axilla or in the groin or under the breasts. So these are common places where psoriasis would lurk. So this psoriasis and has a negative, okay? So that makes it 3 points. So a score of more than 3 points with inflammatory articular disease. But even if the patient did have personal history of psoriasis, previous history, now maybe not many lesions or adequately treated with the topical therapy, patient may not even report to you unless you ask. So ask whether you have had history of psoriasis, whether you had family history of psoriasis, somebody in the family has had psoriasis. Look at the nails, look at dactylitis. We know what is dactylitis, right? Sausage-shaped digits. So the presence of dactylitis is also one of the features which will favor the diagnosis of psoriatic arthritis, and then of course radiological. Now if the same patient, RF and anti-CCP negative, you looked at the scalp, hand, axillae, groin and everything, all normal, and then after a week or 2 weeks, patient develops this. What is this? Uveitis. What uveitis? Posterior? Intermediate? No, what are the findings? Finding is that we have significant congestion, right? And then what is this? Collection. What is it called? Hypopion, right? Hypopion. Hypopion means there is an inflammation in the anterior compartment. So usually it means an acute anterior uveitis, right? Acute anterior uveitis with monoarthritis. Where are we heading to now? No. RA usually does not involve the anterior segment of the eye, right? It will usually involve the sclera, right? Not usually the anterior segment of the eye. So if anterior segment of the eye is involved, we are looking at the spondyloarthritis spectrum of disorders. Now this patient never complained of backache, so that never flashed to you that spondyloarthritis could be differential because the patient never spoke of a backache. But then we need to understand there is a separate category called as peripheral spondyloarthritis. It is so much, it's like an oxymoron. Peripheral spondyloarthritis, right? Rheumatologists like are crazy fellows in the sense that they tend to contradict themselves. So it's an oxymoronic diagnosis to make, but it's the right diagnosis to make. So peripheral spondyloarthritis. So we see what is the definition of peripheral spondyloarthritis. Our patient obviously had arthritis, no confusion about that. But then from a clinical standpoint, you have to also look at enthesitis and dactylitis. What is enthesitis? Inflammation at the insertion or sometimes the origin, usually the insertion of muscles or ligaments or tendons onto the bones. So one classic enthesitis would be, let's say, tendoachilles enthesitis. Another enthesitis which is usually classical to see is greater trochanteric enthesitis, or let's say tibial tuberosity enthesitis. These are all enthesitic manifestations, not arthritic manifestations. So if you do have that, that's also one of the parts. And dactylitis, which is a swollen digit or a sausage digit, plus one of these. Now obviously our patient had psoriasis. So the right diagnosis would be peripheral spondyloarthritis with psoriasis or psoriatic arthritis. Peripheral spondyloarthropathy with psoriasis. Or if the patient had history or active inflammatory bowel disease, ask for it, right? Whether you had abdomen pain, loose stools, hematoschizia, have you been diagnosed with inflammatory bowel disorders? Has a colonoscopy ever been done? Patient may not even remember that because that might have been a remote event like 8-10 years ago. So unless you ask, they will not usually volunteer. Preceding infection, why are we asking that? Preceding infection, reactive arthropathies, right? That also comes under the same group. HLA-B27. Now, whether you should really do HLA-B27 in a peripheral monoarthritis, I will leave it to judgment. But if you do find something else, then maybe it's worthwhile to do HLA-B27. Uveitis, we just discussed that. Sacroiliitis on imaging or radiographs. Even though the patient may not have complained to you, it may be worthwhile getting an X-ray at least, if not a MRI. If you don't have any one of these, you can have two of these also. Anyway, we just want to drive in the point that in any patient with a mono or a oligoarticular presentation, who usually will end up with an orthopedician, ask for psoriasis, uveitis, inflammatory bowel disorders, and preceding infection. These four things you should not miss. No amount of other evaluation or investigation is going to prove this. It is a pure clinical diagnosis. So this is. Now we'll go to slightly rarer things. Okay, same patient, RF anti-CP negative, has this and has this. And genital ulcer I have not put up because no fun in seeing. Molluscum is wrong. How molluscum is going to cause chronic synovitis? Yeah. So molluscum it's not even a molluscum lesion actually. It's a furunculosis, let's put it that way. And if you cultured it, it wouldn't grow anything. Further clues. So we have oral ulcers, genital ulcers, non-infectious furunculosis or pustulosis with chronic synovitis. Anything? Right? So this is a rarer diagnosis, right? Rarer presentation. Behçet's disease. Behçet's disease. So unless you actively look for it, you're probably going to miss it. I'm not telling that every monoarthritis you see is going to have Behçet's disease, but look for other features because they are going to give you clues. And mind you, Behçet's disease will be all antibody negative. You can do whatever you want. You can do ANA, ANCA, Pernio, or whatever you want after this. But then the diagnosis is sarcoid. Again, a clinically oriented, but often they are common diseases. Recognition requires careful clinical history. If you do not ask for psoriasis, IBD and so on, you're going to miss it. And examination with detail to other systems, not just that particular joint, because that joint is probably not going to give you any further information. Antibody tests may be helpful if it turns out to be positive, let's say in RA, but other than that, they are not going to be of great help. Treatment will then be tailored to the individual diagnosis. So psoriasis means you will consider methotrexate, tofacitinib, or some other. If it's a pure spondyloarthropathy, you can consider sulfasalazine or some other intervention. So, and I hope that drives certain points home. Thank you.
Spine and all, and very well educated individuals, in fact. So, and then they're so reluctant to take biologicals and DMARDs. It's very difficult to convince them sometimes. Hopefully, more and more of these CMEs and conferences will bring out awareness of rheumatology. And anything from the chairpersons, anything you'd like to add?
Thank you, Surgeon, for wonderful gist. We are getting busy and busy, but it is always about the history that will give us hope. Thank you for the opportunity, and thank you.
A very wonderful, a very wonderful talk, Dr. Sajjan. So I think I will echo whatever has been already told. And one thing is, whenever we are in a dilemma, we always would like to keep the diagnosis open rather than labeling him or her into RA or spondyloarthritis, because as it's already been mentioned, evolution of the disease is our biggest enemy, and sometimes SLE will become RA, RA will become MCTD, and so on and so forth. So
And we get bad reviews on Google for that.
yeah. So always keep the diagnosis open. We have picked up infections also, which we initially treat like a inflammatory arthritis, and then one lymph node pops up from nowhere, and you find the entire picture to be a TB, which you were treating like an inflammatory arthritis. So I think that is one message we need to drive on.
Thank you. Thank you for the session. Can I call upon Dr. Bhaskar, sir, and the other chairpersons to give a token of appreciation to Dr. Sajjan? And if Dr. Pratyusha can give tokens of appreciation to Dr. Gangaratna and Dr. Shivraj. Can I ask Dr. Sachin, if you can come in, give a token of appreciation to Dr. Pratyusha for moderating the session. Thank you. Next, we have a slightly different panel. Thank you very much for that session. We have often cases where, obviously, for requiring surgery, I'd like to call upon Dr. Anand Venugopal. Dr. Anand Venugopal has been our medical superintendent. To me, he's been quite a mentor, recognizing and giving importance to specialties. He's now CEO of our educational cell at Manipal University. Thank you, sir. Dr. Ajit Mahale. Its specialty of interest is musculoskeletal. So he's my portal of call now for whatever. Thank you, Parikshit, for coming here. Rohan, my colleague, is an orthopedic surgeon. He's working with me as associate consultant. Rohan is going to bombard the three radiologists with questions. Dr. Murali Krishna was listed as chairing the session, but you can, please, if you don't mind, you can moderate the session. And I would like you to give your comments at the end from what you see when you get bombarded with questions from the patients. The relationship with Murali Krishna is unique in the sense, sir has his own hospital in Kakinje. It is amazing how you can see he and his team reach out into the absolute remote areas. He is being the first medical practitioner of his kind there, but he's got a whole team of allied people who reach out into the patients, into the wilderness of the Western Ghats, and have been creating miracles there. So, very lucky to have you, sir. I would love to have your comments because we've interacted with many patients and sir's family with MRI and this and that. So, your comments at the end. That's it. I'll hand over to Dr. Rohan.
Thank you, sir. Good afternoon, Chairperson and the moderator. This afternoon, I'll be discussing about 7 to 8 cases, all different scenarios. I'll not be boring you with theoretical aspect of it, but each case will contain a take-home message. So we'll start with the first case. Okay, so our first case would be a middle-aged female who came with complaints of pain, which was gradual in onset, aggravated with activities like climbing stairs and getting up from sitting position, with what she refers to it as instability. She had symptoms of instability while walking. But on clinical examination, she had quite a bit of effusion, features of mild to moderate synovitis with classical PF, patellofemoral crepitus, and no sagittal or coronal instability per se on examination. Now, she was managed conservatively for 3 months before we took this MRI. She was not happy, obviously, with conservative management, like with physiotherapy and exercises and strengthening program. So we got a MRI done. So here is the MRI image, which shows the black. I'll be just briefing you through the MRI. The black area, which is hyperintense, is the bone. You can see a thin gray area margin like this. That's the cartilage surface. Okay, you can see a break in the cartilage here. Okay, that's the trochlear cartilage. And similarly, this is the patella, and you can see an osteochondral lesion here, as in the cartilage is destroyed or damaged. And whatever white you see here is the synovitis. So, even though there are studies which say that MRI underestimates cartilage lesions, it does not matter whether we have a 1.5 Tesla machine, 2 or 3 Tesla MRI machine. All it matters is, it depends on the skill set of the technician who will be willing to change the gantry of the MRI machine while taking specific sections, and thanks to our radiologist who will be willing to take extra time to take extra cut sections, and best in class technique for reproducing images, just like with less money compared to what NASA or SpaceX did, we were able to reach the dark side of the moon. All that mattered was the right amount of skill set and the talent. So this, I think Dr. Anand can very well relate this study, which Dr. Anand and Dr. Yogesh had done a couple of years back, which says that MRI imaging with specific changes, as in 3D DES and 3D trophy, these are fluid sequences, will be able to project a better image, a PD FATSA, where we will be able to find out cartilage lesions, help patient treat and diagnose better. So this was the lesion arthroscopically. You can see a defect in the cartilage surface. This is the underlying bone. The cartilage is worn out. So what we did was a stem cell therapy. We took bone marrow from the patient, centrifuged it, concentrated it, added fibrin glue, and chondrocyte deposition. And over a period of time, with non-weight bearing and with help of our extended scope practitioner, Dr. Bishwa, with rehab and physiotherapy, we'll be able to make him weight bear completely in a period of 2 to 3 months. Okay, so coming on to the second case, a 24-year-old male with twisting injury while playing football came with complaints of instability and subtle amount of joint line tenderness. Now, why I have put this article? Because ACL alone, there is a 40% chance that ACL will be isolated. Most of the time, ACL is almost linked or associated with other injuries, and in 60% of the time, it will be with a meniscal injury. So this was the clinical picture in our OPD. When on examination, you can see an anterior drawer test which is being demonstrated, positive, and a Latchman which is positive. This was his MRI image. We definitely know that ACL is gone. The clinical examination is enough to say that. But why do we need an MRI? To see any other associated lesions or injury in the knee. So this was the tone ACL intra-op, and here you can see the meniscus which has got detached and displaced, which is very unstable to find. There was no tear inside intra-substance, but it was an unstable meniscus which had detached from its position. So along with the ACL reconstruction, we had to do a meniscal repair as well. So moving on to anytime, anywhere, if you have any sort of doubt, you can stop me and ask me any question you want. So moving on to the next case, here is a young guy in his early 30s, a gym trainer with recent onset knee pain while working out. No major trauma. All inspectory findings were normal, but on palpation, he had medial joint line, posteromedial joint line tenderness. So he was managed conservatively for a period of 3 to 4 months, was not happy. So we got an MRI done, which shows medial meniscus. We call this as a ramp lesion or a posterior third lesion. Went in arthroscopically, the meniscus was stable. What you can see here in the arrow mark over here is a fresh bleeding edge. So going back to the basics, meniscus can be divided as a red, white, or a white zone. If it is in the healing area, which is a red area, okay, it has got a high potential to heal on its own. So you need not have to go there and intervene or repair unnecessarily. Same guy, 3 to 4 months down the lane with rehab, is back to his gym activities and is happy now. So moving on to the fourth case. Here is a 25-year-old male, came with a locked knee following twisting injury while playing badminton. You can see he is unable to extend completely, and when he turns, just see, he is not able to extend completely and walk. So he had pain, instability while walking along with the locked knee. So he also had, so this was the second time he has twisted his knee. Firstly, he had a similar episode for which he had undergone a meniscal repair alone. The ACL was found to be intact as reported, and there was a meniscal procedure which was done. Yeah. So we repeated the MRI. Obviously, we are not looking for the ACL because we know it is torn. Looking at the meniscus, whether it shows a subtle meniscal tear or not. There could be a possible meniscal injury in this patient. So we went in. What we see is the meniscus which was repaired had retorn. This is an intra-substance horizontal tear of the meniscus underneath with fraying of the edges. You can see this here, a radial tear as well, where exactly the meniscus was repaired had again torn. So probably in the first incident itself, he might have had a sort of ACL injury which went unnoticed by the surgeon. Okay, so chances of ACL meniscal re-tear is highly noted when there is an associated ACL tear or an undiagnosed ACL injury. So this was the ACL which was reconstructed later on. So this is the reason. If at all there is a meniscal injury even at the very end of it, posterior horn which we say, or the ramp lesion, it is better to go in and repair it. It might cost a lot because one stitch here, there are three types of stitches which we do. I'll just brief through. All inside, inside out, and outside in. If you're going for an all inside technique, one stitch will cost somewhere around 50,000 for the patient. But it will help in the long term, as in preventing an early knee replacement procedure as well. Because if the meniscus was torn at a very young age, unrepaired, chance of him getting arthritis in the next 10 to 15 years is very high. So here is yet another case of a locked knee, okay, where he's a 26-year-old guy, had a twisting injury a year back, okay, presented to us like this. He was diagnosed with a query partial tear elsewhere, was managed conservatively with rehab, and he then got another MRI few months down the lane, was reported as normal, so he neglected his knee for a year or so. Now he came to us with a fresh MRI report saying ACL injury, and this is his presentation. You can see a ideally, we have to see a black spot here where the ACL generally gets attached. Now, if you're seeing hypointense area over here, that means there is either fluid or the ACL is absent. So, what other thing which you can notice here is there is a small slit in the bone which you can see. That is, the ACL had already got avulsed from the lateral tibial spine. So there could be a possible osteochondral lesion as well, or a avulsion fracture, which you can see. So again, thanks to our radiologist, because we were able to get a complementary CT scan as well. Where you can see these two lesions which you can see here, okay, opacities around like a cystic thing, that actually shows the attachment of the ACL remnant which has come out or detached from the bony surface. Change. Okay, so Intra-op, we went in, repaired the ACL, and this is the newly constructed ACL ligament. You want to ask anything, sir?
How do you differentiate single bundle injuries in general? Because clinically, radiologically, when we get a full thickness tear or a partial tear. So clinically, is there any way for you to like single bundle injury? Because most commonly we would report it as a partial tear. So if you want to specifically tell a single bundle injury, how do you clinically assess them?
See, most of the time, even before clinical, history itself gives us half of the answer. If he had a twisting event and the way he has fallen, whether it was a dashboard kind of injury or is it a purely pivoting type of injury, okay, that gives half of the answer. The other thing is, on examination, even if Latchman or anterior drawers is still negative, pivot test might be positive in those patients. And if in doubt, still in doubt, we'll definitely ask you for help.
So we use your shoulders to cry on, number one. And primarily for us, it is entirely clinical. So ACL clinically is either there or not there. So it's a bit like you can either be married, you cannot be married. The other things can be done, but you're not technically married. It's like that. So there's nothing in between. So there is either an ACL or there is no ACL. Theoretically, the one bundle is the Latchman's test. The other bundle is for the pivoting. The important functional bundle is the pivoting bundle. So if you guys see it on MRI, it's usually the anteroposterior bundle, the anterolateral, because the posterolateral bundle, which does the pivoting. Now, sometimes in what we call theoretically partial ACL, one bundle goes. If the pivoting bundle stays, the patient can still do their function. If the pivoting bundle goes, despite seeing it on MRI, they get instability. So the answer for us is whether they have its own history. Do they have instability? Do they not have instability at the end of the day? But then these things, the correlation helps us document it better. Like there are so many times, like he mentioned, where, you know, the dilemma again is for, the practitioners. There's many times meniscal tears reported with arthritis. That is what we had to volunteer. Those are the situations where doing an arthroscopy could make the patient worse. And those are the ones we'll end up with unsatisfied patients. So we need your help in telling us, are they significant? Because clinically they are not. And then we can work it out conservatively. There have been so many situations where the meniscus is a peripheral tear, which is difficult to diagnose on MRI, but the patient has been feeling unstable. So we've gone and we found it, we've repaired it and have them going back to sports.
Last but not least, a 28-year-old male footballer had a twisting event around 2 years back. Neglected his knee. Now came to us after 2 years with an MRI report saying he needs an ACL reconstruction done. So we examined him. He had instability with varus thrust gait. Varus thrust gait as in somebody walks. This is the varus deformity. So every time a person weight bears on his knee, the knee goes this way, inward. There is a thrust which is seen on the medial compartment. So because of this, based purely on the clinical finding, we got an alignment X-ray done, which clearly shows medial shifting of the mechanical axis. Ideally, it should pass from the center of the head through the center of the tibia, through the spine, and passing through the center of the ankle joint. So you can see how well it is medially shifted. This patient also had a ACL injury, so we had to tackle both at the same time, because there are reported cases worldwide that over a period of 10 years, if the deformity is not corrected, there are 80 to 90% chance that the ACL will fail. The newly constructed ACL will fail. So we went in, did an arthroscopic reconstruction as well as a high tibial osteotomy. Now, the titanium screw which you can see is for the ACL reconstruction, and the wedge plate is to correct the angulation. Medial open wedge. So this is post osteotomy, the alignment X-ray, which shows the mechanical axis passing through the center of the knee joint. Dr. Parikshit, you want to add on something?
So here we see the coronal separated images, one and the mid coronal as well as mid sagittal. Basically, this is to help modified curval angle, so that prognosticates the amount of avascular necrosis in the hip. So basically, what happens is the treatment is the teacher. So can we salvage the patient in the early stages? So as a radiologist, what we want to see is what are the upstages. So in this thing, what we see is an articular cartilage as well as the any secondary osteoarthritis, if the head is collapsed or not. In this case, if I have to visually calculate, the curval angle would be around 200, 220. So coronal, if I see probably 130, as well as sag around 80, 90. So I know this is a moderate stage. So stage 2, this is the stage where you clinicians can counsel or do a core decompression. So what I would like to see is there any upstages? So in this articular cartilage is fairly maintained, no much of collapse of the femoral head in this. So probably this is a late stage 2 or early stage 3. Okay.
Anybody has got any questions?
Excellent session by Dr. Rohan Raj. So I just want to add my experience to this, because I am come from very remote area, last village of Dakshina Kannada and first village of Mudigere Taluk, Chikmagaluru. So there entirely different. When I see the heading, that was clinical clinico-radiological correlation. So in our area, it is entirely different. It is different, instead of differential diagnosis, it is a differential treatment. They go to one doctor to the another doctor, another doctor to the another doctor. Final, after ending of medical doctor shopping, then they went for X-ray or any radiological correlation. So it is a very interesting topic. I very happy that Dr. Yogesh Kamath has called me here. He was the one who helped me in diagnosing many knee surgeries, because after taking the X-rays, we used to WhatsApp to him and he used to help us in diagnosing. In our area, there is only one disease which all the people, doctor and the patient, will agree is MI. Because apart from that, there is always an argument between the doctor and the patient, because patient has got their own pathology and physiology to argue with the doctor. So doctor sometimes poor, and medical shopman, auto wala, everybody will agree with this pathology and physiology than our pathology and physiology. So usually this is being a tertiary center, we used to send the patient to the tertiary center for better treatment. It is not possible, because there we try all the treatment, and for diagnosis we send to the tertiary center. I just to put on statistics if you want. In the Mudigere Taluk, there is a Chikmagaluru Taluk, one of the richest Taluk, because of the Kafinad in Hebbagilu. So there only 2 X-rays are there in whole Taluk, apart from government hospital. That all the 2 X-rays we have. So radiological, I have recently come across one case, went for doctor shopping. Finally, when we take X-ray, it was osteosarcoma, 20-year boy. So everybody, starting from massage to panchakarma to treatment to medical shop to everything, everybody has done. Finally, they send for X-ray. So I think this is a wonderful session, and I'm very happy to participate, and very thankful to Anand Venugopal sir, because he has come for both my hospital opening and as a guest. Then another hospital we are starting in Bankal, that is also a Hobli, small village, 30-bedded hospital. So there also my thing is about the diagnosis. In rural area, the diagnosis is the last part. No marks for who has made the diagnosis. The first is treatment, differential diagnosis, pathology, physiology, even the pharmacology also. They know. Finally, patient comes to the doctor with the first degree OA, goes to an Ayurvedic doctor with the second degree OA, go to the physiotherapist with the third degree OA, and he massages. Finally comes to Yogesh Kamath with the fourth degree OA, and normal patient who can be handled with the minimal exercises finally end up in going for a total knee replacement. So this is a pathetic situation. What in the cities and villages there is a lot of differences are there. So this is a very good this one sir interaction. Then another one adding is sometimes if it is a medical cases, finally it ends in a post-mortem diagnosis to the KSEC Medical College. They go for a post-mortem diagnosis. So all the diagnoses are made. SpO2 96 starts, then 2 doctors it comes to 78, then 2 doctors finally comes to 64. Then they come with an ambulance, and you know the terrific road situation from this one highway things are going on. Finally, with the terrific road, ambulance landed up into the KMC with the 30 SpO2 finally die and goes to the KSEC day for post-mortem with this. So, sir, I will take this dayas to plead Dr. Anand Venugopal sir to help us in getting some expert opinion through video calls or through WhatsApp. If you can help us in guiding these, there will be a great help for the people of that rural area.
Sure, sir. Thank you. And actually, what is happening today, the teleradiology part is expanded so much. So it is both a boon and a bane. And definitely, I think from the hospital side, we can have this kind of networking. Nowadays, most of the people are linked anyway, and all of them do teleradiology reporting. And I think in a real-time perspective, I think from your Hoysala scans in Mudigere and your hospital and the proposed one in Bankal, I think we can link all the three into Ambedkar Circle Radiology Department. And Parikshit is specialized in this area. So anything what is required, he can let you know real time, so that primary to secondary to tertiary to your joint replacement can be maybe managed in a better way. Just to highlight one or two things of what the presentation was also. Initially, before Yogesh came, the concentration mainly used to be to cruciates, menisci and collaterals. Nobody used to comment much on the osteochondral and other injuries which many times are missed, and it will impact the overall clinical management outcome of that patient. So in a larger perspective, I think people who are well trained should focus on specific areas so that the correlation between the clinician and the radiologist will help to improve the clinical outcome for the patient. This is my personal suggestion, but thanks Yogesh for the session. I'm no more practicing this anyway, you know that. So I'll give it to Ajit for his comments.
I think the biggest problem we face today is too much of imaging and too many different reports. I want Yogesh to tell me whether we should have some consensus groups which will tell us what is to be reported and what should not be reported. So is that required? Because you get 4 or 5 MRI reports writing different findings. You don't know what actually the patient is having. So we need to have some consensus about this.
So definitely, because, and it satisfies the patient many times. They say, I had an injury to the knee. I got an MRI and the MRI said the ACL is gone. Then 1 month back, 1 month later, I had another MRI. That MRI showed that ACL which was torn has healed. Then again, do you need me to do another MRI? I'm very happy to do. So it's easy to convince patients to have repeat MRIs because we know there is going to be a downside of the MRI. At the end of the day, I tell patients that MRI is a picture. It is like an Aadhaar card picture. So, like the security at the airport keeps looking many times and cannot identify you on the other card picture. Similarly, like that, all MRIs for meniscus and ACL will have about a 15% error. It requires a good technical support to sometimes tilt the gantry or get the right, you can say, detailed cuts and the right sequences. It is not the Tesla weightage of the MRI which is important, but the passion of the person, right from the technician to the person who's reporting it, which is important. And what is again said is, what the brain knows only is what the eye sees. So often in a hurry of reporting, people just like Anand said, report the meniscus and this thing without looking at the other things. If we look closely, it is all there. Luckily, we have the advantage of putting the hand on the patient and talking to the patient. So if us going along with your interpretation, we can have regular meetings, and this is what we have been doing over the last 10 years. And for me, it has been a lot of learning out of those meetings, because today I can look at the MRI, today at the knee MRI I can look, and the report is again confirmatory. And in fact, sometimes what I have not seen, it is important for me to see, because before operating on these cases, it's of medical legal importance that I don't miss out anything. So having that correlation, having those regular meetings cannot be understated, whatever said and done.
The thing is, if there is 4 different machines in your cartilage, what I read recently is there can be 4 different there's an interpretation not only by the radiologist, it's the machines which can show different thickness. So that's a big problem. Even in Europe they are facing now. So you're not sure which is the normal cartilage. So I think we need to have an Indian consensus statement on what is normal cartilage thickness. When should you say it's thinned out? We don't have that in our district. We need to have that. Otherwise, everybody will say this cartilage is. So we need to have some absolute guidelines which will tell every radiologist what he should write and what is important for you all to take the case forward from.
Thank you. Thank you very much. Can I ask the chairpersons to give an appreciation to Rohan for presenting the cases, and Dr. Murali Krishna for presenting a token of appreciation to the chairpersons. Dr. Murali Krishna, sir, if you can give a token of appreciation to the chairpersons. They're all our people. I would like to call upon on stage our dynamic radiology department HOD. This is the man who likes to stay behind and push his department forward, coordinating and making way for more super specialty, carrying on with the tradition. Please. Sir, please. Correction. On to next and important dynamic. Dr. Madhusudan Upadhyay would be privileged to have him talk. Not a senior anesthetist, he is also one of the consultants. Not only, but has also been a mentor, because vast administrative experience in heading our institute, be talking to us on recovery. To first start the chairpersons for his talk, Dr. Ramadas, please. Oh, sir, please. Dr. Ramadas is from Bajagu. Rao. He will be joining us in a minute. Oh, Dr. Sumesh Rao, please. And session we have Dr. Archit Bulur. Dr. Archit Bulur is our dynamic physician and a very dynamic academician. He has really made it great for training with interesting cases at IMA level. I'm sure all of you all know him very well. He will be moderating the session. Now, enhanced recovery, which Dr. Madhusudan will be talking about, is to a large extent, for some reason, not that very well practiced in India. There is still a debate as to why patients need to be starved before surgery. I mean, the concept is that before surgery, somebody needs to be starved for 6 to 8 hours. Whereas we know and we have enough evidence from the world over that you can give them fluids up to 2 hours before surgery. We have been very regularly doing this for about 10 years now, and we've got really well documented data to see on an average 100% of our patients standing up within 24 hours of surgery. This is for joint replacements. This is for sports injuries. That is the average figures on an average every year. We maintain that. It's not us who maintains the data, but we get it from the hospital records and nursing records, so to ensure there is no bias. Of course, we very well know that if they recover soon after surgery, the pain requirement can be multimodal. Of course, it's Dr. Madhusudan's prerogative to talk about that. And eventually, we have better function. So this is, I've just put up this lady because she came up on the papers in 2015 as the first patient in Mangalore who stood up and walked on the day of surgery. And that is her about, I think it was last year, she came and did an event for us at a patient awareness program we had. This is about 9 years after surgery. You see her, she's a senior citizen, both her and her husband that did a dance show for us. So with that, I'll pass over to Dr. Madhusudan. Thank you, sir.
Yogesh. Thanks, Yogesh, for having me here. I'm a little nervous because Archit is moderating the session. We know Archit very well, very good academician, and he has written more books than the patients I have anesthetized in my life. A little bit of an exaggeration. Next time when you write a book, Enhanced Recovery, I will write in that. Okay. Okay. The deal is done. Yeah. Since maybe I've delivered about 250 plus lectures in my lifetime till today, and I have never finished on time. And I don't know why this should be an exception. Therefore, Yogesh has threatened that he would pull me down once my time is up, but my time was 4:15, and I was willing to walk up on stage, but he didn't allow me. Therefore, now he has to sit quiet. Okay, thank you very much, Yogesh. Yeah, as Dr. Yogesh said, enhanced recovery is something which everyone should be practicing, but hasn't taken off the way it should have. Basically, we want the patient to walk out of the hospital as early as possible, starting with wonderful recovery from anesthesia, painless recovery, and the patient has to stand up and walk as early as possible.
whether it is orthopedic surgery or surgical gastro. And finally, as I said, the length of stay should be much less, much acceptable to the management as well as to the patient's relatives. An extra day of admission means extra money spent for the patient. Therefore, when we talk about, basically, we should remember that all this started in the Western world because there has been pressure, strain on the number of beds available, and strain on the finances too when it is insurance based. But I think we are in a stage right now where we have enough evidence to say that enhanced recovery is the thing to practice. I think that is why Yogesh put up wonderful videos during the lunchtime where the enhanced recovery is the sole responsible reason why they recovered so well even later, 2 months, 3 months, 6 months later in their life. We should go ahead and practice that if we deserve any respect for our patients and their recovery. Interestingly, I'm going to talk about the orthopedic surgeries, enhanced recovery in orthopedic surgeries. But interestingly, when Henry Collett talked about enhanced recovery in 1990s, it's not a new thing basically, 1990s. It was for colorectal surgeries. Even today, they haven't been able to define, all the other surgeons haven't been able to define how exactly to go about enhanced recovery because it's the patient comes with a compendium of problems and it's very difficult to tailor make the protocols for each of the patients, each of the disease patterns. Therefore, but in orthopedics, there has been a lot of work done, and especially with the joints, the lower limb joints, there have been a lot of research done, work done. Therefore, orthopedics has a set protocol, and I think right now you can confidently say that orthopods have achieved the enhanced recovery very well with their patients. And I'm also happy to say that last 5-6 years when Yogesh has been with us, I have been a part of the enhanced recovery protocol which we have been practicing give clear fluids up to 2 hours prior to the surgery or anesthesia. And there are institutions in the US which have shrunk the period to one hour prior to anesthesia, but that is a little too much. I think 2 hours is fairly good enough. And then bed rest caused by the lack of mobility. But that is what the eras, what we do. I will take up each point in the next couple of minutes. Pre-surgery to during surgery, we changed the practices. Post-surgery, obviously, a lot of changes, and then better outcomes when the patient has faster recovery, fewer post-op surgery, post-surgery complications, and shorter hospital stay. I talked about that. And then ultimately, you want the patient to get back to his life as early as possible, even if they don't dance as Dr. Yogi showed in the videos, at least their daily needs, if they can take care of and they go back to their work, I think we are blessed. What do we do? The few things what we should, starting with the pre-operative phase. It starts with the pre-admission counseling, which as anesthetists, we don't do much, but the surgeons have to do. Pre-admission counseling, that is what determines what kind of stress levels the patients come to get admitted with, and what stress levels they come to the OR with. Bowel preparation for current guidelines, as I have already talked about the nil by mouth status. Up to 2 hours you give clear fluids, and 6 hours is for solids. Only when the patient prefers to have mutton biryani, maybe you have to give a little longer time, maybe 8 hours. Okay. Carb loading is something which is a part of the enhanced recovery. You have to, when you give clear fluids 2 hours prior, it has to be with carbohydrates, basically. There are commercial preparations. Otherwise, you can always mix some sugars with electrol powder and then give to the patient. That is basically the patient remains comfortable. The gut is comfortable and the patient is also comfortable. When the patient doesn't starve overnight and then come to you with all dry and dehydrated, patient is uncomfortable, and you anesthetize and the patient crashes because the patient is dehydrated. But that does not happen when you give fluids up to 2 hours prior to anesthesia. And avoid pre-medication. That earlier we used to give for every patient, pethidine phenergan was injected in the pre-op or in the ward before the patient was shifted. Gone are the days, and then we don't pre-medicate the patient till the patient is taken on to the table. And the green is all about the intraoperative phase. We talked about, Dr. Yogesh talked about the regional anesthesia and multimodal analgesia. General anesthesia is not exactly a contraindication, but still spinal anesthesia, the patient recovery is much faster and he responds to what is expected out of him. General anesthesia keeps the patient a little groggy, a little longer time. Therefore, we can't offer him the coffee the way we do to all the TKAs or THAs. When they come out of the OR, they are treated to a cup of coffee from their own pocket though. Multimodal analgesia, the patient has to be absolutely free from pain when the patient comes out. That is why we try neuroblocks, and even when we pump in analgesics, they are all non-opiates. We generally use NSAIDs, and paracetamol is the new fad, and it goes on. But even if you have to use narcotics, it is going to be a weak narcotic. We don't use pethidine, morphine, or fentanyl. Unfortunately, remifentanil has just put the foot into the country, and we haven't been using them much though. Yeah, short-acting anesthetic agents. Anyways, the anesthetic agents have changed. The newer anesthetic agents have changed the way the patients wake up, but still, as I said, they do remain groggy for a little longer time. Fluid is something which we have to take care of. We have restricted fluid therapy or goal-directed fluid therapy. What is needed to the patient only has to go in. Earlier, this was restricted only to patients for gut surgeries, but now for any patient coming for any surgery, we talk about reducing the fluid intake. The short incisions, no drains. Even if you put in drains, tubes, they have to come off very fast. And normothermia is something which contributes a lot to the patient recovery and outcomes. Therefore, we have to make sure that the patient doesn't get into hypothermia. We have our own methods to do it. Early mobilization, which obviously Yogish's team has been religiously doing it. By the end of the day, the patient takes baby steps, and the next day, the patient walks out of the room. That's actually a very nice scene when a patient goes out of the room the very next morning. Opiate sparing analgesia, I talked about that. Nausea and vomiting is something which makes the patients very uncomfortable all the time. Therefore, you have to make sure that the patients don't vomit. One of the ways how you can avoid this is, as I said, fluid up to 2 hours prior to anesthesia. The gut is kept very healthy and the PONV chances are less. And when you don't use narcotics, obviously PONV will not be very frequent. Therefore, you can use the NSAIDs and paracetamols and the COX-2 inhibitors frequently to have good outcomes. Early removal, I already talked about that. Nasogastric tube should not get in. If at all they get in, they have to come off fast. As early as possible, I told you the patient is treated to coffee or tea or whatever it is when the patient comes back into the, if it is a gut surgery, the minimum permissible duration, you have to keep them starved. After that, you have to give something orally so that the patient improves faster. Nutrition is something, supplements have to go in, otherwise the patient may not recover that easily. And that's it about, ultimately, as I said, we have to look at the patient walking home as early as possible. Think I will skip all this, and these are the things which I have already covered, and these are actually the basic headlines under which the ARS protocols are made. It's time, anyways, last slide I will talk about that, but time for us to have our own protocols for every different surgical procedure or disease pattern. You have to have the protocols for enhanced recovery. Pre-op education is, I told you, it is it has to take off. The patient cannot come to the hospital, get admitted and get ready for a surgery without knowing what surgery and what kind of outcomes he's expected to have. He has to know everything about what is going to happen to him. Then only the patient will be confident and the patient will come out comfortably. Intra-op anesthesia techniques I have touched upon. Post-op analgesia, I said opiate sparing and regional blocks. Basically, when we talk about the hip or knee surgeries, earlier we used to look at the femoral nerve block and then the fascia iliaca blocks for the lateral cutaneous nerve of the thigh. Now we have moved on because we need to look at sparing the nerves which supply the muscles. We can't afford to have the patient's legs weak when they make the patient take the baby steps within few hours. Therefore, we either go down into the adductor canal where only the sensory nerves are blocked and the fascia iliaca is combined with that, or we look at perivascular nerve group blocks, PENG block, which covers 3 nerves which supplies the hip joint. And actually, more importantly, what the surgeons do, the local injection of local anesthetics, that adds to the enhanced recovery. Post-op analgesia, I talked about that, and then early mobilization, obviously, within 24 hours, the patient has to be walking around, right? This is, again, there are commercial preparations available, and they are a little expensive, but when it comes to the larger picture, I think it should be okay with your patients. Antimicrobial prophylaxis, at least a couple of doses, if not at least 1 dose of 3rd or 4th generation cephalosporins. And anesthesia is always, as I said, protocolized. We try to avoid the general anesthetic as far as possible. It's mostly spinal, or if it is a bilateral knee or hip, it's epidural. Again, the epidural comes off within about 6 to 12 hours. If it gets over in the early night, we remove it only in the morning because patient cannot walk before that is done. And then obviously the epidural has to come off before they start thromboprophylaxis. Therefore, we remove it in the morning. I talked about the normothermia and blood conservation. Tranexamic acid, an antifibrinolytic agent, which is actually a godsend gift to most of us and most of the types of surgeries. 10 to 20 milligrams per kg is the dose what we use, though there is no hard and fast rule how much, or rather we don't have guideline as to how much has to go in. There are a lot of studies which have used as high as 20 milligrams. But then the good practice is local infiltration of tranexamic acid. That also is effective. Dr. Yogesh does that. And if it is hip where you cannot use the tourniquet, he also uses mops soaked in tranexamic acid. I think that's his invention. I think we have to give him the due credit for that. Blood transfusion comes with its own negatives. Therefore, as far as possible, we have to avoid the blood transfusions. We look at the blood conservation. If I cross my time, you just let me know. Not that I'm going to stop. No, not that I'm going to stop. Anyways. Yeah, I talked about all this, post-op analgesia, early mobilization, and then the IV fluids. IV fluids, again, the restricted fluid therapy is something which we have to use. Okay, the Mayo Clinic was the first one which started the enhanced recovery, and they had protocolized it much before we all even thought about. Obviously, they were the pioneers. Yeah, that actually I had a video which I thought I would skip because during the lunchtime I saw Yogesh had put up videos of his own patients who were dancing and bicycling and whatnot. Then there is no point in. But the thing is, what we should remember is we have a protocol based practice when the patient has to take baby steps. The next morning he has to walk out of the room. The day 3, the patient has to walk up and down the steps, and day 4 is walk home.
With one stick.
Yeah, exactly. Yeah. Yeah, that all they have seen, no? Yeah. Yeah. There are quite a few studies which talked about the benefits of enhanced recovery. I think I will skip most of them. But this is a systematic review, comprehensive review where it's already been cited some 325 times. It's by optimizing the perioperative patient education, anesthetic technique, transfusion strategy, along with opiate sparing, multimodal analgesic approach and early mobilization, can improve discharge criteria in total hip and total knee replacement surgery. That is a known fact. That is what we have been practicing. All these papers actually, the other comprehensive review also talked about the same thing. And why I'm trying to show this is prospective cohort study of 270 sample size. They also talked about similar outcomes. And as I said in the beginning, the Western world also looks at the cost and the number of available beds. We also have moved towards that now. One less day of admission obviously brings down the money the patient has to spend. This is about 207 sample size in a controlled experimental study on a hip and knee replacement surgery. Again, patient satisfaction improves the patient satisfaction. I think that is what we are looking at. 25 studies were involved in this systematic review with meta-analysis. Ultimately, the outcome was just the same. Okay, this is what I wanted everyone to give a thought because in one institution, it has been very difficult, barring a person, a department, it has been very difficult to implement the enhanced recovery all across. That is where I think the management, the top management has to sit with the surgeons, physicians, and the anesthetists And it's actually the team should also comprise physiotherapists and nutritionists. All have to sit together and develop the protocol for enhanced recovery across the specialties. When I said Henrik Quallet, when he devised it for colorectal surgeries, which we still think it is quite difficult to get enhanced recovery protocols into this. But when you look at, I have only shown papers which dealt with the hip and knee, because today's program is on hip and knee. But there are hundreds of papers on enhanced recovery for surgical gastro. Anyways, ENT people have taken up a little more seriously the enhanced recovery. I think everybody should be looking at it. Yeah. Implementation challenges are variability in adherence to ERAS protocols across the institution reduces the effectiveness. I think when I just said in one department, two people may not think alike. That is where the trouble is. But I prefer that associations sit across and like orthopedics, they decide about the enhanced recovery and they have to implement all across. And I think it will be I won't say it is utopia. I think it is ideal. Limited resources and training can hinder staff compliance with protocols. And I wouldn't say it is limited resources. It's basically we refuse to pick up new things. When I started my anesthesia practice, I started with ether and maybe halothane was sparsely available. And now I don't use any of the other agents than sevoflurane. I started with the thiopentone, that too with the difficulty. It was not available at all times. Maybe I had to induce with ketamine once in a while. But now I don't look at thiopentone sodium. I use only propofol. I mean, last so many years. I think that is the way forward. When the newer, safer things, something which does good to your patients, I think we have to move forward and embrace them. Institutional resistance to change can delay the adoption in ERAS practices. Basically, as long as your patients are happy, the feedback is happy, I think everyone will be happy. But for me, it's not the feedback, it is how the patient performs. That is more important to me as a clinician. These are the things which we have to overcome to have better outcomes. ERAS protocols, we need further studies, obviously. As I said, we haven't perfected it for a lot of specialties, but diseases, but I think that is the way forward. Research should focus on standardizing ERAS components for orthopedic surgeries, and investigation into specific barriers faced by different healthcare settings is essential. That is what we have to sit across the table and discuss and sort out the problems. And if we can do that, I think that is the way forward. Yeah, these are the challenges. I won't take your time, but ultimately it depends on the attitudes. I would say it is attitudes and the behavior of the patient and the staff. Skills and competences we all have. Communication, collaboration we have to develop. Engagement, I think we have to be better engaged in the management. And finally, leadership support is needed, and then staff education. It's not enough if you learn unless your team learns, unless the people who join your team also on the same page, then you may not have that kind of an outcome which Yogesh has reached, but I expect everyone else to reach there. Sorry, I took a lot of time. Thanks again for being patient, and thank you, chairpersons and Archit sir. Yeah. Questions? Any questions?
So I
No,
think
no questions.
no, it's been I think only practical things that sir has told that shows that he speaks about what he does. So whatever he has told is purely practice, nothing theoretical there. So that's years together of experience speaking there. So as sir said, it has to be comprehensive. So comprehensive, not only related to the procedure, as the patients of whatever OA or knee and hip joint problems, as the age progresses, the two things that come along with that is multimorbidity and polypharmacy. So what we have spoken just now, I think very maybe a little younger patients with not so much of morbidity, not of polypharmacy. But these two things are definitely the two things that are going to come with age. People will have comorbids and people will be on many medications. So how much practical do you think, or, to have a generalized statement, or has it to be done for each of these morbidities or each of these polypharmacies the patient is going to have?
Point. The thing is, we do get patients with all kinds of comorbidities. When we talk about a couple of things I would like to touch upon. One is whenever the patient comes to Yogesh's OPD, one of my postgraduates goes and sees the patient in the OPD. That is where the assessment begins. And if optimization is needed, it begins then. Cross consultations, if they are needed, it happens then. This all happens much before the admission happens. The rest of the counseling Yogesh and his team does, and then anyways the management guys are there. The other point what we have, the optimization happens before they get admitted. Generally the admission happens the previous night. The other point is when the patient is a diabetic, when we do the carb loading, and that is when the insulin has to be adjusted. If the patient is on insulin, generally what we write down is skip the insulin and OHS on the morning of surgery. But when we do the enhanced recovery, when the patient receives 250 ml of carb, obviously the sugars are going to shoot up. That is when the insulin has to be given in. But you cannot give the full dose because it's not the full meal. It's only about 250 ml of carb, which will have an extra 250 calories or a little more. I can't remember how much calories. But the patient needs a bit of an insulin, but that has to be titrated. Otherwise, all our patients, even the patients with the ischemic heart disease and well under control, they have gone through all this perfectly all right. We haven't had complications barring maybe 2 patients, but they were independent. Somebody who came with the community acquired pneumonia, we anesthetized, and then she ended up on ventilator. That was one. And the other one happened very recently when the patient had to be put in the ICU for about 4 hours, ventilated. Even today, I don't know what exactly went wrong with the patient towards the end of the surgery. Other than that, I don't think any other patient had any major mishaps in the post-operative period. It has been nicely managed. Sumesh, would you like to add something?
Thank you very much, sir. You have elaborated all the benefits of ERAS very well, and it is well known in various kinds of surgery. So in Mangalore, we have got teaching hospitals, we have got corporate hospitals, we also have smaller hospitals where surgeries are being done. So is there any common things that we could do in a simple way to benefit all the patients that in all these cases?
Can I have the last slide? Is it possible? I think basically it's only the attitude, and I have done this all this while and I haven't had problems. Patients have gone home, albeit a little slowly. I think that is the attitude which has prevented us from going forward and adopt ourselves to the newer, more acceptable practices. I think all we have to do is have an open mind and accept that enhanced recovery is the way forward. You just watch, as I said, I have been in anesthesia since 1989. This 35 years. Only last 5-6 years, I'm not condoning anybody else. I'm not putting down anybody else's practice. The thing which came around when we started practicing the enhanced recovery, it's actually very heartening. When the patient walks in the evening, when we do the ACL in the morning or TKR or THR in the morning, patient walks in the evening, you should see the happiness on the face of the patients. They never expected this thing to happen, because most of our patients, as somebody said, they will consult doctors, as Dr. Murali said. They consult doctors and they also consult our Google uncle and then the neighbors. The neighbors are the better doctors for them. And they come and say, don't take spinals. Then they say, don't move around for 2 days. You have to be bloody lying in the bed. And when that does not happen, they move around in the evening. I think that is the best thing to have happen. I think this is, as I said, we have to make sure that the associations take up. Before that, I think the institutions have to take up. And then I think we have to spread. The funniest thing is there are hundreds of articles, not hundreds, from India also, enhanced recovery, there have been quite a few papers. But why it hasn't taken off in a bigger way? I think we don't read the journal articles. Anything else you want to contribute? I think that is the mental block, basically. No, not this. Actually, I wanted. It's working. No, I wanted this. Hello. Actually, I thought this was the last slide. Sorry. Yeah.
Sir, thank you for enlightening us with the ARAS. I remember one case is long back, 28, 29 years ago. My aunt, she was 82 that time, and she doesn't know walking. She only runs everywhere, and she is little overweight, and she has fallen many times, and there are many rods in her thigh bones, hands, and all. And she had a hip fracture, and she was operated in KMC. And very next day I went there. I told her, if you there is even if you fall, there is not getting fracture because all bones are with the rods. And immediately she asked the sister, there is next day post-operative the second day, she asked the sister to bring the walker, and she walked, 82 years old. Probably that earlier they used to keep after hip surgery around 10 to 14 days. And she was discharged in 7 days because she was able to walk freely with a crutch walker. So I remember that. Thank you, sir.
I think from the audience. That's it. Done. Thank you so much for the patience.
Thank you for a wonderful session, sir. Can we ask the chairpersons to give a token of appreciation to Dr. Madhusudan? I know, you are ours, you don't. It's just a formality for them to have photographs with you as well. And Dr. Archit, sir, please, if you can give tokens of appreciation to the chairpersons. Dr. Shanbag, if you can come on stage. Yourself, sir. Dr. Shanbag, ne? Yes, to give a token of appreciation to Dr. Archit. Thank you, sir. Thank you very much, sirs. We move on to the next one. Everybody is sitting around getting tired, so it's time to move about a bit. So a topic personally very dear. As orthopedic surgeons, it is generally a male-dominated field. So the only bright light on the ward at that time used to be, apart from the nurses, used to be the physiotherapists. It went to such an extent that I ended up marrying a physiotherapist. So I thought I liked physiotherapy a lot at that time, but after the marriage, there's enough reason to hate physiotherapy. Anyway, after that, I fall in love with physiotherapists again, but this time with the boys. So, there have been a lot of changing life situations. We've gone on a lovely journey together. In continuity with enhanced recovery, it is so important to have a good, reliable team who takes the confidence forward and moves the patient, because that is the success at the end of the day. So the next session is going to be Dr. Bishwaranjan Das, who is working with me as an enhanced scope practitioner. We want to change the outlook to physiotherapy. So it is not traditional physiotherapy, but more of an evaluator and clinician. So that's Dr. Bishwaranjan Das. Along with him, we have our senior, I would call him associate professor of physiotherapy, because he's due to be officially that anyways, Dr. Ashish. Dr. Ashish and I embarked on a journey together, which ended up with him getting the gold medal at the Manipal University for a very good PhD paper that we had done, where we are now able to detect arthritis early. We've got a working protocol for that. So I would like you to listen to both of them. We'll start with Dr. Bishwaranjan and then Dr. Ashish. I would like to call upon Dr. Amitesh, who has been a friend for years, and he is by definition a pediatric physio, but a very, very dynamic previous head of department. Please, sir. And I'm privileged to invite Mayank Chauhan. Most people and most of Mangalore knows him as, a very, what can I say, a famous physiotherapy practitioner. He has changed the, you can say, the way patients are treated, outlook towards physiotherapy in a large angle. To moderation, my friend and cheta, Dr. Joshua Abraham, he is always there as a show. Bishwa and Ashish in this talk. Thank you. The floor is for Bishwa.
Good evening, all. Good evening, sir. Good evening, sir. Yeah. So, the ideal scenario where you can play the videos continuously. The ideal like the patient would like doing this kind of activity, and done in a position on the same day, of course, along with Dr. Ashish. And for a physio, the outlook to about patient before surgery. So that is before surgery, counsel them, educate them, and give, and at time they are ready, has been taken care, them post surgical outlooks, as in what are the activities they can do or cannot do, because it for the patient to realize what are their sides to the
That physiotherapy means it's all about and that happens make whatever for example this towards students as well. So these are the things we keep on changing, keep on challenging ourselves, so we know that we are continuously breaking the path and more about it. The we are the patient walks on the same day, goes till the washroom, next day goes out of the room. By day 3, day 4, the patient is able to walk with a single stick. So, enhanced recovery has taken a long way, and that is how we are seeing continuously what the activities the patients are able to do. Keep playing the videos continuously. So, this is a routine scenario what we deal with in our hospital setup on a day-to-day basis. There are multiple patients admitted now who are currently undergoing all these procedures. So this is about knee replacement. Now things have changed a lot. This is somebody I was talking about, the bilateral, the lady with both sides surgery done. When it comes to half knee replacement, or what we call it as partial knee replacement, for young people with one compartment or one part of the joint getting affected, this is how we see somebody who is in the middle 50s, a businessman having a bowed knee, and this is the same person walks on the same day
with a lot of confidence. Obviously, the pain part and the anesthesia part has been taken care properly. This is how he walks on by day 3, walking with single stick, stairs done, and by day 4 go home. So that not only boosts his confidence but also makes him more mobile, going back to the normal society, which is the need of the hour, to make the patient active as well as to make hospital system running smoothly. When it comes to hip replacement, out of all the elective surgeries of the century, hip surgery according to the WHO index has been counted as the #1 surgery. So the satisfaction rate with hip surgery is something around 98 to 99%. And you can see why it is rated as the #1 surgery. This is a patient, 50-odd year patient, actually a physician, comes to us with a bad hip. Not only one, both the hips are affected. And that is the same person walking on the same day. Can you see the drastic difference? With both hips done, by day 4 he is able to do stair climbing. And within 2 months, he comes all the way driving from Honnavar to Mangalore in a car by himself to tell us, sir, I'm all fine and I've started back to my routine practice. And what happens is now he is running a clinic where he has to walk and climb up 200 meters. Now when it comes to ACL reconstruction, sports injury, now things have changed drastically. With all I wanted to tell here is, with the primary ACL reconstruction and a stable meniscal repair, we can make the patient walk pretty much down the same day and doing stairs by day 2 and go home. There are a lot of debates in the physio community as well as in the orthopedic community whether to brace the patient or no. We have come up with a paper recently where we have found out the re-rupture rates are maximum when the patient has put on a brace, because the initial rehab was hindered because of that. But this scenario is not all for all the patients, because there are times we have to brace the patient. This is a patient who came to OPD with a locked knee. You can see this patient not able to straighten the knee. He's basically a bodybuilder. The main profession is into fitness. Comes to OPD in this kind of scenario. Now that's the same person walking in the ward. So it is a locked knee at 30 degree. Now these are the type of scenario where we might have to consider brace, because along with the ACL surgery, he got a bucket handle meniscus which was repaired at 3 places. So that's the same person walking, same day walking with walker, second day walking with 2 crutches. Of course we had to brace him, because to give the repair or the healthy environment to the meniscus, we had to keep him non-weight bearing. This is him back to the regular practice, and this is how he keeps us sending us videos, not to show that what he is doing, just to tell us he's back to his normal life. And that's how you can see the leg, both are equal. This is just 6 months post ACL surgery. Now, a return to sports. That is the major question still remains in the sports community. Sir, I have got an ACL surgery, will I be able to go back to sports? Now, lot of traditional practice says no, because once you have got an ACL surgery, you can re-rupture the ACL. But that is what I would really thank Dr. Yogis and the knee center or sports injury center at KMC, because we are able to change a lot of, we are able to get a lot of changes to that system. This is not about one patient. This is a international Muay Thai player. He is currently the national coach for India, who is in Olympics right now. This is him 1 year back, 1 year later after the surgery, going back to the practice. It is not about only one patient. I want to focus here. Anyone who has got a proper surgery done along with taken a good amount of rehabilitation can go back to sports. So it is not about individual or individual sports. That's where we do a regular session, we do a lot of sports meet, we travel across Chikmagalur and other places to educate the patient, so that we can be you know, we can push them to go back to their profession or the passion they like to. The last slide, I want to mention about the performance indicator or the outcomes of this kind of surgery. When it is done properly, you can see with the joint replacements, 99 to 100% of our patients walks on the same day, does stair climbing literally within 1 day of antibiotics, walks 100% walks and does stair climbing before goes home, and this is the mortality rate. Here I would like to give credit to the physio department and our fellow colleagues as well, because it is not only the anesthesia or the medicine or the surgery. This is where physiotherapy is making a lot of difference, and this is what we have to showcase to the world, that we play a major role and put the patient back to the normal society. When it comes to ACL reconstruction or sports injury, you can see almost 90 to 95% of our patients have gone back to sports. Literally within 2 days they have gone home. So this is how physiotherapy can change a lot of things, and there are a lot of things we are currently working on, doing a lot of research, for which I would like to call Dr. Ashish to the podium to take it further about the research and developments, the things are happening in arthritis, diagnosis as well as rehabilitation. Thank you.
Good evening, all. Thanks. I thank Dr. Yogesh to have had me here. Thank you, sir. Okay, when it comes to research, it sounds a little boring to most of them because it counts numbers. I will not talk numbers because even I don't like them. Anyway, when it comes to arthritis, when I talk about arthritis, everyone knows that there are multiple factors associated with how arthritis is caused in the knee. Few of the basic components are malalignment, muscle weakness, obesity, diet, nutrition. But when you let these problems develop, by the time it is detected, the patient is subjected to medications or also to pave the way towards the surgery. So there is a trend right now, that is early knee osteoarthritis, that is finding the condition in the early stages. Alright, that is picking up symptoms in younger population. But the problem with younger population is that to convince them that they are having some issue which requires addressal or some kind of treatment. Most of the patient will tell me, "Illa sir, enta illa bidi ನೀವು ಸುಮ್ಮನೆ ಎಂತ ಹೇಳುದು." ಅದು ಸುಮ್ಮನೆ ಬಿಟ್ರೆ then next it becomes so big that he has to undergo some kind of a procedure. Anyways, so what happens over here in younger patients is these things are neglected. Any fall, any traumas, bad postures, alright, we neglect them because their pain perception is good. They say that they are able to tolerate these problems, they are okay with that pain, so they let them go. But what happens meanwhile is these small rents or the cartilages or the defects in that alters their proprioception, alters their perception, alters the biomechanics, alright. Any defects in these components, that is the ACL or the menisci or the cartilage, will lead to changes which are very subtle. Alright, what I mean by subtle is they are very minimal. So younger population, when I say, we have seen changes as early as 18, 21 years also presenting with arthritic changes. Alright. Anyway, when I say subtle, what happens is it becomes necessary for me to convince the patient that something is wrong with him. I can't just say, you are having pain, so there is something wrong, you take physiotherapy or you take medications, what is given by the surgeon. He requires some feedback. So what are we doing over here is picking up these subtle changes, alright. I will show you that slide. Okay. We use this force platform device which is commonly used in neurological rehabilitation. We found out that these patients are having some postural deviations and some postural sways. So we use this. Yeah. And figured out that these patients are having some postural alterations in only AP direction. We didn't ran this test with 1 or 2 patients. We ran on a couple of hundreds of patients and we found out that they are having sway only in AP direction. Alright. And that gives us a feedback that, okay, fine, this might be having some changes. But this is not the one of the features, alright? There are other changes. Now again, it is difficult for a young patient to convince that he is having muscle weakness. So we have to quantify them that they are having muscle weakness. So we run different muscle tests where we have some parameters to tell them that they are weak, alright? So we're using the device that is called as the push-pull hand dynamometer. Now both the assessor and the subject is not masked over here. The assessor is myself and the young girl. I have got partial consent. Consent is taken from the father, Dr. Yogesh Kamat's daughter, that is. Okay. Now we are also working on gait analysis. This lab, this mat is done, indigenously designed with one of our projects, heading by Dr. Biswa and Dr. Yogesh. We are also assessing various parameters over there in gait, in foot, and at multiple sensors placed at the joints. Alright, so we are able to generate a report for them stating that they are having these alterations, and we are able to detect that they might be having early arthritic changes, hoping that the condition doesn't worsen, addressing them in much initial stages. So if we are tackling them in their 20s, hopefully they might not be having that much amount of deformities in future and can have a better life in terms of knee. These are few of our papers that we have worked on. So the previous pictures or images that I showed were out of the projects, and this is the final product of that. We've got them published, alright, where we used not only the force platform to detect early arthritic changes, but we also use machine learning to detect early arthritis in patients with knee pain. Alright, this machine learning was a multi-centric work which was done. We required the engineer's help to design this. Now we have got the system ready, where we do not require them because they have already given us the software to detect this. So we require the post platform that we have it, and then we feed the data and we get an output stating that they might be having potential. Now we are not saying that they are an EOA patient, but they might be a potential candidates who can be considered under early osteoarthritis. Coming next to this one picture, that there is always a difference. Now this is not an early arthritic girl. She is a normal subject, which we ran on normal individuals only. There is a consent or there is an understanding that post-surgical proximal femoral, we need to go non-weight bearing. So we thought, why can't we analyze if a patient can put partial weight even in day 1 or day 0. So we tried to assess the muscle firing and the forces at the joints, thinking that what might be the variations that might happen if we allow them to permit weight and not go non-weight bearing. Now there are multiple understanding that why we have to go non-weight bearing, so that it gives time for the bone to heal, we don't interfere with the healing process post-surgical, and so on and so forth. What we found out over here is that this girl, when she does a non-weight bearing stance following the fracture, we have placed multiple sensors if you see that, alright, and at the hip joint, it gave the same readings as that of her when she was putting weight on the leg, alright, but this is done on the normal individuals. Based on this data, we found out that both are having similar kind of muscle firing. So maybe we can permit the patient to weight bear. Now the next step of this work is try to do it on the patient population, and we will be running it through the ethics for that. Anyway, so this is some of not only early mobilization but early detection of the condition also, and trying to mobilize them as early as even in proximal femoral fractures. Thank you so much.
I think both the speakers had given a very good detailed elaboration about the rehab, particularly focusing mainly the relevance of preventing muscle wasting, improving the mobility, the flexibility, particularly for the routine activities, like as you told, whether it is for movement within the house, beyond the house, things like praying and other things like that. And then, of course, add-on is like the psychological benefits for the patient. So he feels better when early mobilization is done. So minimizes the complications also which are possible if the patient stays for a longer period of life. End result is that there is a better quality of life. So that's what I feel the most important thing. End of the day, without creating a big, large hole in the pocket, with early dehospitalization. The patient going with a better smile, better quality of life, and that is what the point that which I could get from overall, not only from your speech, but even Dr. Madhusan sir's, Yogesh, predecessors, everybody had given the same kind of point. So that is what the take-home message is, and enough of evidences are already there, basically suggesting that this should be the way of management for patient, rather than keeping the patient for long on the bed, particularly elderly people. The more you keep them, the more they are in trouble. So that is what it is. Like, of course, the style of functioning, the way of approach, the prosthetic units that which are being used, all those things have changed a lot from what it was. So naturally, all these things are eventually, percolating for a better rehab. Thanks. As a moderator, this is what I would like to suggest, and over to the chairpersons.
First of all, it was really nice to see the coordination which orthopedics and physical therapy department at KMC is doing. It's really good to see that we are trying to detect problems at an early phase. So interventions are, according to me, lesser. Mobility of the patient and back to the ADL activity of the patient is restored much faster, and I completely agree with, and I'm very happy to hear that the patients post-operative are getting back to their life very early. That's a very good job which I'm very happy to see and be part of it. Now since I come from, I deal with sports injury. I'm basically a physical therapist, but I work through chiropractic osteopathy. So since you have put across, I'm a little interested to know when you said muscle imbalance adds to the condition. I would like to know what was your observations and learnings in this research or papers what you've done or the work you have done. I would like to know that.
When we talk about muscle imbalances, so what happens is we all know that there are sensors, receptors in the muscles, in the tendons, in the ligaments. What we found out that ligaments can't be strengthened in any way; they're going to remain like that. And both are stabilizers of the joints. One is a static and one is a dynamic. So static, we can't do anything. It's already there. It is lax or whatever it is there. We can train it. We can increase the proprioceptive feedback to it. So anyways, when I say about muscle weakness, what happened is that they develop with imbalances over there. Imbalances as in they could have, for example, knee. If a weaker cortex is there or weaker VMO is there, you might have a buckle. But repeated doing that can cause some kind of deficits in the cartilage or can strain the ligaments also. Can lead to a pain, alright, and can restrict his mobility. What is going to happen after that? Proprioceptive feedback is going to get reduced, right, with this, and that can percolate to having some rents in the cartilage, which eventually goes on. Now, one after the other, it's a cycle. Now, pain starts again, you will restrict, and so on and so forth. So, when we start training the muscle, alright, now, how did we train both the separate components is that we added not only strengthening exercises in the routine, we also designed proprioceptive exercises along with strengthening so that it trains not only the static stabilizers but also the dynamic stabilizers. If you're trying to prevent the imbalances over there, we're hoping that it avoids any kind of further injuries or development of injuries. And as also literature states that if initial cartilage deficits are addressed, they are still recoverable, provided they don't become a bigger crater. And it will same like potholes on the road. If it's a small hole, you patch it up, it's fine. If it becomes a big crater over there, then you have to change the whole thing. Similar with that, with the cartilage, a small dent over there can be, body can heal by itself, properly addressed. Leave it like that, then obviously surgeons have to come into the picture. So that was the whole understanding of why we spoke about muscle imbalance, considering it's so important towards rehabilitation.
Want to add into that. There are a lot of patients come to us with ligament laxity, as well as we see a lot of young ladies, particularly with miserable malalignment. When I talk about miserable malalignment, I am talking about valgus knees with maltracking pattern, and we're doing a lot of that. And observation. training them for proprioception.
Okay, thank you so much. I go a little back. I think we know very well Dr. Yogesh, other half. She happens to be the second batch of physical therapy at Mahe. And we have been insisting him that get her back over here. The message, the collective message was that Dr. Yogesh has been able to bring a beautiful harmony between the surgical skill, the rehabilitation concept in the town of Mangalore. And we take this, all these messages from our educational background, what we learned in Manipal, and what we are seeing effectively is being implemented at Mangalore. Thanks to you, sir. With this little bit, what I have 2 points to say. One is a suggestion, that is the role of vestus medialis and its early wasting as an early identifying marker associated with the medial epicondyle pain. It can be in the tibial or it can be in the femoral. That, your opinion on that. The second point is that when I looked at the statistics shows from the 2017 to 2023. That means 6 years. The youngest one, fine, they all are happy. The older one, that is those who got operated in 2017, 6 years down the line with their age as a background, how they are doing, if that statistics has been brought out, it will be quite informative and encouraging to the patient population as well as a surgeon and the rehab professional as well. Thank you.
Just to add on to that, for the statistics, we keep do something called OKs or OHS, Oxford Knee Score and Hip Score, per annum. So that is where I have taken another project where we want to see the people who got operated early. Here we have got result from 2017 onwards, but Dr. Yogis have started the center from late 2014. Because we don't have those data, that's why we're not able to track back. But now we are re-auditing those patients, particularly whether they have gone back to the normal society in the same manner what they used to be, or whether they have gone worse. Because one of the major complications with osteoarthritis or joint replacement is a fall. And the current world statistics shows there is a 9 to 24% fall which happens in and around pre and post surgery. So we have also got few cases like that. Somehow our numbers are much lesser, probably because one thing, probably it is not reported. Second thing, probably it was in a much lesser extent which can be managed at the periphery center. So we are re-auditing those. So hopefully in another 6 months to a year, we'll be coming up with that data as well.
I think a subgroup analysis might be a better one to pull out the information rather than collective one.
Interesting, so it's a query on VMO. The VMO, you said once it develops weakness, it lands up into medial condyle pain, either the femoral or the tibial. Now the thing is that the line of gravity, which passes through the femoral head, goes between the condyles, then to the tibial condyles, and so on and so forth. Now, whenever there is weakness over there, there will be again loading of the other joints or that joint in a manner where they are spending more time in the stance phase. So what happens is whenever the patient is in the stance phase, the swing phase, COG will shift on the medial condyles on every walking. That happens normal case scenario. But if they are spending more time with the problem that they are having weak and the chances that they might lose balance and fall, that is when they tap on that two condyles more often. So that is one of the reasons why they are having more detectable pain or complaint in that area because of the friction. And second thing is that if they are already having VMO, that means weakness. That means either they have had that condition since long, that way they are restricting their mobility and it's landed upon weakness. That is just going to accelerate, or it is just flare up of the existing pathology.
Right. Thank you. One more point to add over here. The population should know whether they should do compressive exercises or distraction exercises. That is, joint compression exercise or joint distraction exercises. Your opinion on that?
That is something which is still debatable, I would suggest, because people with already known arthritis, when we give them compressive exercises, may not like it. Probably one reason is when it is not supervised, it can have altered forces going across the joint. That is one. Second is the pathology itself. But where it comes to joint replacement, that is where we have trying to improvise with compressive exercise, which is what we have started giving them, is called closed chain exercises, to develop their balance and to have those imbalance corrected. So we have started implementing those, but of course these are the early results what we have got. We have to see how it goes over a period of time.
Thank you so much.
Thank you very much for a wonderful session. Can I ask the chairpersons to give mementos to our speakers and our moderator, Dr. Joshua Abraham, to likewise to the chairpersons. Dr. Shashank? Dr. Shashank, don't leave, please. We want you. We'd like to call you on stage after this. Can I ask Dr. Shashank to come and give a memento to Dr. Abraham, our moderator? Thank you. Thank you very much. We'll speed on to the next one because we need to save time as well. So in the next one, I will be presenting a few up for challenges and how technology is gripping us in orthopedics. And I would like three eminent doctors to shoot me off for whatever I present. I'd like to invite my senior colleague and advisor, Dr. J.N. Bhatt. Sir, please, if you occupy the chair. Thank you. Sir is, as you all would know, very keen on and he's the epitome of energy and very much into academics. And with him, we have two senior orthopedic surgeons, Dr. Jacob Chaco, sir. Sir has been president of Canada Orthopedic Society. He is very dynamic as an orthopedic surgeon, even more as a human being, very well known, and has been a personal friend and guide. Please, sir. And Dr. Umesh Prabhu. Dr. Umesh Prabhu is my senior colleague and friend from Udupi, very well known for amazing ethical practice, and he's managing quite a few orthopedic surgeons. It's interesting that many of our seniors, after quitting Manipal, have found it easy to practice with Umesh Prabhu. So what we have is technology is gripping orthopedics. I'll just dive into it directly. And there is no doubt that we are, coming up with so many new interventions, new implants, new diagnostics, new means, so to say. Run through, please. It is a lot been related to accuracy. So a lot of you would have heard about robotics, which is why I thought let's start with this. There's a lot of accuracy required in every field, and with the satisfaction rates with knee replacement going up and down, people think that it's all about accuracy. So this was how it was missed a couple of times, and you can be accurate or inaccurate. So what happens with navigation? Everybody's talking about computer navigation and robotics, computers helping us get the thing right. So what navigation essentially is for the audience is you've got a infrared camera there, and you've got sensors implanted into the knee. So after the incision, you've got a sensor there, you've got a sensor there, and the movement of the knee is dynamically being tracked by the intraoperatively by that infrared camera. So in the first generation, what we as surgeons did was we marked the points in the knee. We moved the knee, and that system computed the center of the hip. We marked points in the knee, so it told us the center of the knee, and we marked points in the ankle, it told us the center of the ankle. From there, it was getting the alignment, and as we went through the cuts, it was telling us whether we were accurate or no. Now we've gone a stage forward. I think this is not working. You guys have to move it ahead for me. So computer navigation, keep going. Computer navigation was of different types. So you had what I described without any image, or you could have a CT scan fed into that computer, and then it would tell you where to go. You had different types of cameras, you had different types of sensors. Then came robotics. So the first generation robotics was what I used during my PhD, was what you program here was made into moving this into, moving it accurately so that you could cut part of the bones well. We now have gone to a different stage of robotics where you've got a preoperative CT scan which is fed into that. The surgeon marks the surface. So the machine has the CT scan information. From what the surgeon marks, the machine correlates, and you can stand back and watch while it does the cut. Now, the better version of this is where you have a burr cutting, but when you are holding the burr, the surgeon has the ability to override what the system does. So it's accurate to the point of 0.1 millimeter. No doubt it's fantastic. It is giving you a lot of feedback intraop. It is telling you whether your bone cut is accurate. It also allows you to navigate through as you move the knee. Having said that, we sometimes have problems. So as we are, crazy about gold in India, sometimes we can go overboard. So sometimes using it can be restrictive in the wrong places, right? And at the same time, we have a group of patients who care for conservative treatment, natural therapies, and things like that. So we've got the whole gamut of things. Before I go on to the negative side of computer navigation, we will go to the plus and minus. I would like to ask Dr. J.N. Bhatt, because we have the orthopedic surgeons on either side, what is your perception of, as you have heard it in the community, you are on many forums yourself.
Dr. Yogesh, first of all, I didn't know why I have to be here. Now I know why I got to be here. As you said, no, it's in English, yogi-ish, 10-ish. That ish with ashish makes me more sense, and I'm glad I learned a few things. See, we have not given up all many things. Actually speaking, there's been a lot of orthopedic surgeons, Shantaram Shetty, whom I assisted, tendon replacement, things like that. He used to say, unless somebody breaks the bone, we'll not have business. Whereas the situation is changed now. Beyond the fractures, we are doing many good things. And the computer, CT or MRI, the family practice, we do not know what to suggest. That's why we blindly refer to the orthopedicians. They decide whether to go for MRI or CT scanning. Because in nowadays, when we had, had personally open heart surgery at the age of 16. So rehabilitation, when it took place very second day, I was angry with the doctor and physiotherapist. As you said, physiotherapist, when it is been a board to be written by them, they wrote it as physio the rapist.
Yes.
So
Know that here.
so
We also call it physio terrorist.
okay. So things have changed a lot.
Yeah.
Actually, WhatsApp has done a lot of good job. Facebooks, I do not know, still Instagrams. We have got to keep ourselves grading upgrade, otherwise we'll be sidetracked. I'm glad we are making, we family physicians still invite universities list. We do learn, at least to know, this upgradation has taken place, making us feel aware. This is a possibility. Don't stand behind. There is a possibility we can still, beyond the longevity, there could be a quality of life. That's what I'm assured of today's. Thanks.
Thank you, sir. Dr. Chaku, sir. Yeah, what is your opinion on, say, for example, would your patient, when they come to you for advice and they ask you, now you've had family who you've had got surgery, they would ask you, what is your opinion? Should I get it done by robotics, or should I get it done by a particular method? Should I have a imported implant only? What is your personal view on it?
Though I have not seen or even observed robotic surgery, though one of my students early in Father Muller's is now doing over 200 robotic surgeries since he started a few years ago. I do believe that you have to look at the surgery, in a more rounded fashion. What is the quality of service that the hospital provides? What is the robotics doing to improve the quality of the surgery? I think over dependence on advanced technology is going to reduce the skill of the surgeon over a period of time. As you said, there is an option to override the robot. I feel that we have to take into consideration what the results were in that particular service before recommending to a patient to undergo that particular surgery. Definitely, the accuracy of cuts and the fitting of the implant would be perfect. But as I said, you have to look at the whole picture before you recommend anything.
Excellent, excellent. I mean, that is really what you really want to know. So it is whether a hospital is transparently telling you their complication rates, whether you find it directly from the hospital or you find out through some other means, which is what should be the deciding factor rather than blindly relying on technology. Sir, Umesh sir, I'll come back to you in a minute. Let me ask our younger colleagues. We've got a dynamic orthopedic surgeon, Dr. Rajendra here. What do you think on this? Now, something complex like this, would you think that robotics would help a complex surgery?
I definitely feel the future is the robotics, whatever clinically we do, but more and more of complicated cases being managed by the more of a robotic assisted type of surgeries. But at the end of the day, clinical acumen is, I think, the way forward. So if you are good and experienced in your clinical judgment, I mean, no robot can overtake you, whatever you do.
Super, super. So we go to another case as an example. So we've got this patient who you can see has a bad knock knee with what we call a windswept deformity there. Now, if you dynamically examine this patient, it looks like a bad deformity, but let's put up the next picture there, where you can see the ligament on that side is pretty much not competent. Do you agree, Rajendra? Yeah. Do you think robotics would help in this case? It would help assessment, but then would the prosthesis, a normal prosthesis work? Exactly. So that's what. So it would help assess, but then the surgeon should have clinically assessed that the, exactly like Rajendra said, that the ligament is incompetent. So just because it's difficult doesn't mean robotics will provide the solution, because an implant, what that would require, there is no constraint on this side. So you will have to provide stability within the joint replacement. A traditional knee replacement is just a resurfacing. It does not have any constraint. So what this has is a box where it has a constraint within it. It may not be a hinge, it's just a constrained knee. But that is, for example, it is not available off the shelf in Mangalore. So you have to have planned this. Otherwise, the companies keep sets, they keep 1 or 2 sets for the south of India, for instance. So unless they have delivered all the necessary things, you are high and dry on table. So nothing goes, as much as a clinical planning for these cases. Now, there are other things which happen with robotics, and I'd like to show you the advantages. Dr. Umesh, we've had personal experience of this when we've managed patients together. Here is an extra-articular deformity, and you can see the extra-articular deformity looks bad here, but when we have done a long leg view, actually it was corrected. Now, in this case, you could not do it by aligning on the tibia as in a standard instrumentation, so navigation definitely helped. Now, I'll show you another case and I'd like you to comment on that. And I'm sure this brings home some memories. What would you like to say on that?
Yeah, this is my sister-in-law's case where she had a polytrauma with the supracondylar fractures, which we had initially treated with the locking compression plate. And she had a very bad osteoarthritis of the knee, and later with the navigation. So whenever we have a periarticular implants, navigation is the must to assess the cuts and to keep the proper implants. That's where the navigation is very, very important.
So we would like to reserve. Technology is there for a reason. Do you agree, or do you have any more comments? So use it wisely, it works very well. Yeah. Next, I'd like to bring home some points. So there are wonder works that we can do, but unfortunately, some things can happen which unfortunately the patients pay attention to things which are not that important, but comes across as a side effect. And unfortunately, in the patient's eyes, things get diverted to things which may not be important, but suddenly the attention goes away from what the major feat is to some small silly things which, could have been avoided. So good planning is really the message. What we need to know really is the downside of these things. So machinery and instrumentation is great out there. What the marketeers don't talk about is a lot of complications that are being seen with these problems because of trackers being put into the bone. So you can see this is a navigated case. You have to put drill holes and you got to put markers into the bone. So I don't want to show you the next x-ray, but the first marker there, you can see 2 drill holes in the bone, and that has caused a stress riser. That coupled with probably a millimeter of an error here, you can see in the next x-ray, it's not there here, but that broke. So plus what you also have is those markers, trackers being put, causing thermal burns, and we've had cases of infection with thermal burns with sinuses. The knee wound heals, but that sinus doesn't, and it's not comfortable for a surgeon when you have a wound healing with a discharging sinus next to the knee. Coming to the clinical outcome, I was lucky to present my results, clinical results with my cases, my own cases of navigation, and have published it at the American Academy and worldwide. What we have data, the best data so far is from joint registries. It's from Australia, which shows comparable clinical results. Now, we did not see any difference between navigation and non-navigated ones. Robotics has been there in the last 2 to 3 years. So there's just a little level of increased accuracy. But with navigation and conventional, there was a huge jump for accuracy. Despite that, we don't see clinical difference in data. So maybe slightly better, which might translate to better long lasting after 10 to 12 years. But at least in the 11 years time, we did not see a difference. So we want to use it for a reason, but we want to use it judiciously. What we have to realize as doctors, and I'm sure you all will have to comment on this, when we think the monsoon water is pure, we should think where the source is. Similarly, when reps send us, medicines which are new, they might look good. We have to really know the basic sciences. We have to know systems in and out before we get dependent on them. It's easy to get impressed with technology. It's easy to get carried away. Things look attractive. But, things could go for a toss. So, yeah. Going on to different technology, we have variations of this. If we do not have dependence on navigation costs about 1 crore, robotics costs minimum about 5 crore to adjust to, and automatically the hospital has to charge to obviously make up for what they've invested. We have technology which is called patient-specific instrumentation, which can be used in cases like we did in Umesh Prabhu's case, or we have mobile navigations which are useful for specific cuts. What we are trying to embark on is, I had done my PhD entailed checking soft tissue balance. So we are doing further work. We have patented some instruments, and we want to take that further into using these blocks, which we use for measuring tissue tension in navigation, to going on to actually measuring a little more objectively with sensors, which will help us navigate through the soft tissues better. So use technology to a level. Don't get too dependent on it. So personally, my view is not to be dependent on burrs and things like that, because those burrs coupled with our osteoporotic bone, 0.1 millimeter is not going to make a difference. Out there, we know that despite robotics, 20% of knees are unhappy, even in the best centers. So to get that factor better, to get the satisfaction rate higher than 80%, we have to get to the soft tissues, and that part is not being addressed by the current technology, which is where we are trying to move forward. So we are doing some work on this, and hopefully we'll be coming out with our own patented system in a short while. What is your view on that? Sir, any comments?
I think, now the new technology, whoever comes with only with the Googles. So even the smallest the patients are here in our area.
Yeah.
The sons, they are either in Delhi or Bangalore or Bombay, and they come at us who do have a robotics.
Yeah.
So in future, hospitals has to have to cater the services.
Yes.
But where the patient or the patient party may not be knowing where the robotics to be used.
Yeah.
What I feel, when there is a gross deformity, varus or valgus, whatever may be the deformity which is not able to treat it, or where there may be some manual errors of 1 to 2 degrees with the manual hands. In such cases, only the robotics may be. It is very difficult to convince in due period of time.
True.
So definitely whatever you are going with the new investigation or the study, where we can have some spacers, so that we can have a proper soft tissue balance. The soft tissue balance and the bone cut, these are only two things what I feel which mandates in a total knee replacement. And definitely it will be more useful, and I'll definitely wish you good luck also in this.
Thank you, sir. So to move ahead, just to show you a case where this was a navigated knee, that was supposed to come later. Anyway, but the patient had not walked. This was perfect on X-ray. The patient had not walked for 2 years. For some reason, they came to us. Fortunately, it was done elsewhere. Anyway, so it was because you can see the knee was dislocating. So you have to check soft tissue balance. The knee was not very well balanced in bending when it was falling loose. So that knee was dislocating on assessment. So what was required was the gap in this plane was not matching with the gap in this plane. So when they started to do stairs, it was feeling unsteady. That is what happens to some patients. And what you needed to give them essentially was a posterior offset, which solved the problem for them. So essentially, we need a system which can even assess these situations, complex situations. In the current generation, the software restricts us to the primary situations, whereas a surgeon will be helped more with complex situations, which is what we are trying to getting into soft tissue balancing more objectively with the use of computers rather than restricting to systems made abroad, because then we become slaves to them. Similarly, do we agree that arthritic knees come in different types? Rajendra, what is your opinion on every knee replacement? Does it feel the same or does it feel different? Apart from marathon.
Yeah, so all the primary replacements which I have seen, okay, so most of them come in different sizes, different levels of presentation. Some of the knees, when you open up, there may be not much arthritis, but symptom-wise, there will be so much they opt for a surgical management. So some of the knees, it will be too much arthritic, less deformities, but still they come at a very late stages. Some of them present very young, 62, 63, some of them present 70 above. So it all depends on a lot of factors which we are going to being operated from the symptoms wise, patient wise, financial wise. So a lot of varied presentations we come across when we are going to plan for a knee replacement.
So that's one thing. The other part is in terms of kinematic patterns. Some are, even though they are varus, they are not the same. What do you think within?
Have to assess the patient's pre-op condition and know what is the reason why the patient has opted for surgery. And if you have accurately assessed the grade of arthritis and the grade of stability that the knee has, then you may make a better judgment as to whether the patient requires surgery in the first place for a primary problem I'm talking about. So I think therefore when you assess a patient, it's very, very important to look at what the real requirement the patient has before you plan on what you're going to do.
Including the pattern of arthritis. So that's what we are trying to get at as well, that when we are changing a knee, we are changing the kinematics of that arthritic to a predetermined kinematics of a prosthetic knee. And one kinematics may not suit all, which is why maybe we cannot explain why some patients are left there unsatisfied. So it comes a lot to perceptions, right from assessing kinematics to many other factors, which is why I want to come to you, sir. The 4 stages of treatment in India, we say, the first is allopathy. The second, I'm not putting down any system of medicine. I'm just saying that as a second opinion. Some people really like, the fact that they're suffering because they get a lot of attention from people. And the last is we like to go and pray and blame God for all the problems. So, it's all perceptions. It is about whether patient really asks you for the treatment or whether they have made their own opinions before they come to you. And how do you address that?
Yogesh, your name starts with the yogi. So whether you start with the Ganapati and allopathy, homeopathy, sympathy, Tirupati, there should not be Kitapati. See, when the facility is available, because our ancestors have gone to Kashi walking with a lot of threat for their life, automobile started, now plane journey. So if we refuse to take advantage of that, we will be sidetracked, we will be considered as fools. So the individual upbringing of any individual, 2 twins are not thinking exactly alike. So the upbringing has an impact in their thinking, parental training, educational, then all these recent advances, somebody has to make it reach to them. Like me, I was quite ignorant till this morning. So many things I was not knowing, this could be the better way of doing it. So, Gino Algo, Gino Vera, whatever it is, some small children are made to stand before they are really able to stand. So they end up with the bow legs. And for the Bolix, there should be a village treatment, put the left shoe right side, left, right to the left, so that no, it corrects by itself. These probably sentiments, or they have not been able to. In fact, I was wondering today why nobody talked about Perthes disease. Lot many children must be having, I do not know. It is very rare, very, very rare. That probably if you touch upon it, I'll be glad.
Sure.
Yeah.
So there are a lot more other things available. There is 3D printing available. There is no end to technology. So this is for specific situations when we are handling defects. It is used a lot by maxillofacial surgeons. There is custom-made implants. What I'd like to end on or say is we have to first of all think about whether there are alternatives to treatment. So if there are isolated cartilage lesions, that is a cartilage ulcer, this was a 13-year-old girl on chemotherapy and developed kind of an avascular necrosis of one femoral condyle. You can see us doing an opening, and we couldn't leave that just like that for things to get worse and have arthritis by the age of 20. So you can see us taking bone from the non-articular parts, and we have made what is called a patchwork or a mesh in the defect area, and also used stem cells by way of autologous bone marrow, a technique which has been very well documented and accepted by Cartilage Research Society, has been developed by one of our own sons from the Indian soil and one of my mentors, Dr. Anantaram Shetty. I do a lot of this. We have been certified for this use by International Cartilage Research Society when we inaugurated our center. So these things help us prevent arthritis. In further situations, when like Dr. Rohan presented cases like in the radiology session, you've got a 60-year-old with a bowed leg, but it points only to one compartment. I mean, clearly that is a case for a knee replacement. But if they are very active, and I can see that patient with a family history, possibility of living till about 95, 100 with good activity, like you have many people in this area, why do I do a total joint replacement? I can get away with a partial joint replacement. The idea is they will get better for now. This may not last them 40 years, but definitely a total knee replacement will not last 40 years. If I, as a knee replacement surgeon, have taken the decision, I am then responsible for it even after it fails, if it fails at 70. So if I do a knee replacement at 60 and it fails at 75, then I have to put metals from here to here. Whereas if I've done this, it feels like a normal knee. This is a pandit, by the way. He sits down regularly to do his puja in the temple, and he can very well do that with a knee like this. And when I revise it, I will change it to a total knee. Similarly, a person who has a bilateral problem, I mean, a younger person who's a manual laborer, I could do something like this. If we do it properly, an age-old technique, which I'm sure Umesh and Jacob sir will certify that works in the right hands. Or there are situations where we do both at one stage together. The revision of this is going to be big metal. The revision of this is going to be this in a younger patient. So thinking about the long term. And at the end, if you actually Google what the best surgery is, it tells you it is green tea. So prevention is better than cure. Any comments? Thank you very much. Can I call upon Dr. Rai, sir? Doctor, please, sir, if you can give mementos to our chairpersons.
Could I just ask a question?
Of course, sir.
Would you find a partial knee replacement more accurately done with a robot by salvaging the ligaments and therefore saving the ligament from damage? I haven't done one, I'm just asking you.
So there are just one or two systems which do partial with a robot. It definitely is more accurate. There is no doubt about it. Having said that, the robot does not give an accurate indication of the clinical side of whether you should have done the partial. It is undertaken. It is undertaken more accurately. The key, however, in a partial is to leave residual varus. We don't want to correct the deformity entirely, because if you go by long-term data, the way a partial knee replacement fails is the arthritis getting transferred from this compartment to that compartment. So if the robot is too accurate, or if it goes a degree on the other side, then the robot will also fail. There is no long-term evidence to say definitely a robot is better, but I do partial knee replacements just on the basis of tissue assessment, again, like we had talked about, and I would like to leave a residual varus. Yes, my measurement would have been more accurate with the robot, but my tissue tension tells me I have not released any ligament, and the system I use is very knee, the robot, the system which comes with the use of the robot is not balancing based, unfortunately. The different systems are different. So the Oxford system, which has been long-term documented, is actually very balance based, and it doesn't allow you to overcorrect very easily. So I think, yes, the alignment would be accurate, but I don't know the long-term clinical answer. There is no evidence as of now.
Kudos to you, Dr. Yogesh. One more question, because if the knee pain starts at a family physician's level, usually we try to give glucosamine.
Yeah.
Does it make the things worse, or it should not be given at all?
I prescribe a lot of glucosamine. I give them a lot of Ayurvedic oils. I give them a lot of collagen supplements. Now, we don't know whether it works for the knee or whether it works for the brain. But as long as it makes some of them happy, the main essence that works there is not my medication. It is that man who's looking at his mobile there.
I see.
Yeah. Yeah. So what we do is motivated them to do exercises. And I tell them that this is not going to work. You take it for a month or two because it might help you reduce the pain. But definitely go and do those exercises. If you don't do them, nothing's going to work.
I do encourage, because personally I do a lot of pranayama and yoga. You can
Definitely.
overcome.
Definitely.
Because in fact, sarcopenia is happening. I'm 76 now. So I do because muscular exercises definitely strengthen the joints also.
Definitely.
Yeah.
And you'd be very happy to know that that has been accepted in the American Academy recommendations as a level 1 evidence.
Yeah. Thank you.
Yeah. Thank you very much. Dr. Rai, sir, if you can please give. We have one last session. I'm really thankful to people who've sat throughout the day, and I'm so pleased that we have a very senior and eminent physician, Dr. Hansraj Alva, also here with us. So we'll start the last session of the day. So the last session is essentially, we could say, the final eruption of the volcano. So the idea was that we should have liaison between doctors for the patient. So I'd like to invite Dr. Hansraj Alva to take the chair, along with Dr. Ranjan, sir. Yeah. Thank you. Dr. Ranjan, thank you very much for coming once again after lighting the lamp. And to take the session, I've got my esteemed colleague and administrative functional head of Attava, Dr. Deepak Madi, and my energetic orthopedic colleague, Dr. Rajendra. Dr. Rajendra is, he's an orthopedic surgeon, associate professor with us, but is specializing more on upper limb. And we'll start the talk, followed by a quiz and interaction by Dr. Deepak Madi. So I hand it over to them.
Yeah, good evening. So at the outset, I would like to thank Dr. Yogesh Kamath for giving me this opportunity. So it was a last minute arrangement, so I have whatever few points I have prepared. So mainly, so whenever we plan any surgery or any patient care, so it has to be totally coordinated team effort. So one person cannot manage everything. So we have to have not just with the fellow physicians, but with the other team as well. The nursing, maybe the OT staff, maybe the physiotherapist. So a coordinated effort is going to be the give a good end result to the patient. So with the coordinated care, so even constant monitoring of the care is also important. So it's all the whole hospital staff, right from the security of the hospital to till the main administrator of the hospital is the team. So we are all on the same team. So and patient care is the teamwork which we are mainly concerned. So it has to be constantly coordinated and integrated. So coordination, it is more and often recognized as a part of a main determining factor for the patient care, so which is very effective if done properly. So many chronic complex conditions are there which require constant care involving many various healthcare professionals. So maintaining quality care also requires a lot of coordination and to constantly evolve development of study and evaluation strategies. So when we are giving the patient care. Yeah, so if there is lack of coordination, so even with best of the efforts by the team member, the end result may not be suitable and may jeopardize the effectiveness and safety and results when the patient is concerned. So if it is the care and coordination is good, so the quality of care improves, patient safety improves, and we can come up with the good patient outcomes. So evidence, so is this being studied? So there are many studies involved in literature, which is very much studied. This aspect of has been studied. A lot of protocols have been there. So varying factors, some of them describe 11 factors, some of them describe 14 factors. So more and more factors have been described. So to overall care of the patient. So where we use the integrated approach in arthroplasty, so it starts right from the moment the surgeon sees the patient or the physician, whoever the patient first interacts, so up to the end of 12 months. That is what the period which has been described in case of arthroplasty. So more educated the patient, right from the first person who talks about the disease to the patient, the more educated the patient is, more educated the caregiver of the patient is, relatives are more educated, then more happy will be the patients, and more happy will be the more improved will be the outcomes, and he may educate more of patients to undergo the procedure, and also in the end reduces the length of stay, reduces the amount of complications for the patient. Okay, so we divide this care integrated approach into preoperative surgical visit, evaluation, surgical planning, discharge, and rehabilitation. So pre-op visit initially takes few 3 to 4 weeks, where the patient presents to the hospital, the patient history examination is done, the caregiver also discusses treatment options, imaging is done,
Yeah, then all the patient discuss the treatment options with the patient, alternate options, the financial, and allow the patient to come to a proper discussion. So in this stage also we identify all the risk factors. What could be the delay surgery? That is when the team of different specialties come in. So where they evaluate the patient. So they evaluate the comorbidities of the patient. Yes, this is followed by the preoperative planning and all the involves complete laboratory test and screening, plan for surgical and preparation of the clinical team. You update the scheduling in the OT, staffing, resources, documentation, and the insurance approvals. And always there should be a coordinator from the hospital side to communicate with the patient and family. So communication is also important part of the care. Yeah, the preparation of surgery, when the patient is planned for surgery, gets admitted, the procedure, site verification, antibiotic prophylaxis. So all that with the more and more amount of cases, even the surgical staff is trained about the procedures. You constantly do the surgical timeouts and post anesthesia care in the form of intensive care units. Yeah, so the inpatient stay usually takes this process take 3 to 4 days. So where your patients, I think all these aspects has been discussed with different from the morning sessions. So the idea is to prepare the patient and get him back to the society as early as possible. Yeah, rehabilitation, regular follow-up of the patient is important. You advise post-discharge care. You always provide a context for where patient can contact in cases of any emergencies or urgencies. Conduct standardized physical assessments. Continue X-ray monitoring. Yeah, so these are different aspects of the patient care coordination where is involved. So in the integrated approach, to summarize, it starts with the primary physician where the patient first comes into contact, includes the coordinator from the hospital, usually the operating surgeon or a nursing coordinator or a patient coordinator. So all the hospital staff should be aware of standardized protocols. It is better to make the interdisciplinary physicians to be aware of these protocols. Financial arrangements, actively engage and followed by adequate surgical planning and adequate rehabilitations. So identify all the risk identifications. Two few key, important things is encourage the patient to participate in a joint registry. So more often it is followed in the Western countries. It is not there in the Indian subcontinent. And one more important thing is all of you would have seen a small paper where the results is being assessed. So constantly assess. So where you can see the patient walks on the first day, walks on the this average length of stay. So it's there in all the tables. That is very important. So monitor your care constantly with the results. So I think I will hand it over to Dr. Deepak sir for the case presentation.
Thank you. Sit there. Dr. Rajendra, you sit there. That will be better. I'll direct questions towards you. Good evening, everyone. I thought I'll say this session is standing between you and dinner. I think dinner is very early, so I'll put it another way. We are standing between you and India's batting in T20 match versus Sri Lanka. Okay, 15 minutes, India is supposed to bat. So I'll take you, this is a simple case presentation. What I'll do is I have 3 panelists. I think Ranjan sir will get the least amount of questions. Rajendra knows my slides. So we sat together and because the word here is liaison between all specialties. So I had an orthopedician, so I sat with him and prepared the slides. So we had some questions. So he knows all the answers. Hansraj Alvasar is a physician like me. So I think we will think alike when we deal with this patient. So let us see what we can do. Finally, all of us are here to see that patient is happy when he goes out of a hospital. But usually it's not so. This is our group CEO, Mr. Dilip Jose always says, health is a grudge purchase. If I buy a Mercedes car, I'm very happy. But here, if someone tells I'm prosthesis of 2 lakhs, I might be happy initially, but when I pay the bill, we'll be sad. It's always a grudge purchase. So it's very difficult from a doctor's or an administrator's point of view to make a patient happy when he leaves the hospital. Okay. So let me present a simple case. This is usually what we see. As physicians, we manage lot of diabetes, hypertension. Usually when this elderly patient, they have lot of comorbidities. 66-year-old lady, pain in the right knee since 1 year, diabetes on treatment, stable IHT on single antiplatelets. Examination, BP stable, BMA slightly high, 28. Examination, right knee tenderness, swelling present, restriction of movements. This is reduced knee space, osteophytes. So this is what we usually, okay, this looks like osteoarthritis of the knee. As physicians, we want to, before we start analgesic simple test, we need a renal function. Sugars are under control. Okay. Now, first question to Dr. Rajendra. Any other tests you want to do, or is it a simple case of osteoarthritis? And I'm ready to start my treatment. I have just put what a physician will do. Let us see what orthopedician will.
I think someone from the audience can
Or
answer.
I can just pass it to sir.
At the age of 66, I don't think I would look for any joint-related tests unless the patient has a very high ESR, CRP being positive.
So you'll ask for a yes or no, sir?
Yeah,
Yes,
please
sir.
ask for a yes.
Plus or minus CRP.
Best
Yeah. And single joint involved. We'll not think of too many differential
no.
diagnoses. Rajendra? You want an RF factor, okay. So you can see, I don't know, if as rheumatologist, I just pass it on the question to him also. So I think you want RF factor, monoarticular rheumatoid arthritis. Correct?
Late onset rheumatoid
Late on.
arthritis.
Okay. Okay, so you can see sometimes a different perspective, but ultimately we all are there for the see that patient does well. Okay, so plus or minus only extra test if at all you want to ask is a RF factor. Okay. This is what we typically do, analgesics. I think glucosamine, that is a question asked in the previous panel. Do they help? I'll come back to it. This is very important, lifestyle modification and physiotherapy. These are our first line of probably people might say LSM first, or these are things which typically we physicians do. Okay, and what happens is there with me for 6 months, but no significant improvement. And usually this is what we say, patients are obese, they try walking or exercises, pain worsens. So it's a cycle. So it's very difficult sometimes. We may feel that they are not following your advice, but sometimes it's not that easy. Anyone in the panel? I think that question was asked. Yogesh is there? Yogesh, I can't see Yogesh to answer my question. Okay, what about oral glucosamine? Rajendra, I think we also use a lot of glycosaminoglycans.
Yeah, oral glucosamines are first line of treatment. We also add in early case of arthritis. But more the arthritis progresses, the patient has not improved after 6 months. Even the oral medications, the grade 1, grade 2, of course, oral glucosamines. Now newer drugs are there, anti-natured collagens, lot of curcumin, lot of things are in the market, so which are quite expensive. So oral drugs, lot of them are there. A lot of them do act, maybe as sir said, psychologically, or it may act on the brain. But adequate, they are not, we also prescribe, many times we tell the patients it may act or it may not act. So we are going to just give a trial along with physiotherapy. Some of them do really well with the glucosamides.
Okay. Are you happy with the dosage? Say 500 BD, I have not taken any trade names, 500 BD, is it okay? Or
1 gram, 1.5 gram.
Yeah, can I take that
Yeah,
over?
yeah.
So, sorry, I was a bit
Yeah, I was
dehydrated.
searching for you.
Sorry. So, there is a lot of data on these, but the data is essentially claim subjective improvement. There is no objective improvement as is claimed. And the dose they see which is effective is 1500, exactly like Rajendra said. As regards collagens, there are a variety of collagen preparations available on the market. The idea is, you clever doctors have to tell me this. So if I eat chicken, my stomach is going to digest it. That chicken in the same form of collagen is not going to get into my blood and is not going to get into the joint. But the clever pharmacy guys tell me that this undenatured collagen will find its way through my intestine into my joint.
Yes.
I don't know how. But having said that, they have data if it is 40 milligrams of undenatured collagen is what they call it. So I try to be clever, and that's the only knowledge of pharmacology. So as I probably was destined to be a surgeon, so I actually don't prescribe drugs. I tell them straight away, I'm not a physician. If you need drugs prescribed, please go to my fellow physicians. These things I can give for you, but I don't know whether it will work. Exercises work, and I give it to them. There are things in combination with collagens, so we prescribe those. So there is data on collagens being or having a slight nociceptive effect. I don't know how that works. Probably whether it actually, makes the patients, whether it goes into the brain. If it goes into the joint, it should also go into the brain, I suppose. And it helps make them think more lubricated, better, or whatever. But there is data on collagens, there's data on curcumin. The dose of curcumin is very high. So you would think that if curcumin makes things better, Indians should never get arthritis because we have haldi in every food that we make. But they say that the dose of curcumin, active curcumin in our curries is not that much as in the medications. The problem is the pharmaceuticals put all this in combination and give it to you. So which of it works, which of it doesn't work, we don't know. We would have rather had them individually and have done trials. And I've asked a couple of pharmaceuticals for trials. Maybe Hansraj sir can help me because you've been able to set up good trials in Mangalore. Somehow they don't want to give us the money for trials. Maybe they think Manipal is going to take out the money.
I think so. What you probably suggest is try to increase the dosage and see to 1.5 gram. Okay.
Yeah. But again, with glucosamine, they are known to have problems with blood thinning effect. So it's say that it is synergistic with people on blood thinners you should not give. So I don't know.
So I think she has ischemic arthritis. So I have to think what else can offer. Probably turmeric related products. That was one of the doubts I thought at last, because lot of lot of promotion for that. But I think if you see the data for oral glucosaminoglycans, not that great, but we do use it, and probably it's, as I think last panel also, probably plus or minus a placebo effect. Okay, any comments on analgesics? What do you want to put? Sir, Hansraj sir, or anyone? Or what probably in the first line?
I usually put them on paracetamol.
Okay, paracetamol.
1 gram twice a day.
1 gram twice a day. The younger generation, okay.
Presenting symptom, pain is very severe. We use 3 to 5 days of maybe tramadol paracetamol combination.
Okay, tramadol.
Then switch over to the etropoxy or plain paracetamol.
How long do you probably tramadol paracetamol safe? What about etropoxy? How long can
3 to 5 days followed by maintenance, maybe 2 weeks, not more than that.
Okay, your take on that?
No analgesics. I don't prescribe.
Nothing more than 2 to 3 weeks.
Only I prescribe for 3 days, if at all. And that also, I said I'll give it to you only if you have surgery.
So I think
it's not going to get any worse.
But how do you relieve him of his pain? Good evening, sir. I recognize the presence of our pain, Dr. Krishna.
Yeah.
What do you give them for pain? Physiotherapy?
Yes. I tell them to have some modality, send them to the physio department for pain, for the relief. If they are in a true flare-up, we give them, that is a synovial inflammation, where they are acutely, inflamed. Then we would probably think if it is associated with some other joint, then do a referral to a rheumatologist, as the case may be, or a physician. before I prescribe anything.
You are telling liaison between specialities.
Yes.
You are up for it. Same thing we also follow.
Yeah.
Then one more point. I don't know whether we physicians see it. We feel the joint is not bad, that bad, but the pain is disproportionate. I don't know whether you guys see that. Joint is not that bad, but pain when we see it's very bad.
That's what we were discussing in the previous talk. Some of them needs to grade 1, grade 2 arthritis, but still they have so much symptoms they opt for joint replacement. So some of them, maybe the pain with the patient can bear the
Pain tolerability.
tolerance towards pain.
Each individual, one size will not fit all. Pain threshold is high in some individuals. Okay. Well enough. 6 months we covered about glucosamine. Okay. So patient is there with me for 6 months now. I think it's time to lesson. I see he has not got much benefit from what we give, and Yogi said no analgesics at all. I think it's difficult for us to digest. That will be our first line. Okay. Typically, in my institute, I have a lot of options. I have an orthopedician. That's the easiest. Plus, my rheumatology colleagues are also. I have 2 rheumatologists, so it's easy for us. So next, usually I will refer probably first to ortho. Here, I think there are. I think what data I was reading more benefit for injectable agents than with oral agents, especially injectable hyaluronic acid preparations. You want to take it? Now it's completely your domain.
Yeah, so there are different intractable injections.
I'll just put, okay, which first, steroids you want or any other?
Steroids, I don't suggest intractable steroids. So we usually go for either hyaluronic acid injections or PRPs, is the new thing that is there.
Okay. PRPs? Plasma.
Platelet plasma. So that comes in a commercial preparation where they take the patient's blood and filtrate in different levels and give it. So usually it is the commercial available is quite effective. It is very less painful. Nowadays we are.
What's the cost involved just to that?
Hyaluronic acid, intravenous steroids are very cheap, so they, they're totally abused drug. So hyaluronic acid comes in the range of 12 to 15,000. So we have available in the range. All these are OPD procedures that can be done in the outpatient. And nowadays there is the new thing is the stem cells injection.
Is it done here? Is it done anywhere here?
Yeah, now it is commercially available. The trials, few sites were there in Mangaluru also. They came up with some positive results or equivocal results compared to the hyaluronic acid. But a lot of studies are there, hyaluronic acid and intrathecal steroids have similar results. So I think the results towards the patient, whatever the vast pain scoring, what they do. These are the options available, but hyaluronic acid has quite clinical results.
On that, we will prefer easier to use hyaluronic acid. Yogesh, you were asking a lot of questions. Now we will ask you. We were discussing about intra-articular injections. Any steroids, hyaluronic acid, stem cells?
I have a protocol for them. So if they are in a flare-up, in an acute flare-up, I would give only steroid. If it is a painful chronic joint, then I give them a mixture. Hyaluronic acid works, but with collagen, hyaluronic acid has become second line. So I give hyaluronic acid sometimes in combination with steroid as well. That works. If it is a chronic joint and they're not getting better for a long time, I have published evidence with regard to PRP in the knee. There is level 2 evidence for that with right physiotherapy. The problem with PRP is it will take a minimum of 2 months to start acting. So with PRP, when we started with PRP, I have done some work and I've had seniors, I will quote again Anantaram Shetty on this. We started about 2012. Initially, with the preparations of PRP, there were cases of increased inflammation in the joint because any blood product after centrifugation will have leukocytes, will have interleukin-1, which are inflammatory mediators. So you inject that into a joint. I have personally got them. You get septic arthritis type reactions. So I would be very wary of injecting it unless I know the product in and out. The only one PRP I use is the one where you can kind of regulate. There are PRP preparations where you can regulate the leukocyte concentration. So any locally made PRP which has not tested the leukocyte concentration, I wouldn't dare to give in a joint. So there is leukocyte rich. Leukocyte rich PRP is for tendons. Leukocyte intermediate PRP is for hair growth and things like that. Leukocyte poor PRP is for joint. And that we again give in combination with HA because HA neutralizes it. Never PRP alone. Stem cells, I don't believe. I refuse to believe that there can be evidence. Though there are claiming these trials and they are very expensive. The problem is stem cells can just go into a joint and can become, we use stem cells, but they've got to be in a targeted area. So if I can restrict the stem cell with fibrin glue to one area of the knee, we know they can form cartilage. But if you just inject them into the knee and the stem cell sits on an inflamed synovium and tomorrow I get a synovioma, I don't want to be responsible for it. We don't know the long-term effects of stem cells. That's my opinion. But there is a lot of things.
So this PRP, how many injections and how much ml and what is the cost in?
So the PRP I give costs about 15,000 per the injection. There are PRPs available at 1,000, 2,000 also because it is locally made. There's nothing standard on them. There is data which varies between 3 injections of PRP or 1 injection of PRP. I have only given 1 because 1 to have an effect will take 2 months with HA. Repeated injections can carry with them the risk of intervention into a joint, therefore septic arthritis just by repeatedly intervening on a joint. So I've given
1,000 probably 1 PR. Yeah. Okay. That's why we need physicians to liaise. You say stem cells, no, he says yes. Yeah. We need to control
yes, we have
entire team. Okay, and I always told you I don't have any rheumatologists. So usually sometimes if chronic ortho also cannot manage, we have a rheumatology department also. Physiotherapy, I think anyone wants to take the role of physiotherapy, simple 2-3 points, yeah, is there behind. Obese patient, her complaint is osteoarthritis. She cannot obese, she cannot, more she walks pain. So what simple things you can suggest? 2 or 3 simple things, that's all.
Okay, sir. So first thing is weight reduction that works like magic for anyone who is on the higher BMI. Of course, when it is difficult.
Yeah, because the usual complaint is we want to walk fast, we want to say do some cycling, but pain, joint pain is bad. So that vicious cycle, how to break it off?
So the best way to break the cycle is to desensitize the joint. So that we have modalities for that. We have different type of electrical modalities. We have different type of home measures like ice packs or hot water fermentation. That also helps.
Okay, what to give now, cold or hot?
Yes.
Usually they ask.
Yeah. So when it is a acutely inflamed joint, ice always helps to reduce the inflammation. When it is a chronic inflammation with muscle spasm, that is the time where we usually advise hot water therapy, or we instead of hot water we tell them to use moist gel. Take a wet towel, wrap it around the hot bag and put it so it doesn't burn the skin, doesn't irritate the skin.
Acute and chronic, you mean that the joint is, what is acute or chronic? Let us know.
It is the stage where arthritis has been going on for few years. It is settling down as the inflammation settles down when they take rest or inflammatory anti-inflammatory medications or analgesics, and it comes back again when they start doing strenuous activity.
Okay.
So that is something to break down the cycle. And I always suggest my patients start with milder form of exercises, because when you start exercising, it is well documented, you will have muscle soreness. You can have acute soreness, you can have delayed muscle soreness. So do not overdo anything because your pain is less. It has to be a build-up effect. Start gradually. As the inflammation or the pain subside, then you can take up, sir. Then we have various type of exercises to take it from there.
And we have one more department in our institute related to pain management. How frequently will you refer for pain management? Yeah, both, any one of you can take. Then I'll come to Rajan.
So for
Before
me,
surgery, you told no analgesics, physiotherapy. Now pain is one of the important symptoms of the probably cry of the dying joint.
Absolutely.
We have to address it, otherwise patient will not stick to anyone.
no, definitely. There have been my shoulders to cry on are physicians, rheumatologists, and pain specialists. So what I would do is, if there is a bad enough confirmation that the joint is mechanically unsound, confirmed on x-rays we don't need, because if it is mechanically unstable, it's a no-brainer. If pain is an element with inflammation and I don't see a problem on the x-ray, that calls for some kind of medical intervention. So if after a good workup nothing has been found and the rheumatologist does, the patient is up for grabs, you put it up in the market basically. If the rheumatologist wants to take it, great. But if there is a mechanical component, my brain work, because I would treat the mechanical component. The moment I can't correlate clinically with an investigation, I think that is the solace.
Yeah. And then anything specific you want to say, anything pain technique? Because you are the one who helped me with the slides.
Recently, some of the pain specialists have come up with genicular nerve blocks. And some of them even go to the extent of ablation of the genicular nerves. So these are mainly reserved for patients who are totally not preferring surgery or unfit for surgery. So there are few anatomical landmarks. Okay, so where the probes are inserted and the genicular nerves are blocked, means the damage, so that the patients don't get the.
It can be done on an OPD basis and effect will last for like.
It's basically either ultrasound guided or it can be done anatomical, where you clinically mark the points and you can do it.
How long will it last?
Supposedly the nerves which are damaged regenerate, but 9 to 12 months, maybe 6 months.
6 months.
Pain free.
People prefer better than surgery. Okay. Small OPD procedures. Okay. Now surgical options, I'll not go into much details. Suppose these patients want surgery. Sir, what are the surgical risks? 60 plus lady, obese, ischemic heart disease. And then, sir, what are there any problems do you anticipate, or it's a simple? He's on antiplatelets, heart is quite okay. Ejection fraction is good.
Yeah, if the patient is scheduled for a surgery, this particular patient has got ischemic acid on antiplatelet. So I'd like to see the coagulation status of the patient.
Obviously,
so what is obviously they put that stuff out. And also the status of the heart function. What level it is, or how good the cardiac rhythm. So that's a surgical risk, because
she's obese also. Anything you anticipate?
Cancer is also an
obese patient. So this probably
also. So that's also added to the surgery. So this should be taken into account before taking up, and it should be explained very well to the patient and adequately managed. That's the thing.
Sir, anything?
Take care of DVT this time.
Yeah, I think that's one of the things. These patients post surgery. How you make them walk in? I saw one topic. How fast you make them? You mobilize them
soon after the spinal wears off. So we are talking about 6 to 8 hours.
Day zero. Okay. Yeah. Surgery is over. And DVT prophylaxis for everyone.
For everybody, mechanical plus chemical.
Chemical. Okay. Chemical, say Clexane.
Yes. So low molecular weight usually, which starts for 12 hours after surgery, between 12 and 24 hours. But we make them walk as the main thing. But nevertheless, DVT is something we would worry about.
That is one common problem. I think a lot of post surgeries joint.
Oral anticoagulants, would you continue?
Yes, sir. Definitely. So we follow the NICE protocol. There are different ones, but for total knee replacements, it's 14 days, and for total hip replacements, it's 5 weeks, 35 days. So usually I give them injectables, particularly in obese ones. I would give injectables for a little longer because with the oral ones, in my personal experience, I've seen a lot of bruising. So whatever the clotting pathway, that 10A inhibitor, does seem to bleed more if I give it in the first 5 days. Whereas with more fitter ones for cost benefit, I'm going against NICE guidelines because in the court I'm protected whatever I give. So I just give them and send them with aspirin because that's the cheapest thing we can do. And I'm protected.
So how many days of anticoagulation injectable?
Injectable for usually 2 or 3 days till they are walking comfortably, and then follow it up with aspirin for 2 weeks in a joint, in a TR, 5 weeks in a THR. If it is anybody high risk with a family history or obese or 2 joints done at one stage, or somebody who's been immobile for a long time like a complex or a revision joint, then we give oral 10A inhibitors.
Say, like what you prefer? Apixaban?
No preference.
No preference.
Whatever.
I was surprised. You told you'll send them on aspirin. Okay. It's little difficult.
Yeah.
What about, forget Yogesh, what you will, because will you send them on aspirin?
Some of the patients,
Majority, majority. Will you send them on aspirin?
male patient mobilizing well.
Okay, I'll rephrase. Majority of the patients, will you send them on aspirin?
No.
No. Whereas Yogesh, so he prefers aspirin, whereas probably if you ask me, we'll, I think nowadays NOAC are very good. With Warfarin, we have a lot of issues. Probably cost is not an issue. Apixaban, we have previously. It was very costly. Now we have the cheaper version. So what will you do? Send them on for, say, knee or hip replacement?
So we follow the same criteria. Oral anticoagulants for 2 weeks for the total knee replacement. For the hip, it is 6 weeks.
Because that's very important. You want them to come back with put a nice process. You want them to come back with a DVT. That's a challenge which we face.
Yeah, one thing I want to ask, patient is already on aspirin, so what are the modifications for the DVT prophylaxis?
So he will continue that.
I put them back on aspirin.
He puts them back on aspirin. Will not act to
aspirin and clopidogrel. So if there's anything need to be added or just be continued with the
So no, that's what, if he feels comfortable with aspirin alone, so clopidogrel will come into picture.
Yeah,
he will with the NOAC. So I don't think for 4 weeks you can give that, it will work for heart also.
So some of the patients who are already in clopidogrel, so for total knee.
Thank you everybody. We are pleased to have Dr. Unni Krishnan here, our dean, and Mr. Sagir Siddiqui, our CEO and the regional CEO. I would appreciate a few words from your side. Dr. Madhusudhan Upadhyay.
Thank you, Dr. Yogesh, Mr. Sagir Siddiqui, the regional CEO of KMC Hospital, all the senior faculty members who are present here, the administrative staff from the KMC Hospital, students who are present here. A very good evening to all of you, and I am bringing the greetings from Kasturi Medical College, Mangaluru. It's a very unique, as Dr. Yogesh is unique, and his program is also very unique. That is Comprehensive Joint Care, the super team. And I was going through the program, and he has covered the entire aspect of the joint care, because he has involved a microbiologist also, he has involved medicine also. I think in totality 360-degree involvement is there. That is a team effort. Okay, I always tell Dr. Yogesh is an idea man, an innovator. I'm very happy today evening because his student today he won the best innovation in Father Mullah's conference, Silver Jubilee conference, and that is Mr. Shubham. He is in the 3rd year and he has won the best innovator award and ably guided by Dr. Yogesh. And already the Shubham has already patented one thing, already second is in the process of patenting, and that is the mentoring part Dr. Yogesh does. After Dr. Yogesh joined our hospital and the medical college, the innovative spirit among students have improved and is always there for innovation. Thank you, Dr. Yogesh, for inviting me for this function. Sorry, he had given me a talk, then I thought I had another meeting, then I thought what a community medicine person will talk about joint care. So that was the reason, but another meeting was there. But Yogesh is working a lot on AI, on machine learning, on algorithms. He is working very closely with NIT Surat and nowadays with MIT also. We have started an innovation hub at the college. All those who are not from, I just want to announce that we are celebrating 70 years of establishment of Kasturba Medical College this year as a platinum jubilee celebration. And the celebration will continue for one long year. In this year, lot of CMEs are planned, lot of workshops are planned, and lot of conferences are also planned, and a lot of fun-filled evenings are also planned. Thank you very much for inviting me. Thank you.
Thanks, Dr. Yogesh. Good evening, everyone. As Dr. Unni mentioned, Dr. Yogesh has taken the his field of joint replacement to next level. I still remember the day when he actually joined Mangalore from UK. That was, I think, some 7-8 years back, and that time actually was not very sure how we'll go forward in terms of developing the department. He was still in two minds whether Mangalore, Bombay, or multiple locations to where to settle down. Then actually he zeroed in on Mangalore and he joined us. And right from the day one, he was very clear that he wanted to set up a department which is world class. Because the way he started about the activities for the department was all benchmarking everything to the Western standards, like outcome based practice, as Dr. Undi mentioned, more of innovation, R&D, and the system development. So I have seen how he has joined, and after that how he has actually developed the department. Initially he focused on how the core joint replacement works, and slowly he started involving the physio department, Dr. Ashish, Dr. Joshua, Biswa, and multiple stakeholders for a replacement kind of a surgery. And I have seen every work that he does, he has got a lot of systems in it. He doesn't look at individually working and leaving the department for one man to handle. So he has brought a lot of innovation and system thinking to the entire department. Hence, we have a department which I can say proudly that we can be called as a center of excellence as far as joint replacement is concerned. And thanks only to Dr. Yogesh and his team. And also, along with that, it is not just the medical part or a physio part or the allied health part of it. It is the administration part of it in terms of patient counseling, in terms of financial counseling, or whether in terms of information from admission to discharge. He has developed a system where the patient is very, very comfortable in understanding the entire process. So kudos to Dr. Yogesh and team for developing such a wonderful department. And he said that we will be the #1 department in terms of joint replacement. He has proven that both in terms of quality and quantity, I guess. So congratulations, Dr. Yogesh and the entire team. And thank you all for having a long day and being through the entire program. Thanks a lot, and congratulations to the entire team for organizing such a wonderful program. Thank you.
Thank you, sir. So just to the back end, we'll have a group photograph while Rakesh, our marketing manager, will tell us a little bit, would like to tell you a little bit about our department and the super team. He will introduce, followed by Dhruv giving the word of thanks. The bar is obviously open. You can, I don't want to this to delay.
You have set the bar very high.
I think we'll just quickly run through the video, which will actually cater to like what we do, and here at KMC as a team, what we do, I just want to depict one of the video.
Can we also have our nurses and Madhu sir, please. Madhu sir. Priya, Jayashree, Janet. Yeah, please come. Lakshmi sister. Roshan किधर? Divya, come. Dhruv, Rakesh,
Meanwhile, I think the membership and bar is open. I think we can please feel yourselves comfortable. Dinner will be ready in next. So in the meanwhile, when we have a group photo, I think you can please feel comfortable. Beverages are open and dinner also will be ready in 10-15 minutes. I request my marketing team also to join.
Yo, you guys are very important. Aajao, aajao. Sudhir, please come.
Sagir will not go that other side.
आगे पर हम लोगों की Thank you.
Send me the photo.
Over to Rakesh.
We will be for you. He has set the pathway. He has set the pathway. I haven't done this.
Today, Manipal Hospitals as a group, we are nearing to be the number one private healthcare provider in the country. So, we are the largest hospital chain with 37 hospitals with 10,500 plus capacity bed, and we manage annual patient traffic of more than 70 lakh. Our strength is what we as projected by Dr. Yogesh and team, it is 5,600 plus doctors, around 20,000 employees, 25,000 plus employees. So the footprints is across all parts of India. So this is our hospital after the facelift. I think it has a legacy of more than 27 years. So started in 1992. Now this is the new facade and the facelift. So running with the time, we are now being more modern, just to be catering to customers. So these are the, now we have more dedicated OPD counters in each floor, so that we are able to service the customers in a better manner with a lesser turnaround time. Extended billing and insurance counters at every 3 floors. Phlebotomy services in all the OPD counters. We have a daycare facility as well in OPD also. So this is what how we collaboration with technology we do. Like whenever there is a critical patient, especially the OP with the lab reports, it is directly linked to the doctor system. That is what the software we run, and there is a prioritization. So that is how we do the triaging for OPD. So doctors get their real-time appointment list. So how many patients are there, and they can plan their day very well, including their routine rounds. So these are the feedback. This is what the patients have to say about us. So in addition to what we do inside the hospital, these are our team where we are spread across. We have 8 lab collection centers in Vijay, Katipalla, Vendurvel, Mannagudda, Mulki, Surathkal, Vitla. We have 4 basic labs in Hosmar, Modubidre, Karwar in Uttara Kannada, Honavar and Kashmir. And there are 2 emergency centers, one in Kerala, in Chervattur, and one in Puttur in Pragati Hospital. So with this, we cater to more than 2 lakh outpatients, more than 21,000 inpatients, and the team of doctors comprehensively perform more than 25,000 surgeries in a year. So this is what Dr. Yogesh Kamath, with the specialist OPD in the comprehensive approach for the joints, so inaugurated by the esteemed dignitaries. So this is what we had the super team, which had a group photo. Thank you. I think, ladies and gentlemen, we should enjoy the evening. I request you to propose the word of thanks.
So, good evening everyone. It's been a long day. So, first of all, I will start the express my gratitude to all our senior leadership team for giving us the opportunity and making this event a huge success. And my gratitude to all the senior doctors and speakers, moderators, and chairperson for attending the event and finishing on time. Secondly, I would like to thank our marketing team for coordinating for the event, and sincere thanks to Prakriti for making a very wonderful video, Swati for a wonderful branding, Mr. Rakesh for giving all the valuable inputs, and Dr. Yogesh Kamath, Mr. Vishwa, and Dr. Rohan for keeping a constant support. And thanks to Mr. Sudhindra, Mr. Karthik, Mr. Darshan, Mr. Kiran, Mr. Manmohan, Mr. Thomas, and Mr. Kiran, Mr. Rutesh, and also Mr. Chandan and Mr. Lokesh for helping us with the AV and all the back support. And special thanks to Roland and Divya for helping us with the registrations, and Mr. Aslam and team for the videography and photography. Thanks to the HA Grand management for a wonderful lunch and a very wonderful hospitality. With this, I would end the vote of thanks. Sorry if I have missed anyone. Sir, yes, sir, my sincere gratitude to Dr. Uni Krishnan, our Dean, KMC Mangaluru, Dr. Deepak Madi, Mr. Sagir Siddiqui for with constant support and helping us with this wonderful event. Thank you very much, sir. The bar is open. Please help yourself. We have a back part-time DJ also, Mr. Roland. So if you want any music, he's there. Please enjoy the evening. Thank you very much. Take care and 3 cheers to the super team.